and then I will hand over the session to Dr. Rajeev Pachauri.
5, 4, 3, 2, 1. You are live, sir.
Yeah, good afternoon to all delegates and eminent faculty members. I am Naveen Cole, representing PharmaCare, a division of Sun Pharma, the makers of Cipodom XP, Montag FX, Recipar D, and Betavert as well. Welcome all the delegates who have joined us and are connected in today's webinar. I, Naveen Cole, on behalf of Sun Pharma, welcome our faculty members to start with Dr. Parmita Saha and Dr. Udvam Metal, who are going to our moderators for today's webinar. Also, I take this opportunity to welcome our faculty members like Dr. Kranti Bhavna from Patna, Dr. S.K. Apparao from Vizag, Dr. Vaishno Reddy, Dr. Gayatri, Dr. Manoj, and of course the person who have made the series of webinar very successful and interesting is Dr. Rajeev Pachauri. Thank you so much, Dr. Rajeev Pachauri, for taking the initiative and making this happen. And my heartiest welcome to the person who does not need any introduction, as his name itself is a big introduction. So it is none other than Dr. Satish Jain. Welcome, sir. Welcome, Dr. Satish Jain. And with this, I hand over the session to Dr. Rajeev Pachauri for the proceedings. Over to you, sir. Over to Dr. Rajeev Pachauri.
Good afternoon, all my friends from the country, from abroad, and all the delegates who have attended so far in our this is 22nd webinar which we are doing today. And luckily we got few cases which were not shown in last webinars, and this was especially the CI one, and again we are showing glomus, and so many cases are there. So I think I should not get delayed by this thing. I will request Dr. Satish to start the radiology and discussion on the cochlear implant part, because it is a very special case for all of you, and different approach will be used today. So welcome all the friends and all the faculty, all the friends. Again, enjoy our today's webinar for next 5, 6, 7, 8 hours. I don't know. So let's go to Dr. Satish.
Thank you, boss. Good afternoon, everyone. It's a pleasure to have you all again. And it's a big day for us with some interesting cases and very, very important faculty members with us. Let me take this opportunity to welcome Dr. Apparao. We all know Dr. S.K. Apparao looks very young. This young man of 64 years, it's difficult to understand him. I know him for more than 20 years, the kind of commitment he has to the subject. Thank you, Apparao, for being with us. He is a very, very committed lateral skull-based surgeon and otologist who has been part of several workshops with us, has been a very, very important faculty in various workshops in this field. And thank you, Appa. Can you hear me? Thank you. Your mic is unmute.
Yeah. I'll go. The secret of his youth is hanging on that wall behind him.
And then we have the young, dynamic Dr. Kranti Bhavna. You all know, in such a short span of her career, she has become a prominent ENT surgeon of our country. After, passing from AIMS, he has worked in SGPGI, and now heading the department at prestigious AIMS Institute, Patna. She has to her credit a lot of, international fellowships to Glasgow, Baku, and so many places. She has traveled in American Academy as a faculty and many other places. And Kranti has a huge interest in otology, in cochlear implant surgery particularly, who started the program there at AIMS, and many more, lateral skull-based cases. So thank you, Kranti, for being with us.
Thank you so much. Thank you for this opportunity.
Thank you. I can see Dr. Vishnu Reddy.
No any introduction.
Manoj, you need to mute. Manoj, mute your...
Is Manoj there?
Manoj is also there, but Vishnu, Satish, I'll speak a little bit about Vishnu.
Yes.
Vishnu is a double FRCS from Edinburgh and Ireland, and he came to India only 2003 with a mission. I call him the silent king of the South. He's very, very quiet, very meticulous, absolutely top of the class surgeries, but does not even whisper, forget about scream, which a lot of south of India is famous for. But he does not do that. He's a really very, very silent player. I've seen his work, incredible rhinoplasty and facial plastic. I think that is his sort of mission now going forward. Besides, of course, the general ENT and the routine.
I
But
remember
he
our
and
time in Madrid
Vishwas,
with him.
he and Vishwas and Ullas have together. They have a dream of nurturing the facial plastic movement in India. But above all of this, he has over 1100 stepidotomies. I requested him today, especially for the revision stapes, 1100 recorded, documented stapes surgeries.
Wow.
And the uniqueness is he's the ENT, as the physician to the Vice President of India. So we have a man in Delhi in case we land in trouble or we want some movements. And not just that, he has actually done a stepidotomy on the wife of the Vice President of India. So that speaks of what his caliber as a surgeon is. So thank you for sparing the time and thank you for being with us. We are really looking forward to a lot of academic thing from you. The other person that I could think of when Satish and we were speaking about revision stapes surgery was Manoj. I mean, he's an incredible, the jewel of Kerala or India. Manoj,
Hi, Satish.
again, a very, very silent player, not as silent as Vishnu, because he has well-studied opinions in otology, and he's not shy of saying them. The best thing that connects me and Satish with Manoj is that whatever he says, he does, or whatever he does, he says. There is no dichotomy in that, and that to me is a great quality in this today's day of technology and make-believe, where people manipulate. That level of honesty and integrity is very high. And Manoj, thank you for being what you are.
Thanks, Satish.
We really admire you as a person and as a surgeon. And
Ashish,
looking forward to...
Thank you.
Ashish, more than that, he's very experienced cochlear implant surgeon as well.
Yes, cochlear. So that part will come out now in the surgery.
And I hope we'll be benefited with his comments, with his suggestions, opinion. Manoj and everyone, please feel free to comment. Feel free
I will, Satish. Surely. Pleasure watching you, man.
Feel free to interrupt.
Yeah,
Our goal is to give maximum to the delegates, and with your help, probably we all will be benefited. Thank you. Thank you all.
Satish, like we say, this forum is about science or silence. Nothing, no other bullshit. I mean, talk science, otherwise be silent.
This is pure science with no agenda at all.
Yes.
Thank you.
Before we start,
Gayatri here to introduce.
one more celebrity on the screen, Dr. Gayatri.
Yeah.
Gayatri, we saw her last week when she was with Ashish sculpturing, the pinna.
Your audio is down, Satish. Your audio is a little bit down.
Member of our team, and we'll see her in action next week with a workshop at Ashish's place. The last webinar, we did an external to inner ear, wherein Ashish demonstrated pinna reconstruction. But because of the time constraint, he had to demonstrate in between, through PIP. So next week, he has promised to demonstrate pinna reconstruction right from skin to skin uninterrupted. Am I right, Ashish?
Yes, absolutely. Absolutely.
So we'll all have you again at workshop from Thane, from Ashish. Hi, Gayatri.
Yeah, thank you. Thank you, Dr. Satish, for inviting me.
And next week she's on, it's a very challenging cartilage next time. It's partly ossified, so Gayatri is going to be spending a lot of time in the sculpting.
Yeah.
It's an adult patient with a lot of ossification. We'll talk about that.
Yeah. So before we start, I'll again...
Satish, your audio needs to go up, Satish.
Pardon?
Your audio needs to go up. You're a little faint. Yeah.
Now?
No, still the same.
Audio. What happened? Now?
Yeah, it's fine, sir. Coming proper.
Okay. So before we start, I would like to express our gratitude to Sun Pharma, to Rajeev Pachauri boss, and I can see two youngsters on the screen, Dr. Udbhav and Dr. Paramita, for their continuous support and commitment. Thank you
Okay,
all once again.
Satish, sorry, I'm going to interrupt for just 5 seconds.
Yeah.
We have a surprise celebrity visitor here, but I'm going to talk about him and introduce him after he has created something very novel. I can see him on the screen, but in some time. Ravindra Bansal is here joining us. He's very famous on the WhatsApp for the cartoons he's been creating. We will speak about Ravindra a little bit later. Thanks, Ravindra, for joining us.
So our day...
And Narayan. Hi.
We'll start with the first case with a child having bilateral profound hearing loss. We'll start with the cochlear implantation. We'll share the details. And after that, the next cases would be two cases in succession, would be revision stepidotomies. Then we'll have a paraganglioma, huge paraganglioma, and then a multi-compartment, multi-lobulated, dumbbell-shaped lower cranial schwannoma, right from intracranial to extracranial compartment through the jugular foramen. This is going to be the schedule for the day. So can you share my screen, please? So this first case is a 3-year-old child. This is a very, very interesting scenario in terms of decision making, in terms of understanding. Why we kept this case now? Our first series started on this cochlear implantation with a demonstration of inner ear anatomy with a special emphasis on the anatomy of the cochlea on temporal bone. That was a 7-hour webinar, was the first one. Then in the next of the webinars, we demonstrated a cochlear implantation on a normal anatomy. On this one now, we start the series of cochlear implantation on various malformations. We all know the science of cochlear implantation has grown up like anything in last couple of decades, with more and more applications coming in, more and more indications, I would say, adding upon. This science started with the rehabilitation of the prelingual deaf children to begin with certain criteria of having more than 85 dB hearing loss with this kind of a word score and that all. But with the advancement in the technology, with the advancement in understanding the anatomy of the cochlea, the various implants, electrodes, and so many things, the science has expanded like anything, and now the indications are numerous. By and large, today, if you ask me, anyone, maybe a child, adult, maybe 6-month-old, maybe 90 years old, no restriction. Anybody having hearing loss which cannot be benefited by a hearing aid is the candidate for cochlear implantation. So, anybody who is not benefited for the hearing loss with the hearing aids is simply a candidate for cochlear implantation. And what we believe for the person to have is a basic functioning unit. You can call it as a basic functioning unit to have a fluid-filled cochlea and an intact cochlear nerve to carry on the signals further to the brain. Though with the advancement in the science and better understanding, even in the compromised condition with malformed cochleas, even with cochleas having hardly any fluid, even with the malformed nerves, hypoplastic nerves, still the implant is indicated and working well. And then the further advancement was the development of the ABI, that is the brainstem implant. So today is the discussion on this child having a profound hearing loss with some interesting finding on radiology. We discussed in the last webinar about the workup for the cochlear implant. Besides the physical medical workup, the audiological workup and the radiological workup is very, very important. And this patient radiologically, it fits into the category of a cochlear implant beneficiary. On radiology has certain characteristic important findings which are, I would say, it's not like a previous case which has a normal anatomy. So he has certain malformations on both sides, and I would like to emphasize on what exactly are these malformations, how do they develop, how they can be rehabilitated, what is the the difference in the implantation in these children as compared to the normal children, the difference in choosing the surgical technique, the electrodes, dealing with the complications is altogether different from the normal situation, and which is the point of discussion today. So let me take you through. And before that, we discussed in the last webinar about the radiology, about the CT and MRI, what to be seen in CT scan and MRI for cochlear implant case. And that too we discussed for almost 2 hours. So today I'll highlight the important findings in this particular patient, and then we'll move ahead. So this patient, let me enumerate in a minute about the positive findings what we see on a CT scan. This is a 0.7 mm scan on the DICOM. Now let me take you first on the right side. See right side, no semicircular canals. Like we see on a normal cochlea, the superior semicircular canal to begin with. On the right side, there is no semicircular canal. What we see here is the intra-auditory meatus, that too, I would say bulbous, wide, not like a normal canal you see on the right side. Looks like a normal canal.
extra
On the right side is a bulbous canal, and anterior to that, if I see, I can see the facial nerve here, and if I follow the facial nerve, it looks normal. That is the labyrinthine segment, that is the first genu, that is the horizontal segment, and that is the vertical segment, and I don't find any abnormality, which is unusual for this kind of a pathology. This kind of anatomy, I would say. Now, more than that, coming to the point, look at the cochlea. Look at the cochlear aperture, look at the cochlea. The dimension of the cochlea is pretty normal. The shape is looking little round, I would say. I will tell you the reason behind that. And then the cochlear aperture, which is widened. We discussed last time, the normal cochlear aperture is around 2 to 2.3 millimeter. And see the dimension here, more than 3.4 millimeter with a more wide intra-auditory meatus. Both are, suggestive of a possible communication of the inner ear with the intra-auditory meatus, with the subarachnoid space, with the possible gusher if you operate on this side. This is important to understand. Now, this morphology of the cochlea is again important, which I will discuss later. But what I can see, the more rounded cochlea on this side. Then the vestibule, which is looking enlarged. You can see the vestibule, which is more enlarged than the usual. You can see on the right side the normal vestibule, and see on the left side normal, and this side enlarged vestibule with in these particular patients have a large ductus reunions. That is a characteristic finding. There's so many things. Let me pick up and then see where this kind of a malformation fits in. We'll discuss in detail that part. Then I don't see a prominent vestibular aqueduct, and on this side of the pneumatization is not, I would say, over pneumatized. This is, if you talk about the classification of pneumatization, to me this is category 1, 2 pneumatization. This is not over pneumatized temporal bone. Regarding the ossicles, the malleus incus you can see, but the important thing here, what you see in the region of the oval window, can you see some communication from the vestibule to the middle ear, some sort of soft tissue density in continuity with the vestibule towards the oval window, over the oval window. Can you appreciate this? Ashish, can you appreciate this opacity here?
Yes, Satish, beautifully. Yes, very well seen.
That is so important. So important. Now, coming to the opposite side. This here, on this side, the facial nerve, everything normal, the intra-auditory meatus normal, the vestibule normal. You can see the lateral canal, the canal superior, lateral, posterior canal, all are well developed. Vestibular aqueduct normal. The difference here lies is the cochlea. Look at the cochlea on this side. This cochlea is little smaller.
Yes.
Little smaller, hypoplastic, with no internal architecture. And what if I change the window setting? If I change the window setting, I can see the faint, modulus. That is hypoplastic modulus on this side, on changing the window setting. It is not absolutely through and through communicated. I can see the faint modulus over here. So this is the finding on this side. Let us go through the finding and then we'll discuss what kind of pathology it is. Now, the same thing what I showed you on the foot plate on the right side, you can see in the coronal section. Look at the coronal.
Is there a stapes suprastructure at all?
I don't see any suprastructure on the right side, but there is some opacity. There could be some part of the suprastructure, but some rounded opacity, soft tissue opacity on the foot plate, which is in continuity with the vestibule, which is not seen on this side. This side, see this?
Yes, yes, you can see the tape is well. Yeah,
This is in contrast to the right side,
beautiful.
which has a classical opacity in relation to the, in continuity to the vestibule. This is important finding which we should not miss on this side. Now coming to the MRI, about the findings. See this, what I intend to see on MRI besides the normal any ruling out any intracranial pathology, what I want to see the nerves. See dynamically, this is the cochlear nerve, this is the vestibular nerve. In such pathology, to me, this on the right side is a IP1 kind of a malformation, which I'll discuss what exactly it is. Incomplete partition type 1, in which this cochlear nerve is almost always hypoplastic. It is not absent. This is and there is a response on the aided audiogram at 80 decibel on both sides. So this is hypoplastic cochlear nerve on this side as well as this side. To see best the dimension of the cochlear nerve in comparison, to classify whether it is absent, hypoplastic, normal, it is best to see on the sagittal reconstruction images. See, let me reconstruct this the 3D cis MRI on the sagittal image, and what I can show you, if I take my cursor on the cochlear nerve, this is the sagittal image and this is my cochlear nerve. Now, how to confirm? See, this is cochlea dynamically, and this is the nerve which is emerging from the cochlea, this now, can you see the cochlear nerve where my cursor is?
Yes.
Yes.
That is the facial nerve. And see the dimension of this nerve is little smaller than the facial nerve. That's why I call it hypoplastic. And see this nerve is going towards the CP angle system. See, I'm following this now. So always don't believe at the snapshots at the sagittal cuts, because you never know which nerve you are following. Always follow dynamically so that you can trace the nerve to the origin. Here I was tracing the nerve from the origin, from the cochlea. So it cannot be wrong. Always trace the nerve from the origin. So this side of the nerve is relatively smaller than the facial nerve. We had responses on aided audiometry at 80-85 decibel on both sides, and rest of the anatomy is normal. You can see in the IP1, why I was calling it as IP1, the single, normal size rounded cochlea with no internal architecture. Can you see this?
Yes.
On the opposite side is a smaller cochlea. A smaller cochlea with faint modulus over here. On left side are the semicircular canal, normal size vestibule, lateral canal, posterior canal, all. But on right side, the vestibule is bigger. The vestibular conqueduct is not very prominent, and no semicircular canals. So now the question is, the previous time was a normal cochlea, and this time is absolutely, a different situation. And in order to explain this, the guy who has worked most in this world, I salute him for his dedicated work. This is Professor Levent Senaroglu from Ankara, Turkey, who has dedicated his life in understanding this embryological basis of malformation of the cochlea, and for that he has devised the classification. He has upgraded his classification thrice, and this is not simply playing with the words which people usually do for classification. He invested his decade of life in the temporal bone histopathology labs to understand these cochlea, their development in the embryos, right from 3 weeks to 20 weeks, 25 weeks, how the cochlea develops, how the cochlea grows, how the membranous and the bony cochlea develops, how the malformation take place, and the reasons behind understanding the malformation. This is a real, genuine hard work this guy has done. That's why we salute him. Ashish.
Yeah.
Introducing a new classification has become a fashion. It has become a gimmick now.
Yeah.
Anybody, you can play with the word, change one or two things and give Ashish Bhumkar classification. You
Yeah.
can give Thane classification, Mumbai classification, London classification. That is all gimmick, not only in cochlear implant, but in other things, JNA and so many things we all see, hundreds. But this is the real work, understanding the embryology and how he has devised the classification. So, in these inner ear malformations, there are certain concerns as compared to the normal, anatomy, no implantation in a normal anatomy cochlea, because such malformations many a times have a communication with the intra-auditory meatus, give rise to gusher. That management of the gusher is very important to prevent meningitis. Because of the malformation of the inner and the middle ear structure, very frequently they have facial nerve anomalies. And very important, because looking at the variety of malformation, size and internal architecture, you take a final call regarding your surgical approach, the type of electrode. If the cochlea is small, you have to go for a smaller electrode. If it is a like IP1 with no modulus around, you can't go for a modulus hugging electrode. You have to stay around the periphery. So type of the electrode selection, type of surgical approach, everything is different according to the situation. And in certain situation, when you have a doubt about the integrity of the nerve, or even if you implant and it doesn't work, then you have to think of ABI. So selection of the implantation, whether CI or ABI, what all to be done, all depends upon this, type of malformation. So now the biggest question is the simplification of understanding this malformation, which this Professor Senaroglu has done. And in the most simplified manner, I'm putting forward here with this graphics. Our cochlea develops as a simple autocyst at the 3rd week of gestation, And at that time, if the development of the cochlea arrests, if that part of the cochlear development is arrested or the inner ear development is arrested, what is going to happen? There will be no cochlea, no vestibule, and no inner ear. This will be a pure Michel deformity. Got my point?
Yeah.
If no develop beyond that stage of the cochlear autocyst develops, or the cochlear autocyst doesn't develop, then if the development goes on, in the 4th week of the gestation, what happens? That autocyst enlarges to become a common cavity. It doesn't differentiate. It differentiates further into cochlear and vestibule later. But in the end of the 4th week, it differentiates or enlarges to a common cavity kind of a thing, where it gets communication with the intra-auditory meatus and the nerves. And that, in that period of time, if the development happens to get arrested, the final picture, what will be the final picture? Will be a common cavity malformation. But the common cavity has a communication with the intra-auditory meatus. Now, what happens in between these? This is at the end of the 4th week. At the end of before the 3rd week, if the development arrests Michel deformity, no cochlea, no vestibule. In the early 4th week, this cochlear bud enlarges, and sometimes it becomes difficult to differentiate from a cochlear bud or the common cavity deformity. How can you differentiate with the communication with the intra-auditory canal, which joins at the end of the 4th week? And that is important to differentiate. Sometimes, what happens, this common cavity further differentiates into a separate cochlea and vestibule. And sometimes the cochlea doesn't develop hypoplastic cochlea, and only common cavity is the vestibule, which represents. And it is important to differentiate that cochlear hypoplasia from a common cavity. These are all fine points we need to understand. And this Senaroglu has given this, after deep understanding into the embryology of this aspect, he has classified these malformations according to the developmental arrest at the time of gestation. So suppose the development goes on in the 5th week. What happens in the 5th week? Normally, this common cavity differentiates into a separate cochlea and a vestibule. Just differentiate into 2 cavities. One common cavity differentiates into 2 common cavities. So, in that scenario, if the development arrests further, the patient finally will present with a separate cochlear cavity and vestibular cavity with no internal architecture. That is what we are having in this particular patient, IP1, with certain other characteristic which I am going to discuss later. So this is when the development arrests during the 5th week of gestation, or at the end of 5th week of gestation, when the common cavity divides, is already divided into a separate cochlea and a vestibule. Got my point so far clear?
Yes, very clear.
Now, with further development in the 6th week, the internal architecture develops, This is limited to the development of the cochlea and vestibule. The other parts of the inner ear are simultaneously developing, like cochlear aqueduct, vestibular aqueduct, semicircular canal, along with them. So this is restricted to the development of cochlea and vestibule. So what happened in the 6th week, after the separate cochlea and vestibule which have developed in the 5th week, they differentiate because of the internal architecture developing inside the cochlea. In the 5th week, the cochlea is a common cavity with a communication with the intra-auditory meatus, with no internal architecture. In 6 to 8 weeks, the internal architecture develops. At the end of the 8th week, if the person's development going on till the end of the 8th week, the cochlea will have a normal internal architecture, I would say. So what happens between 6 to 8 week is all various malformation develops according to the arrest of development at various places.
Timing, yeah.
Like for example, in the 6th week, variety of cochlear hypoplasia develop. I will show in the next slide the variety of type 1, 2, 3, 4 cochlear hypoplasia. Hypoplasia means, in simple, the cochlea develops, but the size of the cochlea is smaller than normal. They are divided into different types according to the further internal architecture which is developed. In the 7th week is a classical anomaly which we define as a IP2. In what is there in IP1? No internal architecture. In IP2, the further internal architecture develops. The basal turn is very well developed, but the modulus beyond the basal turn and the interscalar septa are not developed. So what happens? The middle and the apical turn, they form as a cavity. Single cavity with a separate basal turn. That is IP2. And this is very commonly described by Mondini as a Mondini's deformity. If the patient is along with IP2 has an enlarged vestibular aqueduct and a vestibule, dilated vestibule, then it is known as Mondini's deformity. So IP2 is one of the component of the Mondini's deformity, we can say. And another deformity, if I go ahead, see this, so just to show you the picture what I have shown. At the 3rd week, no labyrinthine structure developed, Michel's aplasia. But developed rudimentary autosis at the end of the 4th week, end of the 3rd week or beginning of the 4th week, that is rudimentary autosis. This is a common cavity with a communication, direct communication with the intra-auditory meatus. Then, incomplete partition type 1, this is the case we have today. We have on one side IP1 and on the other side cochlear hypoplasia type 2. And let me describe what these two things are, and then we'll discuss how to take a decision which side to operate upon.
Satish, sorry, at what week of gestation is the cochlear nerve developing?
Yeah.
Early on.
In all these deformities, cochlear nerve development is an important independent factor in choosing the surgical approach or choosing the overall treatment. The reason is, any of this deformity, if are associated with a absent cochlear nerve, is an indication for ABI.
Okay.
Maybe IP1 with the absent cochlear nerve is the indication for ABI. Otherwise, IP1 candidates with the cochlear nerve intact are good candidates for cochlear implantation. So cochlear nerve has been classified into various categories according to the development as well, separately.
Okay.
So why this patient we have categorized into incomplete partition 1? Senaroglu has established this malformation by understanding at the level of pathology. And the defect in the IP1 is classically a defect in the endosteum. The lab has developed 3 layers. The outer periosteum, middle endosteum, middle layer, mesal layer, and the inner one, the endosteal. So IP1 has a classical defect in the endosteal layer, number 1. And number 2 has a defect in the vascularity coming from the internal auditory canal. Let me elaborate what I'm trying to say. Ashish,
Yeah, yeah.
this labyrinth has three layers: the outer, middle, inner. Yeah, outer one is the periosteal, inner one is endosteal. Okay, the outer two layers has a separate vascularity during development from the middle ear vessels.
Hmm.
The inner endosteal layer has a separate vascularity coming from the intra-artery canal. This is important to understand. Number one.
Okay. Okay.
So this IP1 is because of the endosteal developmental defect, and this is most likely ascribed because of the defect in the vascularity coming from the intra-artery system. So basically, it is a defect in the endosteum. So what happens? Our membranous labyrinth is now directly in contact with the outer two layers as the endosteal layer is deformed. Got my point?
Yeah,
So
yeah.
the membranous labyrinth is now becomes expansile, it expands. And the outer two layers are compressed. That's how this cochlea becomes a rounded one in IP1. Secondly, the foot plate similarly has a two development. One is from the middle ear side and another endosteal from the inner ear side.
Yes.
In such endosteal defects, the foot plate is malformed. And many a times you'll find a cystic kind of a thing coming out of the foot plate into the middle ear.
Oh, that was what you were showing as some the soft tissue there.
That is classical for IP1. And it has a lot of bearing, Ashish. Such cases, I would never recommend anybody with a simple approach. I will tell you the reason. You know, out of all these malformations.
So sorry, Satish. So this foot plate is actually very fragile, or theoretically there is no foot plate. There perhaps no bone there.
It is simple fibrotic from above. Inside there is no endosteum.
Okay.
So foot plate is defective. Now, what is the bearing upon this issue? The issue is, out of all these cochlear malformations which have, communication with the subarachnoid space, this is the one which most commonly presents with meningitis. Not post-operatively, pre-operatively is a different situation. Because these children with a defect in the foot plate were a cystic kind of thing bulging from inside. Whenever they develop otitis media, can lead to infection and meningitis. For such reason only, these patients require surgery. Hearing aids, forget about the hearing. Remember, last year at the Morwani Search workshop, I did one case wherein the child presented with meningitis 3 times, had a profound hearing loss, and sir kept it for a CSF otorhinorrhea repair. When I look at the audio, the CT scan, it was pure IP1. Had a CSF otorrhea from the foot plate.
Oh.
We did a subtotal petrosectomy and obliterated the entire cavity, and the child is perfectly fine. I asked their parents that time, because the patient had a profound hearing loss, to undergo cochlear implantation as well, but they were not willing because of the monetary issues. But still now we have done subtotal.
But would you have, if they were willing, would you have done in the same stage, the implant?
Yes, same stage. Yeah, like this patient, if he has been having the CSF otorrhea from the foot plate the same side, we'll repair the same side along with the implant. No issues.
Okay.
Still in that patient, the option of the cochlear implant is still viable. Viable in the sense, we have done a subtotal petrosectomy, means excentrated all cellularity of the temporal bone, all mucosa on the skin of the temporal bone, and blocked off all connections of possible source of infection from outside by means of obliterating the Eustachian tube, by means of blind sac closure of the extraordinary canal, and the entire cavity over the implant is filled with the fat. So that is a very, very sterile zone for the implant for future, with no possibility of infection in the future. Anytime that patient wants the implant, we'll go from behind, lift up the fat, and push the implant inside and come out. As simple as that.
Sir,
Ranti wants to make a comment. Yeah.
No, I just wanted to ask, do you do subtotal petrosectomy in all cases of IP1?
Yes, I am coming to this, Kranti, and I will tell you the reason behind that. A solid reason behind that, and I've been doing and I've done more than 50 subtotal petrosectomy for implantation so far, with a strong scientific basis, which is pure evidence-based medicine, which I'm going to share with you. So the reasons are many, and that is one of them to prevent future infections. So these patients present with repeated infection because of the fistula at the level of the foot plate, that is classical for IP1, because they have endosteal development anomaly. So what are the characteristics as you see on the slide? More than a common cavity, there is a clear differentiating in cochlea and vestibule. The external dimension of the cochlea are normal. The cochlea lacks the entire modulus and the interscalar septa, no internal architecture. There could be small defective modulus at the base of the cochlea, which our CT scan may not appreciate. Because many of such IP1 patients on, cochleostomy, they do not give gusher. In spite of looking like a through and through space between the subarachnoid space and the cochlea, because of some membranous septum separating, the subarachnoid space from the cochlea, which is not appreciated on a CT scan. So there is lacks the entire modulus and the interscalar septa, a defect in the ISC and the cochlea due to developmental abnormality of the cochlear aperture and the absence of the modulus. That is what I was saying. The vestibular aqueduct is generally enlarged. The reason is not in IP2. The reason is because of the direct communication of the CS of space, as the membranous labyrinth can expand. The cochlea has an outer, the two layers of the bone. It cannot expand, but the vestibule can expand because the development of the vestibule is always delayed by the development of the cochlea. And majority of these patients have the vestibule enlarged, not the vestibular aqueduct at all. There is dilated ductal reunions, as I mentioned, and this endosteal development anomaly leading to defective foot plate development, leading to a cystic structure on the foot plate. All these signs are classically, you can see on the scans of this particular patient. And so far, any suggestion, any question or anything so that we can move forward?
Sir, Dr. Vasanti Anand from Bangalore wants to know, is this patient is having any history of meningitis, any episode?
Not really.
No.
Not really.
CSF rhinorrhea or something, sir?
Not really. We don't have such history. Yes.
The answer probably is not yet.
Not yet. Lucky.
I just want to add one instance when that one of the cases which we posted for laser styptotomy at our hospital once, and he was I have repeated this instance and many times. So this boy was I think 17 boy, and we had posted him for stapes surgery. We had no data with us. The audiogram showed us conductive, and the moment I put in the laser shot, and it was a huge tear, and then retrospectively went back and did the CT scan and found IP1.
Kranti.
So did the superstructure was normal, Kranti? The superstructure was normal?
Yes.
Kranti. Yes, your point is valid. Let me emphasize two things over here.
Yeah.
Number one, what the classical example you have shown is almost always associated with IP3, number one.
IP3?
Because IP3 is an enlarged, in situation when there is enlarged vestibular aqueduct, in IP3 is a direct communication to the,
IAC, yeah.
And the foot plate in the IP3 is something fixed because of the third window kind of a phenomena.
And also due to increased pressure, it is not moving.
But yes, and Ashish, you remember in our Stapes Carnival,
yes.
The patient Ashim was doing the same thing, and later on we evaluated and found IP3, and then finally we implanted.
Yes.
The patient developed a profound hearing loss after the Stapes surgery, and we had to implant. So
this Kranti, your patient was 17-year-old, you said?
Yeah, so I do understand that, young boy, I should have gone for radiology before. Yes, I do understand. So from then on, we have changed our protocol. I don't have a cone beam CT, but radiation is something, but these latest CT scans have less radiation. Obviously not in comparison to cone beam CT. But now we do radiology for all the otosclerosis and COM patients as well.
That is something can prevent.
Perfect.
Dr. Kranti, can I ask you one question? Your audiogram, has it shown a conductive hearing loss or a sensorial hearing loss?
It was
you planned for a stapes surgery.
It was a conductive hearing loss.
Was it a wrong audiogram or is it a
No,
sensor in
it
your
was,
hearing loss?
it was not a sensor in
No,
Sir, can I say something?
also because very typically in IP, normally what sir says is many patients do come with these fixation of stapes because of inside the vestibule, because it's directly in communication with the IAC. So there is a fallacy, and many such, if you go through literature, you will have. So that's why it's said that in young patients, at least go for a radiology and see if there is any cochlear malformation. There was
Yes,
conductive hearing loss.
yeah, when it comes to I know that age group, you said the age is how old is he? Dr.
He was
Kranti, how old is
17.
he?
Yeah,
17.
he was
Was it a
17.
bilateral
17.
conductive hearing loss?
Yes, it was bilateral conductive.
Oh, okay.
Yeah, it was bilateral conductive.
That audio may not be incorrect. I tell you the reason.
Yes,
This happens classically in the third window disorders.
Yes, yes.
When you have an enlarged vestibular aqueduct, it behaves like a third window disorder with a status of sort of inner ear hypertension with a more pressure of fluid behind the foot plate. So it restricts the movement of the foot plate, number one. And number two, in such third window disorders, the bone conduction become oversensitive.
Yes, it's above it's supra threshold.
Bone conduction is negative.
Yeah.
With some airborne gap, in particularly in lower frequencies.
Lower frequencies.
But because of the repeated, your patient was quite old. Because of the repeated head trauma and all this, these patients keep on developing some sort of sensorineural hearing loss. So majority of such patients, if you are careful, still you can pick up by having a lower frequency airborne gap audiogram with oversensitive bone conduction, particularly sometimes in minors, with a mixed hearing loss pattern. In young individuals, you have to be cautious, get CT scan done, and you can avoid this problem.
Yes, I think these are things which I do very carefully after that case.
Yeah, but
what Achi just mentioned about the foot plate, that is very important. Because in such patients, when you explore, still you are not sure, you are going for a stapes surgery, not knowing what is there behind. Still you can pick up, if you focus under high magnification on the foot plate, you will find either some pulsations of the perilimb or some micro perilimb coming out through the micro fissures, under high magnification. Still you can suspect that kind of a picture and warn you from doing a stapes surgery further.
Satish, are there any associated annular ligament variations in such patients?
Not really.
Not really.
That can happen in
a fixation. Yeah.
Yeah, in a different situation. In IP1 also, many times one may find, the foot IP3, the foot plate fixation.
Absent annular ligament?
Yes.
Yeah.
Because the annular ligament differentiates later. This is early development we are talking about. The annular ligament differentiates later. And if the development arrests at that point of time, the inner ear development of the foot plate
is going to get arrested.
Like a fixed one without annular ligament. So that is something important. Now, to add on to what I was describing as IP1, why it is important? Choosing an electrode is very, very important because there are certain...
sir.
Yes?
Satish sir.
Yes?
Soumitra here.
Yes, boss. How are you?
Hi, I'm good, sir. How are you?
Good, good.
So I had one query regarding Kranti's case.
Please.
Usually we see IP2 are the people who have deteriorating hearing loss or who have progressive loss. So they will have language. But an IP1 or an IP3 will always have SN loss. So at 17, the patient already has language problems.
No. This was IP3 anomaly. And he was just having hearing loss, no language issue.
No language issue.
No language.
So could it be an IP type 2, sir, then, with an enlarged vestibular aqueduct?
No, it was not IP type 2. Gushers are very uncommon in IP type 2.
No, IP type 2 usually have a large vestibular aqueduct. So we'll have
but gushers are not very, very common in comparison to, I think, IP3 or even IP1. IP1 also doesn't have a lot of. IP3 has no gushers.
So,
Sir, a question from Dr. Nageshwar Rao. When do we say a enlarged vestibular aqueduct?
When do we
say enlarged vestibular aqueduct?
Vestibular aqueduct is considered to be enlarged when the dimension of the duct, right from the at the midpoint, you can say from between the vestibule and the posterior edge of the petrous bone, where it opens. At the midpoint of that, if it is more than 1.5 millimeter, and even at the opening of the operculum, if it is in tangentially, it is more than 1.5 millimeter, it is considered enlarged.
Can I add one point, sir, in this? There was this interesting presentation which I was listening to, which also said that an easier way to understand also is if the lumen appears more enlarged than the semicircular canal lumen, then you should expect that it is enlarged.
Yes, ma'am. Posterior semicircular canal lumen we can compare. Yeah.
Yes. So in this IP1 patient, I have certain concerns. What happened? Number one concern, because of the possibility of communication directly to the subarachnoid space, there are high chances of gusher. And in over 80% of the patients of the IP1 have gushers. So number one, you have to manage the gusher surgically, the surgical challenges. Number two, since we have no internal architecture modulus inside, when we insert our electrode, the electrode may go inside the intra-auditory meatus because there is nothing to stop there for the electrode to go inside. So we have to be careful in terms of during implantation that the electrode should not enter the intra-auditory meatus. So the choosing a particular electrode is very, very important. The reason is no modulus around. If you use a pre-curved electrode, it curves towards the modulus, and in the center there is the intra-auditory meatus. There's a high possibility of the electrode going in the intra-auditory meatus. So here particularly we need a lateral wall electrode, straight electrode, so that you can pass along the lateral wall, because you don't know where are the neural material to stimulate, but it is at the periphery, and it has been studied recently that majority of the neural material to stimulate in the IP1 is at the periphery inferiorly. So the electrode we need what we
circumferential.
Yes.
Should be circumferential electrodes, I think.
Yes, should be
Yes.
circumferential. I would say the electrodes having not half-banded, full-banded electrodes you need, which can stimulate all around, because you never know where the neural material to stimulate is. So what our preferred electrode in this situation is the Madel foam electrodes. It has added advantage of this stopper here, so that when you make any cochleostomy or something at the end, you can plug this along with the soft tissue at the level of this stopper, so that you can efficiently clog the CSF leak as well. Along with this full banded electrode, circumferential electrode, this is 24 mm and the 19 mm. 24 as a active electrode diameter length of 18.7, where the electrodes are spaced at a 1.7 millimeter, and in the 19 in a 14.3 mm long this thing electrode array, with the spacing of the electrode in between is 1.3. So these are not longer electrode arrays. If you try to use the longer one, it can go inside the intra-auditory meatus because there is nothing to stop. And second thing, it can efficiently stop. It can help you stop the CSF leak much better than a regular one. Okay?
Sir,
Yes.
one question. Along with this stopper, do you use do you thread this through a fascia and then put it, or
Yes,
you
always. So what Kranti is saying, before placing the electrode, you can thread the muscle of the fascia, and then once you pass in the electrode, you take the fascia to the cochleostomy site and then push with the stopper so that it snugly fits into the cochleostomy to block the CSF leak. That is a good strategy. That's why I prefer to use these electrodes for such situations. Now, quickly to the other anomalies, we have seen the heard of IP2. IP2, we have already discussed. The basal part is intact, but the other two form a common cavity for the middle and the apical one, and they form the classical Mondini tied with the entire enlarged vestibular aqueduct and a dilated vestibule. And this is type 2. Cochlear implantation in type 2 is as good as normal cochlea because you have a complete normal basal turn. The one turn complete with the maximum neural material to stimulate is there normal like normal cochlea, so you don't have to do anything different than a normal cochlear implantation.
Yeah.
Type 3 is, this is rarest. This is most, I would say, challenging in the sense the interscalar septas in the type 3 are intact, but there is no modulus. No modular base. There is through and through communication with the CSF space. And here the anomaly is different as compared to the IP1. IP1 has an endosteal anomaly. IP3 has a periosteal and the mesial layer anomaly. What's my point? The outer two layers are defective. Because the reason is the vascularity coming from the middle ear side during development to the outer layers is defective. But the inner layer is intact. So how would the picture looking like? See this. The cochlea will look like this. Cochlea will look like this with interscalar septa and no outer thick layers. They are intact. And this is a sort of challenge to the implant surgeon because the bulbous IAC, the cochlea is sitting right onto at the lateral end of the IAC, so electrode is likely to go into the intra-auditory meatus if you are not careful. It has a more chances of electrode placement into the intra-auditory meatus as compared to the IP1. Got my point? Yes, so this is something you have to be very, very careful in these situations. So these are IP1. Finally, the no internal architecture, IP2, the separate basal turn, and IP3, the outer two layers defective, and the cochlea is sitting right on the intra-auditory meatus. So these three different things have different implications and we need to understand. This patient is on the opposite side of the cochlear hypoplasia type 2. Why it is important to understand in terms of implantation? This is the classification for hypoplasia. Hypoplasia means the overall dimension of the cochlea is less than normal. Less than normal. So in type 1, it's simple like a bud coming from the intra-auditory meatus. This is most dangerous because there is direct through and through communication to the intra-auditory meatus. This patient has a type 2. It is simply like IP1. This is a younger brother of IP1, I would say. Cochlear hypoplasia type 2 is a younger brother of IP1. The reason is, see this is cochlear hypoplasia 1, just simple bud. Here it is looking like IP1 with no internal architecture. There is faint modulus and direct communication to the intra-auditory meatus, and I can call it as a younger brother of IP1. And the commonest anomalies together, if you go to the literature, wherein one side is the IP1 and the other side is the cochlear hypoplasia type 2. And the reason behind both of them is the same genetic abnormality, that is the defective vascular supply coming from the intra-auditory meatus to the endosteum. And both have endosteal, abnormality. So both are similar. In IP1, the severity of the abnormality is much higher than the cochlear hypoplasia type 2. That is the basic difference. Type 3, when the cochlea is having less than 1.5 tons, smaller in size, and the cochlear hypoplasia type 4 is when the basal turn is normal, but the middle and apical are hypoplastic. This is so important to understand. Why I put up this 3 and 4 over here. The reason is, as I said, the membranous labyrinthine development up to 8 weeks. If it goes normal to the 8 weeks, the internal architecture is normal. But its development goes on till 18 weeks. And after that, the bony, the cochlea develops around that. So what happens between 8 to 18? Whatever cochlea which is developed, this cochlear duct which is developed, the turns of the cochlea which have developed, they lengthen. Increase in length between 8 weeks to 18 weeks. And this is classically a developmental anomaly between 8 to 18 weeks, wherein 10 to 18 weeks, I would say, the basal ton tube is completely developed. First, the basal ton tube develops, then the middle ton, and then the apical ton. So, middle and apical are defective because of the developmental arrest between 10 to 18 weeks. This is classical of cochlear hypoplasia type 4. So we need to understand the developmental arrest at what point of time happened, what kind of abnormality is given, what is the defect, what is the genetic condition behind it, and what is the implication for cochlear implantation. All these are important. And in the end, there is a classification recently by Sanaragoglu about the modular defects in the normal modulus, to a short modulus, to a compressed modulus because of the extended scala. This is in the enlarged vestibular aqueduct. What happens in enlarged vestibular aqueduct? The scala vestibuli is enlarged, pressing upon the modulus. Then this is the partial, absence of modulus, subtotal absence, the subtotal absence of the modulus, and the complete absence. We need to know from radiology that what kind of modulus structure is there, so that we can predict the possibility of gusher, and we can plan our surgery accordingly to that situation. Now for this patient, why I have chosen the subtotal petrojectomy? This is the biggest question. And why I have chosen the right side, not the left side. Why right side? Simple. As a similar hearing loss, similar cochlear nerve, on the left side, I would be able to insert less number of electrodes as compared to the right side, and that is the simple reason behind choosing the right side, because the right cochlear dimension are normal. Got my point? Number one. Why chosen subtotal petrojectomy? Subtotal petrojectomy has number of indication in cochlear implantation. The reason is these patients with a possibility of gusher, with a defect at the foot plate, we don't want the infection to come in any point of time to this area again, to give a sort of guarantee to prevent future infection and meningitis. Subtotal petrojectomy involves exentration of all cellular system. It helps in identification of the middle and inner ear structures much better than a normal situation. And you can efficiently clog the CSF rhinorrhea or CSF leak as compared to the normal situation, as you obliterate the entire cavity. And then more than that, you block off all sources of infection to the area by means of obliterating the the eustachian tube and the cul-de-sac closure of the external auditory canal. So no question of infection setting in to this sterile zone in future, and that is what we want in these patients who have a high probability of a gusher. If you don't go by the by the regular technique, what can happen? What chances one can take? Number one, dealing with a CSF leak would be much difficult. Even if you close the cochleostomy CSF leak, you don't deal with the foot plate. Still, with the normal closure of the CSF at the cochleostomy, patient may develop meningitis because that foot plate anomaly is not addressed. So that's why this is the need of the time to address such patient in a more efficient manner to protect your patient from developing meningitis in future. So in general, why we need subtotal petrojectomy? Let me tell you, this is the man behind where we learn all this art from. This man who has done a phenomenal work and propagated this science with a pure science behind it, subtotal petrojectomy for cochlear implantation, and who has, to his credit, the largest series in the world of subtotal petrojectomy for cochlear implantation. I will brief in 10 minutes, enumerate, and then our case is ready. Dr. Pachauri has already started, who has developed the incision and the flap and the bed for the implant, and now I will join him and start with the steps of the subtotal petrojectomy in next 10 minutes. So, next 10 minutes about understanding this science of subtotal petrojectomy, particularly for cochlear implantation. This subtotal petrojectomy was developed in 70s by Hugo Fish, for other lateral skull-based pathologies. So what it involves? Complete exenteration of all air cell tracts and skin from the temporal bone, and block of all connections of possible infection of future by means of blocking eustachian tube and the extraordinary canal and obliterate the cavity with the fat. This was initially developed after addressing lot of lateral skull-based tumors, but it has a huge role in cochlear implantation as well. The reason is, see his publication, which stimulated us in 2013, and then his own publication, see, in 2016, lesson learned after 110 cases. What is that lesson? What lesson he learnt, which we need to understand and prevent that mistake to happen. If you implant on a child, cochlear implant, on a regular child, regular normal anatomy child, whatever, with an implant in place, if the child in future happens to develop otitis media or chronic suppurative otitis media, what happened? Kisne hilaya? After the implantation in future, maybe 6 months, 1 year, 3 years later, whatever time, if the child develops a discharging ear, how will you deal with that? With a disinfection in the ear, wherein a foreign body in place, which is difficult to control by antibiotics, it's a simple philosophy. Everywhere in the body, if there is a foreign body in place and the infection sets in, the only answer is to remove that, explant. Otherwise, that infection, in this particular situation where the patient is implanted with a cochlear implant, where you have opened the avenue into the inner ear already to propagate the infection to the subarachnoid space. If you don't treat the infection, the patient may develop meningitis. It may extrude the implant out, or you'll have to explant it. So to prevent that situation, you have to think of this technique, and you can almost certainly prevent that things from happening. That is what he published. Lessons learned after 110 cases, and this is for us to learn out of his experience. So what does the subtotal petrosectomy provide us? Subtotal petrosectomy provide us the best opportunity to deal with any infection in the middle ear cavity in general. Now in a child, for example, if the patient has had CSOM earlier, has cholesteatoma earlier, and you have operated, or you have to operate, has a profound hearing loss which requires cochlear implantation for rehabilitation, how will you go ahead? If you do a mastoidectomy, suppose intact canal mastoidectomy, canal wall down, what can happen? What are the long-term results of mastoid surgery? The CSOM can come back again, and with the implant in place now, the patient is at the risk of losing the implant, at the risk of meningitis and all that. What you can do at the same stage, you have almost 35 plus cases now of cholesteatomas with subtotal petrosectomy and implant same stage. And Touchwood are doing very well because we blocked off all the connections of future infection to that region. So it gives you the best opportunity to deal with the infection in the future. It minimizes the CSF leak. Whatever electrode arrays you play, like you do drill out and all, it stabilizes the electrode arrays better. It prevents the extrusion of the implant because the entire cavity is obliterated. Your implant can't extrude so easily. It prevents the possibility of extrusion, and more than that, it gives you the best exposure. Suppose you have an abnormal middle ear, inner ear, abnormality, malformation, whatever. You have a high jugular bulb, very high jugular bulb, you have a narrow facial recess, you have a low tegmen, whatever anatomical abnormality. Subtotal petrosectomy opens up the space like anything. Yeah. And implantation is a child's play, which gives you the best exposure. So this is something which can be provided. All these four objectives are from subtotal petrosectomy, and these are our list of expanding indications for subtotal petrosectomy, not for IP1 only. Any malformation which can give rise to CSF leak, I will go with subtotal petrosectomy implantation for once for all. There is no question of future infection, no question of future CSF leak. And for that matter, we ablate the middle ear system, which is never going to be utilized by the implant as well. There is no harm in doing that.
Correct. Yeah.
Because you are not leaving the middle ear for infection.
It's irrelevant, that organ, yeah.
Yes. So these are the indications. Or any radical mastoidectomy, whatever you have done, you can rehabilitate with the subtotal petrosectomy and obliteration and implant at the same time. Cochlear ossification, this I will emphasize in a minute separately. Ossification is one thing in this era with a lot many pneumococcal meningitis patients giving rise to ossification. Still you can rehabilitate those patients with drill out procedure. Even in the extreme ossification situation which requires a complete drill out, still you can rehabilitate. Like now, think of drilling out the cochlea through the narrow posterior tympanotomy, the entire cochlea. What can happen? The carotid artery is immediately anteriorly. One can damage the carotid artery if not very careful. If you do a subtotal clitorudectomy, you have a full exposure in front of you. You can control the carotid, jugular, everything in front of you, and you can drill out much better. You can secure your electrode arrays, which are now open, with your obliteration material to prevent displacement, to prevent CSF leak. So this is the answer for all these drill out procedures. All those inner ear malformation requiring good exposure, giving difficult anatomy, or giving CSF leaks. Fractures of the temporal bone. You know what happens in fractured temporal bones with profound loss, and if you can rehabilitate with the cochlear implant. But what happens? The fractures in the temporal bone do not heal with the bone. They heal with the fibrous tissue, and that becomes a future avenue for infection to propagate. So always in such situation, do a subtotal petrogectomy and implantation and block off all the connection of future. Osteoradionecrosis of the temporal bone with low vascularity in that region and acquiring infection and again. With radiation-induced sensory neural hearing loss, still you can rehabilitate with the implant and prevent future infection by subtotal petro. There is no other technique which can work in this situation. So in any difficult situation, after any skull-based surgery, provided your cochlea is intact with the fluid and intact cochlea now, every given situation you can rehabilitate with the subtotal petrogectomy implantation. This is the most versatile technique, I would say. Unfortunately, many cochlear implant surgeons are not using it. Considering this is a big operation, difficult operation, you have to skeletonize the carotid, jugular, could be risky and all that, but this is the merit which you cannot deny. For the patient's benefit, this is the number one surgery. And believe me, once you get used to this surgery, you can do it. It is not difficult at all. So my concern in CSF, why? Any condition which can give rise to CSOM to the child in future. If I'm operating on a young child, I'll assess it most, I would say, extensively to rule out any condition which can give rise to CSOM. Because after implantation, CSOM occurs is a big problem. So any given situation which can lead to CSOM or any pre-existing CSOM which has been treated, the answer should be on priority to prevent future problem is subtotal petrogectomy. Some can call it as the most radical for that situation. This is how it appears. I will show you. Somebody can tell me that why to do after a simple perforation closure a subtotal petrogectomy obliteration. Let me tell you. Or after a cholesteatoma intact canal surgery. What are the long-term results of tympanoplasty for perforation, subtotal perforation for say? You pick up any long-term series in the world published. 82, yeah. Immediate results are over 90%. Long-term results up to 70%. Yeah. So the guy who has been implanted and again develops the perforation, what is going to happen? Now either you operate on that perforation with the implant in situ, putting your implant on stake, or infecting the implant, which may develop biofilms, warrant explantation, because you don't have any control over the physiology of a perforation. You can't prevent in future for 100%. Why not to prevent at once this kind of surgery to prevent future problems? So all these children having all these high risk factors, like if you're implanting children, normal cochlea, Eustachian tube dysfunction, nasal problem, cleft palate, recurrent adenoid, severe allergy, severe rhinosinusitis, recurrent ONME, particularly eosinophilic, better to stay on the safer side and implant with a subtotal petrogectomy to prevent future infection coming into the temporal bone. I hope you understand what I'm trying to say. This is something, the need of the time to prevent future infection. Otherwise, all those poor patients may require, a chunk of patient may require explantation in the future course of time. Many sub patients have been explanted also. I cannot quote the figure, but this is the reality. Lot many patients, particularly who have been done free in the schemes, used implanted indiscriminately without extensive workup on the nasal part and all, and these poor chaps develop infection and explanted later on. So this is something you can avoid. So I can just now go into the surgical part. I can skip all this. We have discussed.
One more question. When can we expect facial nerve dehiscence in these IP321 deformities?
Yes, very important. So, facial nerve abnormalities you'll find in relation to abnormalities of the semicircular canals. Like in common cavity, in those, the facial nerve is more anteromedial. You know, in IP3, the facial nerve, in IP3, the facial nerve is more superior. It depends according to the, the development of the vestibule, because the facial nerve is just lateral to the vestibule. According to the development of the semicircular canal, the facial nerve is in relation to the lateral and superior semicircular canal. So, depending upon the malformation of the semicircular canal and the vestibule, the facial nerve has a final position, and that you have to ensure pre-operatively on CT scan. See, once I started CT scan reading today, the first thing I saw was the facial nerve. Because, and in this particular patient, fortunately, we have a facial nerve at normal place.
Yes, sir.
So, that is important.
And sir, one more question, Dr. Bishwajit Gogoi wants to know, if we have a cholesteatoma going to the pitagus apex, will we do the implant in the same sitting?
Yes, why not? See, that is what I'm coming to. A lot of opponents of the subtotal petrojectomy may have this question in their mind. If the cholesteatoma comes back, if you happen to leave the skin behind and obliterate, what is going to happen could be a disaster. Yes, it could be a disaster. Now, let me tell you, if you are doing a cholesteatoma surgery with a canal down approach, you happen to remove cholesteatoma from all over easily, isn't it?
Yes, sir.
This approach gives 100 times better exposure than a canal down mastectomy. Still, if you can leave cholesteatoma being a CI surgeon, you don't deserve to do that. As simple as that. How can you leave the skin behind with so much big exposure? You know, my big concern is not the skin. My concern is the mucosa left behind, which can suppurate later. With such a big exposure, no one can, average middle ear surgeon can leave the skin behind. But to stay on the safer side, you're right, we must follow these patients with a regular radiology. With the implant in place, of course, you can't get the MRI done. With the diffusion weighted MRI is the best technique to detect cholesteatoma. What we can do, we can get a simple CT scan done with a fat in place. Fat in place, if any cholesteatoma coming in relation to the fat, you will be able to appreciate it much better as a different contrast from the fat, and we can appreciate the cholesteatoma. If you have a doubt of cholesteatoma developing, you can get a serial CT scan to confirm that it is growing, and then you can go and remove it. So this is something, this is the slide you can see. These are certain contraindications, certain complications that you need to keep in mind, and it all depends upon your surgical excellence. You know, one cannot leave the cholesteatoma behind, I believe, if he's an average middle ear surgeon. But yes, the mucosa, one should not leave behind.
Yes,
that
sir.
is, if I'm operating, my main concern is mucosa. I should not leave the cells behind. If I leave the cells behind with unaerated mucosa, it may suppurate. So you see, during the entire course of surgery, my focus would be to excentrate, track behind all cellularity and excentrate all possible cells. That is the, the main challenging part of the surgery, not the skin. See this on follow-up. This is for Mario Sana. See this fat cavity and this cholesteatoma is appearing different in contrast as compared to the fat, and still you can appreciate from the CT scan without an MRI. So this is how, but not only a single scan, you have to follow with the serial scans whether it is growing, and then you can explore and remove it.
Then so when will you do the serial scans?
Yeah, our protocol is 1, 3, 5, 7, 10 years. This is the ideal protocol described by Professor Mario Sana. And depending upon the kind of surgical experience you had in that particular patient, you can choose your own protocol. If you are not very, very confident, you can get it more frequently done as compared to the regular advice protocol.
Sir, one more question, Dr. Mohammed Rizwan wants to know, in case of
Yeah.
meningitis, there are chances for ossifications. So how do you deal with those cases?
Meningitis, yes, that's very important question. Okay, I must congratulate him, boss. See, in meningitis, let me tell you the protocol. Pneumococcal meningitis can spread through the cochlear aqueduct to the basal turn of the cochlea first. That's how the ossification start at the basal turn of the cochlea first. And then to the complete basal turn, then the middle and apical, then that's how it goes. First to the scala tympani and then to the scala vestibuli. So, the ideal protocol internationally is any child who has developed meningitis, believe me, the first call is to ENT. First call is to ENT, and what you need to do is to give a shot of steroid to prevent inflammatory complications and to keep a tab on the hearing of the patient. Any movement in the serial, follow-up in meningitis patient, every other day follow-up, the moment you find the hearing loss developing, even a 30 dB hearing loss developing is the indication for MRI. What you can find on MRI at the earliest, the value of early diagnosis is you will find the loss of fluid signal and the fibrosis developing.
The flare sequence is important.
Yes, that is the siesta. You will find the loss of fluid signal and the fibrosis developing. That's the earliest change you can appreciate. And that is the time to counsel the patient to go in for implantation, otherwise the cochlea will get ossified. Once it is ossified, it is more difficult, more challenging. The results are never going to be as good as normal cochlea. So, in that situation, you need to implant on an emergency basis. You know, the Professor Mario Sana has implanted the youngest child, 4 months old, because of the meningitis. Because of the changes starting in the cochlea, which otherwise, if it doesn't do, will preclude the cochlear implantation in future. Now, the only thing is, in that situation, in emergency, the patient is not willing to get implantation done because of the monetary issue and all. What you can do is stenting. This was the publication from Dr. Milind Kirtane long back. You can go through what he did. Cochlear stenting. You means you hire you can have a dummy cochlear implant from the company which always provides. Go to the cochlea, implant the dummy implant to maintain the lumen. So that if the child is not getting implant done now, you can come back in the future, remove the dummy implant, you'll have a lumen in place, and you can implant the other one. So that is known as cochlear stenting. That is something, a dummy cochlear implant you can place to buy the time. So in meningitis, you have to be very quick, I would say.
Thank you, sir. Thank you.
I can see Professor.
I think there is no signal. I think we lost Satish sir's signal. So to ask Dr. Kranti, so in these cases, what will you prefer? Full banded CI REST or middle half banded? What is your preference? I think you can just unmute yourself.
Yeah, Paramita, can you repeat?
So there was a question in these cases, what will you prefer? A CI REST as its full banded or?
I already mentioned I'll use a foam 19 or 24 electrode, which has a stopper behind to prevent CSF leak.
And they are full banded too.
Medal.
Full banded.
Medal.
Full banded. So type of electrode choice is important, and different anomaly, different conditions. You can have different, unfortunately, especially medal comes up with differences, not only sizes but designs. Other companies have them. You have the slim electrode, you have the straight electrode, you have the form electrodes, and form electrodes are excellent for IP anomalies. IM3 especially,
Yes.
IP2 is almost like
You
a
have
normal.
advantage of sealing.
Yes, that is the
Dealing
best.
with a stopper. Professor Noori, can you hear me? You have to unmute.
Just one question.
I can see
So in
Professor
case,
Nuri.
Okay, I can hear you. Satish, how are you?
Welcome, sir. Welcome. Nice to have you. Professor Nuri is from King Abdulaziz University, Jeddah. I have had that opportunity several times to visit that university. That's a state-of-the-art center in Saudi Arabia. And what a lovely time we had while operating there. Thank you, sir. Professor Nuri is a dedicated otologist besides his other interests in the ENT. And he's doing a lot of cochlear implant surgeries there. Probably he was amongst the people who started cochlear implant program in Saudi Arabia. Thank you, sir.
Okay, thank you for inviting me, Dr. Satish.
So Dr. Palaniappan has a question that very much anteriorly placed sigmoid sinus. Can we go for a subtotal petrosectomy?
Yes. Paramita, any difficult, anatomically challenging situation for cochlear implant can be turned into a simplest situation by a subtotal petrosectomy. And that is what I'm going to show you. Once you remove everything, keeping the labyrinth in you, everything is crystal clear in front of you. You just have to open the inner ear and implant. That's it. Then it's a simple child's play. That is the biggest advantage, exposure, identification of structures. Second is control of CSF leak, because you obliterate the entire cavity besides closing the cochleostomy. You can secure the implant much better because the cavity is obliterated. Your implant is not going to move here and there at all. So migration is not going to happen. That is one of the biggest advantage. And no future chance of infection coming in to this sterile zone. These are the biggest advantages. Once you do it properly, you can forget about it for future. Okay. Otherwise, imagine you have implanted and the infection settles in. Ashish, you have done a cochlear implant and 3 months later the child comes with a perforation and discharging air. What will you do? That is something a CI surgeon would never want. And that can be simply prevented by one and only thing, petrosectomy implantation.
Sir, so slowly are you shifting to subtotal petrosectomy for all kind of implants? Because
no,
only for complicated ones.
Situation. I mentioned in the slide the indication. All those high-risk patients towards developing CSOM, all malformations have a possibility of giving CSF leak. All difficult anatomical situations, only in that. In normal regular cochlea in a normal child, you don't need to do.
So Dr. NVK Mohan is asking that in previous CI with subtotal petrosectomy, what problems will you face if it's a failure while doing a
revision?
So far, touchwood, we didn't have any failure of subtotal petrosectomy in CI. So far.
In case if you have any issues, then would there be a problem with...
we can have issue of infection. Like you obliterate the fat, you can develop an infection in the fat.
Fat, yeah.
You may leave the cholesterol behind. Theoretically, there are so many complications which can happen to occur. Theoretically, but it depends upon your skills, how you execute the subtotal petrosectomy, which can prevent you from complications. How you obliterate the eustachian, that's what I'm going to show you. How you exentrate pericarotid cells, peritubal cells, perisinus cell, perijugular bulb cells, petrous apex cell. Each and every cell is important to address. And that is how you can prevent complications further.
Hi, Dr. Satish.
Sir, welcome.
Yeah, I just had a point. How can you prognosticate that this patient is going to develop CSOM and cholesteatoma?
Yes.
Because we are operating at a very young age and there may not be any congenital cholesteatoma.
Yes, yes. So in those group of patients, I mentioned that, sir. Let me put it again. Those are the high-risk situation. Children, you can segregate during your workup. See this. Patients with a eustachian tube dysfunction, developing otitis media and effusion again and again, particularly eosinophilic, have a severe history of allergy, history of recurrent sinusitis. The cleft palate patients, because they have a defect in the muscles controlling the eustachian tube function. So all these are patients who are prone to develop CSOM again and again. And secondly, those patients who have been operated for CSM earlier, you have no control over the physiology to prevent the CSM from coming back again. So those are high risk.
Satish, does the pneumatization of the mastoid give you an indication? A well-pneumatized mastoid could probably indicate a healthy middle ear?
Not really.
Not really. Okay.
Not really. Because, yes.
Hello.
Can
Dr. Satish.
yes.
Vishnu here. I know these cases of anomalies, I think again the outcomes are going to be based on the nerve, as we said already. Whether a nerve is normal or hypoplastic, and the outcomes depends on the nerve, presence of the nerve. And can I ask you another question?
Yes.
What is your experience in auditory dysynchrony or auditory, the neuropathy cases? Can you please share your experiences?
Yes. So neuropathy is again a challenging situation, and it is difficult to predict which patients are going to benefit, with an implant or not. But majority benefit, and implant is definitely indicated whatsoever is your workup for the neuropathy, by and large. Number two, if you do a E-BERA before, you can prognosticate a little better, because the patient responding to E-BERA, that electrical responses, is likely to respond to the electrical hearing later on as well. So you can predict, but by and large, those all patients are, indication for the implantation, and majority of them do very well. This slide is particularly kept for this particular situation today, what we are operating. See, these are the common inner ear malformation are likely to give CSF leak, CSF gusher. And in this situation, you have to be carefully prepared to do the subtotal petrojectomy and implantation. And secondly, the advantage is what we get in this present situation, because in malformed cochlea, sometimes your promontory is not that prominent to identify. Your round window may not be evident. Your facial recess is narrow, difficult to identify. In those situations, subtotal petrojectomy unveils everything open in front of you. So your identification of landmark is much better. Your control of CSF leak is much better. And overall, the high incidence of meningitis can be prevented. All those patients can give meningitis, can be taken care of by this. Because infection can be certainly prevented. Yes.
Satish?
Yes, Appa.
So generally, in the incidence of CSOM in general population is around 7 to 8% in India.
Yeah.
So can we expect the same?
Yeah, just a minute. Yes. Papa, can you hold for a minute?
Yeah.
Yeah, I'm going for the WhatsApp. You can continue your question now. Yes.
Yeah. So, hello.
Yes.
Yeah. So, can we expect the same incidence in implant patients also? So, do you mean in future we'll have suppose we've done around 1,000 cases of cochlear implant cases, out of which are 70 cases of CSO will develop and those become failures? Hello?
Yeah, he's just washing up, but your arithmetic is right. I think that is what he's trying to alert everybody about.
So there's an announcement for all the viewers who are watching. Thanks to Sun Pharma, they've arranged for a participation certificate. So you can just whenever you're registering in, there is a icon which is shown at the bottom. Click here to download the participation certificate, so you can get the certificate online.
Thank you.
Dr. Satish, hello.
Can
you?
Yes.
Yeah, I think he's about to scrub. I have hello.
Yes. You continue, sir.
Yes. Have you any of you have been doing the cochlear implant surgeons under local anesthesia for postlingual adults?
Yeah.
I haven't done it till now. I've done few postlingual, but not under local anesthesia.
Right. How about Dr. Satish?
Yes.
In postlingual adults, have you been doing cochlear implant surgery under local anesthesia, Satish?
Yes, one can do under local anesthesia as well.
Yes.
It can be done without any problem.
Right. we started the, cochlear implant surgery under local anesthesia for a patient who came from Saudi Arabia with bilateral hearing loss and with
Especially
one
for
lung.
Saudi Arabians.
No, he had only one lung.
Okay.
And, he had one lung, and my anesthetist said, doctor, it's risky to anesthetize. He was not very happy. That's how I started my, postlingual adults under local anesthesia. And we had done about 5 cases.
Yeah, a lot of
it
people
is
do
so-
this. It has been
Yes.
published several times, and it is
I
safe.
mean-
You can do it.
Yes, interesting thing, while you are doing NRT, neural response telemetry, the patient starts saying, I'm hearing.
Yeah.
It is so thrilling because he's postlingual. That's how we started with a single lung patient. And
Yeah.
afterwards, we have done about 5 cases. But of course, it's only possible in adults. We can't do it in children. And certainly, I think it's quite good, actually.
इधर आएगा, उधर आएगा.
नीचे पक्का.
Yes, sir. That's one can do it under local anesthesia.
Vaishali, sorry.
Are you getting the microscopic
Your,
picture now?
Down, na?
Yes,
sir,
we are
yes.
getting the
Yes, Satish.
Just from the implant.
Yes.
As per dummy, it is down.
Yes. So let me
I made
first show you what has been done until now by Dr. Pachauri. See the flap he has raised. This is the flap which is going to cover the implant. This is superiorly. Okay. And this is the implant bed which he has prepared for this metal implant. And this is for the lead to pass through to the ear. Can you see that?
Yes, sir. Yes.
Is picture good?
Yes.
So this is the flap he has developed, and this is the implant bed, and this is for the cable, this gutter for the cable to pass through. And then after that, he has just done this cortical mastectomy. Okay. I hope this part, what he has done so far, we have shown earlier.
Yes, sir. Yes.
Couple of times. So now the steps for the subtotal petrojectomy. Number 1, give me knife. Subtotal petrojectomy means we have to exenterate all possible air cells, number 1. And then we have to do a cul-de-sac closure. See this extraordinary canal? Can you see this extraordinary canal?
Yes,
sir. Yes.
I am opening the canal. See this?
Yes.
Especially with the knife. I'll tell you the reason why with the knife.
Sir, picture's frozen.
Yes, sir. The picture is frozen.
Okay, it's come back.
Yeah, come back.
See, I have divided the canal. This lateral part of the canal is skin. Can you see this?
Yes, sir. Yes.
This will take out to close the extraordinary canal. Okay? And all this medial skin, we have to remove. This part, why I did with the knife, so that I don't happen to leave any skin below. Can you see the distinction? Hello?
Yes,
sir. Yes.
This skin I am going to remove now. I have already,
Not come out. I
demarcated
usually make this thing.
this part. Part of the skin, we have to bring it out.
That we can make it wider.
So now this part will remove.
He make it straight.
First, let me
I
use the
usually that's why I made
extraordinary
it
canal
initially that
closure.
he will not do it.
The cul-de-sac closure will be the first,
That will make it wide. That will make it wide.
and you have
Just to hook that.
bring out the sleeve
board
of
will
the
help.
skin and put a non-absorbable
That will
over there,
the cable will not come out.
so that it doesn't fall back. Not only that, we will reinforce this closure with another layer below, so that it will never break. Post-operatively, this is one of the complications. If your cul-de-sac closure breaks, the cul-de-sac closure breaks, your skin can go inside and can lead to cholesteatoma. That is something disaster that you can't afford to have. So now we'll do the cul-de-sac closure. Asha, pakadna.
Satish sir,
Yes.
Soumitra here. Why? Hello.
Yes, Soumitra.
Sir, now that you're using the preferred electrode choice that you want for this particular patient, but can you elaborate on whether if the patient under a government scheme or a EDIF scheme, and if he has we don't have the choice of electrode, what precautions can we take while putting the electrode in?
Yeah.
And how can we seal the CSF?
Yes.
Because not always do we have the choice
Yes.
of the preferred electrode.
Yes, yes, you're right. So what you can do in that situation, first of all, the pre-curved electrodes are contraindicated, I would say.
Yes, yes.
One must not use the pre-curved electrodes. Always use the straight electrodes. Why I'm saying so? Because the pre-curved electrodes tend to come medially towards the modulus.
Right. Yes.
And they can easily pass into the intra-aortic meatus, which we are concerned here, not to go into the
Yes.
intra-aortic meatus. So always use the straight electrodes, number one. Straight array, simple straight array you can use from any company.
Right.
Number two, always make the inferior cochleostomy and
Right.
go along the lateral wall.
Right.
Always you're beginning from superior to inferior, from the fossa incudis to the inferior, cochleostomy, like superior to inferior, along the lateral wall to go along the lateral wall.
Right.
Once you go along the lateral wall,
I just made like this.
your electrode stays along the lateral wall, number one. Number two, you are not supposed to use a longer array. Use a shorter array.
Yes,
If you
yes.
use a longer array, it has a chance of slipping into the intra-aortic meatus.
Right.
So the third point is use a shorter array. You can use a 20 millimeter array, 18 millimeter array, 19 millimeter. Like today, most likely I'll be using 19 or 24.
Right.
So depending upon the situation, you should use. So the fourth one is important is use a circumferential ring electrode array.
Right.
The electrode should be full banded on both sides, because you don't know where the neural material is. You have to stimulate circumferentially.
You could have done this step.
That is fourth point.
If you want to
Okay.
to all the people.
Yes, yes.
Would you recommend putting tissue along with through the electrode when you put the electrode?
I will
seal?
show you.
Yeah.
You can pass the tissue along the electrode. The electrode array should pass through the tissue, so you can seal it effectively. The electrode which I am using today has a cork behind.
Right.
So that is a seal. So finally, I will push my tissue along with the seal to fix tightly at the cochleostomy.
Right. Right.
And more than that, we'll have a complete obliteration of the cavity.
Right.
Yes. So Dr. Dishit from Mangalore wants to know, can we calculate the cochlear duct length before that, how much we need to?
Yes, by and large you can. There is a formula, by and large, by means of a CT scan, from the site at the level of the round window to the farthest anterior part of the cochlea. That is something like 8 to 9 millimeter, and there is a formula like you calculate, multiply by 4.16, subtract something, divide something. I don't know exactly, but it is. You can approximately calculate. You can calculate through the MRI as well. See the absorbable stitches being used, sutures being used. Why? I don't want to remove the suture to give way. The skin may invert and the epithelial may ingrow. Let it be vicryl or something, a strong suture, non-absorbable. Let it be for, the vicryl takes almost more than 2 months to absorb completely. You can use more than the vicryl, you can use monofilament.
That's why it's
absorbable monofilament suture.
Yeah, I just wanted to add one another thing, but when you asked to clear duct length,
these child,
there are software
to develop gusher from other part also.
you can put the diagnosis called Otoplan.
4-5 years of some other gusher. Then
Otoplan is a there is a software available with Medel called Otoplan.
Yeah, can I make one point and then you ask?
Yeah, sure.
See, this was the closure. The important thing is, see this, the skin what we have pulled out should not be too out. It looks ugly. It should look like a depression. I transected the extra-aortic canal quite laterally, if you have noticed.
Yes, sir.
Had I transected more medially, I would have to pull more skin out. Then it would not result into a depression. Got my point?
Yes, sir.
And now see the second layer. This is the This is the conchal cartilage being sutured to the tragal cartilage to reinforce the first suture line. See now it is completely enclosed. See now?
Yes,
It
sir.
cannot break, the skin cannot come inside. This is a sort of almost guarantee once you reinforce from below with a second layer, and this is simple, the tragal cartilage being sutured to the conchal cartilage. So simple it is. Yes, you had some question. We can take now. This thing is over. This is this is cul-de-sac closure. We must know cul-de-sac closure is a very important step in lateral skull base surgery for many of the procedures. And today we'll have this again in a glomus jugular case, the paraganglioma. In the, I don't know, in a lower cranial now we will require a subtotal petrojectomy or not. Otherwise, we may need in that procedure as well.
Sir, Dr. Nageshwar Rao wants to know your experience in Down syndrome. Have you done cochlear implant in Down syndrome cases?
In any given syndrome, you can do. The Char syndrome, Down syndrome, Pendred syndrome, Lange syndrome, so many. The issue is, in Down syndrome, every has a negative and positive aspects. The issue is the mental ability is poor. The rehabilitation is very difficult. So you have to keep in mind all those things. Yes, mechanically putting the implant and giving hearing is not difficult. See now our cul-de-sac closure?
Yes, sir.
Yes, sir.
Retractor लगा ले. Suction रखना. Nice. Nice. मेरे को दे forceps. Yeah. Now I can see my medial level of the skin. Here I am little conscious because I should not leave any skin behind this closure. Can you see this?
Yeah.
Yes.
Still I am using the monopolar here to this lateral most part of the skin which I am removing separately. After implantation, your middle ear system is not going to be utilized at all. So there is no harm in removing this. Yeah. You are not giving patient any, loss or any kind of, damage. Drill guy. Now, in subtotal petrojectomy, as I said, we have to exenterate all cellularity. This is much bigger than a canal down mastectomy, you can say. Drill kidhar hai yaar?
Dr. Satish, this patient will not have any external auditory canal for rest of his life, isn't it?
Pardon?
No external auditory canal because we have closed the external auditory canal just at the entrance.
Completely closed.
Yeah. Will he develop a dimpling later on, or it will be just closed like this?
Yeah. That's why I told you to keep a dimple so that it should not look ugly.
Right.
That's
if the skin protrudes out, it will be. If the skin protrudes out, it will be very bad.
Yes. See this.
Yeah.
Exactly what you are saying. Chhodna. Let me show you again, sir. Can you see this?
Yeah.
This will settle down.
Yeah.
And will look like a depression here.
Yeah. So nobody can notice from outside at the first look.
Exactly.
Yeah. That's important.
ये करना और मेरे को retractor दे दो. Retractor दे दो. Now quickly I will exenterate the air cells now.
Yeah.
And see at the end of that the kind of exposure we'll have. The beauty is the exposure it provides.
For all these subtotal petrosectomy patients which you do, what is your follow-up radiology protocol? Do you go for radiology again? Just
already mentioned, yes.
Okay.
Already mentioned 1, 3, 5, 7, 10 years.
And you go for an MRI?
Not MRI. After the implant, we generally don't get the MRI done.
Yeah, that's true. But how would you rule
Though
out
nowadays all these implants are compatible with a
MRI?
1.5 Tesla MRI. With certain implants, here Medel is the leader in producing implants with rotatable magnets,
Rotatable magnets, yes, yes.
which are compatible even with a higher Tesla implant magnet.
Yeah, 3
So
Tesla.
if you use a synchrony, synchrony implant, it has a rotatable magnet, and you can use MRI, any strength MRI after that.
Yeah.
Similarly, the advanced bionic has come out with a, ultra 3D implant, which is again a rotatable magnet.
Rotatable magnet, yes. Yes. So I was telling you about this software called Autoplan by Medel, which now gives you a patient-specific plan. They can actually design electrodes according to the cochlear duct length, and because it has been perceived that different races have different cochlear duct length, and they have come up with something called Autoplan. We are doing a project them regarding stuff. So you can actually plan your electrodes. There has been many questions about it, but this is something which is there
But
with
if
them.
you want to know more about electrodes, we have here with us Ms. Shefali from Medel, who can really tell you details of the other, range of electrodes. Medel have the biggest range of electrodes.
Yes, yes, no doubt about it.
See, this is the anterior canal wall.
Yes.
Yes.
So most of the work has been done by Pachauri boss here. See, we have already made the bed for the implant. Yeah, इधर आके डालो पानी इधर कितना मिट्टी है. We have already a cul-de-sac closure done. After this, drilling, I will go to the cochlea directly and implant. See the incas in picture? Diamond.
Yes, yes.
Satish, please show us the stapes under high magnification at an appropriate time.
Yes, yes, Satish, definitely. Diamond. See, the idea is to excentrate all possible air cells. This is my Tegnan plate, which I am flushing. This is the sigmoid sinus behind, you can see.
Yes, yes.
I told you this patient doesn't have to pneumatize a mastoid. That is something welcome for us. More pneumatize the mastoid, more extensive would be a subtotal petrojectomy drilling.
Yeah.
More difficult to chase the cells. Sickle there. Is the picture good, Ashish?
Yes, sir.
Very good picture, Satish.
Yes.
Okay. Now, inside, we know the semicircular canals are not well developed in this patient. That is otherwise a very good landmark once you go inside. See, this is skeletonizing the sinus.
Yeah.
Sir, I think the video is frozen. Am I right, Kranti ma'am?
Yes, yes.
No, for me it's fine. No, it's functional. I think there will be issues in.
We are able to see Udbhav. It's all flawless.
It's all fine.
Ashish,
Yeah.
you wanted to see the footplate region, see something?
Yes.
Yeah, that soft tissue. Okay. Can you move, sir? Yes.
Cystic kind of a structure.
Yeah.
Can you see the cystic structure at the footplate?
Yes.
Oh,
yes, it is burning.
Amazing. Yes.
This is classical of IP1.
IP1.
Why don't you shoot a laser there later on? we will replicate Kranti's case.
Anyway, I am going to show you the shower.
So for these cases, as people who don't do subtotal petrosectomy for IP1 would say that first you do the implant and always inspect the stapes footplate area, and if you find
okay, if you do the implant by the posterior tympanotomy technique, whatever, you inspected the area like this, and you find the picture like this, what would you do now?
Very true. I do get your point of why.
I guess they probably just put some fat there and come back.
Yeah.
How will you prevent future meningitis? Tell me.
There is no argument. I think there is no question that this is the.
In the technique which we do, we lift up the tympanomeatal flap. So in such cases,
you are not minimizing.
No, not all.
You are not preventing the future possibility of meningitis. You know.
Yeah. Even if we, I do agree. Whatever you said about subtotal petrosectomy and the logic behind it. I was still, because I have seen people operating IP1 and they have not done petrosectomies routinely. So that's what I was just wondering that.
Yes, because I told you, I have given the answer to this.
Yeah.
Many cochlear implant surgeons are not convergent with the subtotal petrosectomy. That is the reason they consider this as a difficult operation. Diamond, you know. It is not difficult. If you can do cochlear implant, you can do this. It is not difficult. If you can do cochlear implant, you can do this. See, this is simple science. You have to. By such, stupid logics, one cannot, defy the evidence-based medicine. See the region of the round window.
Yes.
But this will not be normal. I will show you once I expose it. Like it will not be like a regular, exposure of the round window. I will show you.
Sir, will you at least a few lines about rotation of cochlea seen already, and how do you prepare for that?
Rotation.
Yeah,
you can see, you can very well predict on the pre-op, CT scan. I told you in rotation what happened, the round window is more posterior medial.
Yes.
And you can't exit it easily through the posterior tympanotomy. Either you mobilize the canal wall
or go transcanal
and do implant, or I told you one answer for everything, for any difficult anatomy. Any difficult anatomy related to the facial nerve, jugular bulb, carotid artery, whatever. Any difficult anatomy. Subtotal petrosectomy is the final resort. With an additional benefit. Because indirectly you are giving a guarantee to the patient of preventing the future infection.
Hello.
Yes.
Is this internationally?
Dr. Satish.
Yes.
Hello, Dr. Satish.
Yes, boss.
Dr. Vishnu.
Yes, boss.
In the year 2008, Mario Sana came in and he operated from my theatre at Care Hospitals in Hyderabad.
Yeah.
Were you there in that conference, ISO conference?
Mario Sana?
Yes, 2008. He operated from my theatre.
Okay.
Care Hospitals, Hyderabad. Taj Krishna was the conference venue.
Okay.
I don't know whether you were there. 2008 ISO conference, Indian Society of Otology.
Yeah, I remember Mario Sana came to ISO, but that was what I remember was Delhi.
No, that was second time.
I was there in the operation theatre all the time with him. Whenever
Right.
he has visited India, as far as I know, in Delhi, Mumbai, Bhubaneswar, everywhere.
Yeah, I mean, he came for the ISO conference, first time to Hyderabad and second time to Delhi.
Delhi.
And he did in my theatre cochlear implantation and glomus, and probably I think those are the two cases he did. I was just wondering whether you were there at the time. You said he popularized the subtotal peterectomy for these chronic ears.
Yes. He's the leader.
Yes.
Now you can
Sir,
see
there's
the.
a-
Yes, please.
Hello.
Yes.
Take the tensor tympan and
So Dr. Vasanti Anand is asking why transcanal approach was not considered.
Transcanal for this. That will be the least in my thinking if I choose out of some approaches. How will you control the CSF?
Dr. Vasanti has, if you can unmute, I think she presented one of her cases where she did, if she could unmute herself and say, is that Dr. Vasanti?
No, Dr. Vasanti is not there on the Zoom link.
Oh, okay.
Yeah.
All this cellularity, you have to spend a lot of time in drilling all these cells. I have seen the facial nerve anteriorly. I have seen the tensor tympani tendon. I have seen the Eustachian tube. I will show you.
I was Satish saying Hugo Fish used to take the tensor tympan and shove it into the eustachian tube orifice.
Yes.
Skeletonize, mobilize it, and in
That's
addition to the bone wax. Yeah.
जो भी हो मेरी इस प्रेम कहानी का
Pachauri sir, you need to mute your mic.
Or sing little better.
Yeah.
Oh my god, oh my god.
Let me know if I go out of the focus, please.
No, we are seeing the sinusoidal angle nicely.
Yes. See how it is flushed.
Yes.
Yeah.
And chakachak. My study is going to be chakachak.
Everywhere.
Yeah.
This patient has not developed the semicircular canals. Every malformation is a challenge. How you can simplify is categorizing properly into the particular category so that you can plan your surgical treatment, you can execute your surgical treatment properly. Like this patient, my radiology had made my all plans in my mind. Ashish?
Satish, Manoj has had to step out because some friend has had some accident.
Oh.
But he is watching us online.
I would like him to come. See this completely gone?
Yeah. Satish, Manoj has had to leave a little bit to go to a hospital for a friend.
Okay.
But later he's watching us online, but if he does come back, he would like to go over the CT scan with you.
Okay. See, this is the mastoid tip.
Yeah.
Yeah.
Though it is not cellular, but I will better remove this to rule out any possibility of any cells left here. Give me the monopolar. You can, there's a small tip you can remove in no time. Tooth forceps. अपना बंदा और बुला रहे हो. See, this is the mastoid tip, nibbler. टाइम बहुत लगाता है. ड्रिल. कामली को बुला लो.
So 30 are you able to go, darling?
Pardon? Diamond. These are marrow cells now.
Yeah.
See that?
Dr. Nadia wants to know, do you use facial lung monitor in these cases?
Pardon?
Facial lung monitor.
Yeah, if there is an anomaly and you feel like posing difficulty to you, better to use monitor. Here the first thing I saw on the CT scan was the facial nerve. So I didn't feel like, I saw that it is going normal. No point in cutting there. See, my posterior work is almost done.
Yeah.
This is our oval window and this is our tensor tympani canal.
Yes, sir. And sir, one more question. Like in this case, there are no semicircular canals. So what are your landmarks for identifying facial nerve?
Facial nerve, I have already seen. See the horizontal portion there.
Yeah.
Just above the oval window. Can't you see?
Yes, sir.
And then was the short process of incus is what he.
Yeah, I removed the incus. Below that was the, under that was the horizontal portion.
And sir, if possible, kindly show chorda tympani nerve. If you.
That is all gone, boss.
It's all gone.
I removed the ossicles.
This area of drilling is usually not done in cholesteatoma.
Yeah.
Of course, in glomus you have to do it, but so this is a tympanic bone again in atresia.
Yeah, this is hypotympanum,
very dense.
which I am uncovering. This is the facial, ridge. This is anterior thinning, funny. Anterior thinning of the facial ridge.
Yeah. You have to be careful about the jugular bulb there.
Yeah, lower down. Now, give me the bipolar first. See, our goal is to exentrate mucosa. Now, wherever you can't exentrate the mucosa, suppose, what you can do is, you can devitalize it. Or you find difficulty in exentrating mucosa, like for example here. See this. I will coagulate this, devitalize the mucosa and I can drill away this easily. That the eustachian tube, and I can see underneath the eustachian tube the prominence of the carotid artery.
Yeah.
That is my promontory.
Dr. Satish, same can be achieved by the diamond burr also.
Yes, you can. It would unnecessarily. Now this will give me a good field, sir, after bipolarization.
Yeah. Yeah.
See now.
Yeah, very clear.
Cut diamond. Now I will show you the. See the bulb, jugular bulb.
Yes, sir.
Yeah,
Yes.
Since I told you there was hardly any pneumatization going toward the petrous apex, I had shown you. Had this been me, this would be the site. If you have to go to the petrous apex from here, there is a straightforward infracochlear approach. What you need to do is skeletonize the jugular bulb, the cochlea, the carotid anteriorly, and in between them follow the cells, go anterosuperiorly towards the jugular. See the carotid artery prominence. Now I am drilling the lateral part of the Eustachian tube, to widen this orifice, because I want to clear all pericarotid, peritubal cells here.
It's 30 years old,
Okay.
See, this is my round window region. That is oval window region. Let me show you in magnification.
Yeah.
See
Oh
the
God.
glimpse of the foot plate, the suprastructure was there, little bit, this one. Could you see?
Such a crucial time.
Yeah. I want to see that footplate. Yeah.
Yeah.
See, that was a glimpse of the suprastructure.
Yeah, we can see that.
That is the round window region.
Yeah.
Very clear.
This is your facial now.
Yes.
Yeah. Nicely seen. Yeah.
Very nicely seen. Yeah.
And give me the circular knife there. See the little bit of the CSF started coming.
Show. Ah, yes.
Yes, very clear.
Yes, sir, yes.
Yes, very clear.
Yes, sir, yes.
We can see the movement of the stapes.
The gusher has started.
Yes, sir, it will come. See, this is processes cochleariformis.
Yeah.
And see anterior this, what is this? Canal for
tensor.
tensor tympani.
Tensor, yeah. So I think, Satish, that little bulging cyst was actually the mucosal reaction to a micro CSF.
Could be.
Yes.
Yes,
You can have a very good idea that what is going on behind.
Yes.
What's it?
What we were seeing on the CT scan and what we're seeing here, it is because when I think it
See,
chemically...
my entire planning was done through the imaging.
Yes. Imaging and your knowledge. Yeah. The fact that you say it is an endosteal disease, it is actually, that I think explains everything.
Two things we must understand. This is endosteal abnormality. IP3 is a periosteal abnormality.
Yes.
So I think that sort of summarizes the entire philosophy only.
Yes. This is because of the defective blood supply coming from the intra-auditory meatus.
Yeah. You said that, yeah.
And IP3 is because of the defective blood supply coming from the middle ear to the outer two layers.
Yeah. And there's a clear-cut CSF leak now from the foot plate.
That guy, Professor Senaroglu, has revolutionized this science.
Do you know him personally? Satish?
Ashish,
yeah,
we met him in Beijing actually for Asia Pacific Symposium on cochlear implants.
See now this area
that was, I think, about.
See now this area of the attic.
Tanaroglu. I think we in fact we recorded his talk also. Myself and yeah, basically on these anomalies only he gave a talk.
I'm interested in the relationship with the external canal atresia. If he has any insights into the embryology.
See now, this is the clearance in the attic.
Yes, nicely, yeah. Around the floor of the attic, yeah.
You have to, under magnification, accentuate all this cellularity. You have to skeletonize your structure, facial now. promontory. See this, completely skeletonized.
Yeah.
I
Have
have
you
left,
blue lined the cochlea also?
yeah, I have left
The promontory.
behind the critical area of the oval window and the round window, which I will handle in the hand. Now my focus is on a very, very critical area, that is eustachian tube carotid artery, peritubal and pericarotid cells. So first of that, in order to efficiently clog the eustachian tube, I will drill it laterally to widen it. The bony eustachian tube is 1 centimeter long. Okay. See this bony eustachian tube is being wide opened. Can you?
Yeah.
Stippies ले ले बोल रहा है. See this wide open.
That's because you have to remove as much mucosa from there also, right?
See this. See the prominence of the carotid artery below?
Yes, very nicely seen. Yes, yes.
See how close is the carotid to the.
Yes.
Now if you are doing a drill out procedure,
yes.
Ashish.
Yeah.
If you are doing a drill out procedure through the posterior arrow,
impossible. Yeah.
you can end up injuring the carotid artery.
Injuring. Yeah.
क्या हुआ? बंद क्यों हो गया? Yes, छोटा दे मेरे को. So my subtotal petrojectomy is going to finish in no time. हाँ, तो वो देखो circular. हाँ, circular.
If somebody was doing the conventional posterior tympanotomy approach,
yeah,
once they tried to insert through the round window, they would have landed up with gusher. Until then, they would have not.
Yes.
And then it's too late.
Yes. See now, this is the eustachian tube. यो रखना यार, दो जने खड़े हो. See the eustachian tube in full exposure.
Yes.
And the carotid in the floor. What I am doing, see this, widening. This way I am removing the pericarotid air cells. You know what happens if you don't excentrate, even if you block the eustachian tube, the fluid may go through these cells to the further part of the eustachian tube, and the patient can have still CS of rhinorrhea.
So that's sort of anterior to the carotid.
Yes, all around.
All around, yeah.
See, I have almost drilled out the bony eustachian tube. See, my carotid is in full control all around. And see now, at the end of the surgery, what I will do, I will clog this entire thing with the muscle and the bone wax. Chapter closed.
Free muscle you are saying, or the tensor you will done, or both?
Yes, along with the bone wax, bipolar. See how big is the eustachian tube orifice now?
Yeah.
Cauterizing the rest of the mucosa. See, no mucosa now. Patla dena, patla dena diamond. See the exposure.
Yeah.
It is not going to close by itself, Satish.
Pardon?
Dr. Satish, the eustachian tube, just by cauterization, it will not close by itself because of the, yeah.
Pardon, sir, I didn't get your question.
If you cauterize and put the bone dust in that and fill it with the bone wax and all that, it will be completely obliterated, isn't it?
That may not be efficient.
Okay.
See now,
So
completely drilled away the eustachian tube in depth.
Yeah.
Completely. See this mucosa
You have to remove
around
the mucosa also.
and the cells around the
that is
carotid.
important.
See, I can.
Yeah.
I am here. My section is the carotid.
Yeah. You don't want to leave any mucosa inside, isn't it?
Yes, yes.
That's important, Ashish. Yeah.
See, I'm working far anterior to the carotid now.
Yeah.
See, if you do this procedure half-hearted, you may invite a lot of problems.
Yeah.
Now it is completely, see the Eustachian tube completely saucerized.
Yeah.
Now, see this, the space between the carotid and the jugular bulb. Though it is not very pneumatized, fortunately. This area.
Yeah, there is some bony wedge, there's some name, I think.
Crotch.
Between the crotch, yeah. Okay.
See this? This is the angle between the. This is carotid.
Yeah.
This is jugular. This is cochlea, and this is the angle.
Yeah.
Had this been pneumatized, this pneumatization would go to petrous apex.
Petrous, that's the
This is my
intracochlear.
drill going to the petrous apex. There you have to go medial to the carotid. We'll keep in our upcoming webinars one of the case of petrous apex lesion
Cholesterol.
by the infracochlear approach. Okay? Now everything done?
Beautiful.
Nothing is left behind? See, no question of leaving epithelium for the matter. If anybody asks that one can leave the cholecystoma, I have no answer for such question. It cannot.
Now only the mucosa on the foot plate is remaining.
Yes, foot plate and round window side.
Yeah.
See, round window is bulging like this. See this?
Yes, very nice.
See the bulge of the round window?
Yeah.
Everything bulging means there is high pressure inside. Now I am coagulating this membrane. Side knife. Forceps. Forceps. Ashish.
Yeah, watching.
We have induced the next case, that is revision stp. Can you see?
Oh, wow, look at that guy.
See the tube?
Yes, absolutely. Fantastic.
See? And we
hold on, Satish. Let me take a video. 1 minute, hold on.
Ashish, this I knew from the radiology. This is going to be there.
Yeah.
रुकना वीडियो बना रहा
एक मिनट
एक
wow. Yeah, thanks.
And this we will close now because we are going to obliterate anyway.
Yeah.
See this? Now we come to our forceps. No more mucosa anywhere. No more skin anywhere. And now, give me the drill, patli dena. I will make this, enlarge this cochlear opening inferiorly. Okay? Now see, with this exposure, suppose you are doing this for any other region, not for IP1. With this exposure, what is the difficulty in cochlear spin implantation now? Now it's a cakewalk. Every single structure is in front of you. See this?
Yes, sir.
Yeah.
So it gives you the best opportunity to orient yourself, to identify the landmarks in difficult situations. See this inferior extension?
Hello, Satish Jain sir. Dr. Vasanti here.
Yes, madam.
sir, just one question. This foot plate area, you're going to cauterize and leave it, or you're going to seal it with muzzle or something?
Yeah, we are going to seal it. That's why we have this exposure.
He's going to put all fat all around. No?
I will use a piece of muscle over here.
Yeah.
Actually, I had done this IP1 earlier, discussed with Dr. Senaroglu. I did it through a transcanal approach. That was the reason I was just asking why you didn't want to think.
How did you manage the gusher in that case?
Actually, we could seal it was a good wide exposure. I mean, we're used to going in transcanal, so yes, I've compromised maybe because this gives you a bigger and wider exposure, but I could do it with the transcanal technique. The foot plate area, we have to drill it wider open, put a muzzle seal and cochleostoma with fibrin glue. And I didn't use a metal electrode because I feel metal is half banded. So we had used REST cochlear.
Okay.
I mean, sealed well with fibrin. Yes, it was a big task, compromised space. Because I had not seen the
endosteum.
Another option.
Ashish, see the endosteum.
Yes, very nicely. It is pulsating. You can see now the round window and.
You can imagine the pressure.
Yes. Vasanthi will get back to you discussion wise. Wow. Feel the entire.
We're making a bigger cochleostomy in these cases so that it can plug it better.
Always.
Yeah.
That concept of a smaller cochleostomy to reduce the leak.
Yeah,
no more.
wrong.
See, I am more and more expanding it inferiorly because I want to place my implant along the edge.
Sorry, Satish, say it again. I missed that sentence.
I want to insert my implant along the edge, along the periphery. See inside.
Yeah.
Yes. Beautiful.
See in the midline that whitish structure?
Yeah.
Towards the cochlear base, if you push your electrode, it is going to go inside the intra-auditory meatus. That is, see medially now, that is the intra-auditory meatus. See that?
Yes. Beautiful.
Can you see the intra-auditory meatus?
Moving a lot. So you could
Zoom.
We can see it.
Yeah, see medially.
Right from where it is coming. Yes,
Yeah.
medially.
See medially, that is intra-auditory meatus. So clear?
Yeah.
Yes.
Super.
But see where I am going to implant, not there. I have completely changed my direction now. See, I will go here along the periphery here. See that?
Centralize, sir.
See that? I will show you again and again. This is the crux. See this? See this? This is the periphery. Hello?
Yeah.
Where I am going to go?
Yes.
Where I am going to go? Now see, under vision I am changing the direction. Where was my periphery and where is the direction of the intra-auditory meatus? Can you see?
Yeah. It's almost, I can see the groove of the tympanic nerve. It's like that anterior.
And see, my implant is going to go in this direction. X-ray manga. X-ray. Fast. So now we are ready for the implantation. Can you see?
Yes.
And this also makes the point about the drill out procedures being so easy with this approach.
Yes. You have all controls, all critical structures around are in your control. Now I will harvest some periosteum, some muscle, all that. See the wider opening.
You have to centralize.
It's out of focus, yeah.
See the wider opening.
Yes.
And see my direction inferiorly. So that will be absolutely right angle from the direction of the intra-auditory meatus.
Yes, sir.
Okay.
Yeah, can you pass yellow endoscope to show us the interior?
Pardon?
No, you are a greedy man.
Just yellow endoscope. Can we look into the lumen?
Yes, I can show.
Infection at this point.
Yeah, la silentoscope la.
डालेंगे सर.
Now let me harvest some. See, let it drain. See the CSF.
Yeah.
You don't have to rush for it. Sometimes the gusher is even much bigger than this. Just wait for 10-20 minutes. You don't fall into all that monkey business of bringing the head up, down, mannitol. Nothing is required. Let it.
You just wait.
You will have a false impression of a lower pressure, and that it may give up later. Give way later. So don't do all that. Nice. One tooth. Yes. Now I will harvest some muscle. Muscle is a tough material. It swells up, you know. It swells up a little bit and gives a better, reinforcement.
Dr. Satish, while harvesting muscle, you can leave some dexamethasone there, I think, in the cavity. Dexamethasone.
Yeah, dexamethasone there. Dexamethasone, no?
Sir, will you discuss your antibiotic protocol also?
Prophylactic, yes, should give for a few days. Because here you need prophylactic, nothing else. You can give...
Do you give them antibiotics post-operatively also?
Yes, 100%. So, इसमें छेद करना है. चले, इसमें छेद करना है. बीच में.
That is a dexamethasone soaked gel foam that is kept, Vishnu.
Yes.
Good.
This is for the foot plate, and that was for the cochleostomy. Okay? इस लाइन में डाल. इस लाइन में डाल दे. Fat ready? जल्दी. Get the fat ready. Glue ready?
The eustachian tube block करने का रहेगा ना?
करेंगे ना अभी. Gauge फीस दो. Clean gauge. Clean wet gauge.
Ashish, do you keep a checklist so that you don't forget?
Pardon, sir?
I think, do you keep a checklist on the board that you don't forget to say obliterate the eustachian tube or something, some steps?
So the eustachian tube is the most important issue.
Yeah.
If you don't obliterate, you are gone.
Yes. Because now the whole attention is about the cochleostomy and all that.
Yes, sir. I am waiting for the things to be lined up, the glue, the fat, the muscle, the implant being opened up, everything.
And in the meantime, the flow to stabilize, isn't it?
Pardon?
In the meantime, the flow to stabilize.
Yes, flow will stabilize. I want 5 to 10 minutes for that as well.
Right.
Knife, no tooth. Bone wax, ready?
What a beautiful.
Honestly, had I not seen your temporal bone dissection of the cochlea, I would not have been so well oriented. The way it is.
Yeah.
I mean, you really.
I really want
that was the changing point. After 30 years, I didn't know where the apex of the cochlea actually lies.
Third है ये. Yeah, the cochlear anatomy is very important to understand. The things become so easy then.
Yeah.
Now this is the time before I open up the implant. Sir, eustachian tube I will close after the implantation.
Implantation, yeah.
The reason is I don't want the CSF to seep there.
Yeah.
It will not allow my bone wax to stick.
Yeah.
Going to use the bone wax.
That is a reinforcement. See, I tell you, Region, that is reinforcement. I will be using the muscle to close the eustachian tube forceps, and I want that muscle to remain in place for some time. The muscle will scar and block the eustachian tube like anything.
So just one question, because in implant surgeries, bone wax is something which might act of automotive. We had a case of and when doing my senior residency, we had to revise a patient in which we had used bone wax.
Yes, absolutely. I tell you the
No,
reason
that
why.
probably that's the round window, Kranti,
Madam,
when it is in contact with the implant.
No, sir. Even if it was just
Let
it was not used for that. It was
Madam,
used to.
let me tell you, you are right, but where the bone wax should not be used, close to the infective areas. Close to the infective areas, here the bone wax is being used in the most sterilized compartment. If you are doing a middle ear surgery or any chronic ear surgery and using bone wax in relation to the infection, you are gone. Then you will have to do what you did.
So can you use bone dust instead, just to pack it off? You put a muscle. You put
Yes,
bone
you can use the bone dust also. See now the gusher have come down.
Yeah.
Things are much better in control. Our bone dust I have cleared, hemostasis I have seen, everything clear.
bone pate.
Dr. Satish, exactly the same thing what Dr. Kranti asked about the bone pate versus bone wax.
Yeah, bone pate you can make where you want the future bone.
Okay.
That is
Here I don't want. I want a complete obliteration.
Yeah, that is one of the options. Yeah, दिखाओ उधर clear आ रहा है क्या? Yeah, I'm using the silent endoscope now. Hello?
Not clear.
Yes, sir. Yes.
I think Satish said OT mein somebody else has started this on another Zoom channel and that's equal.
See,
Okay,
I'm
okay,
going
go
in the
in.
cochleostomy.
Go.
Yeah.
Yeah.
See, that is intra-aortic meatus.
Yes,
Yeah.
very nicely seen.
Wonderful, sir. Yes.
And see, that is the periphery around where I want my electrode. And for that, I want my electrode to pass along the periphery. See, in the center is the intra-aortic meatus. So I will keep my electrode away from the intra-aortic meatus. Okay?
Yes.
See the peripheral structure around inside the cochlea.
Yeah, yeah.
It's like an open tube. There is no intrascalar structures.
No partitions, yeah.
So now, suppose if you are using a curved array, pre-curved array, and if it happens to enter the intra-aortic meatus, it's a disaster. Suppose you have done it and it has entered the intra-aortic meatus. Now what to do? Cut the array at the outer wall of the cochlea and leave it in place rather than pulling it out. Because if you try to pull out that pre-curved array from the intra-aortic meatus, it may ruin all the nerves there. So don't do. Open up the next implant and put in the periphery, leave that array wherever it is. Is that clear?
Yes,
Yeah.
sir.
Yes.
Yeah, Dr. Satish, if there is no option, you have to leave the stillet.
Pardon?
You have to leave the stillet in place. That's what some studies says. I mean, we have straight array easily available. That's not an issue at all.
Yeah, but ready?
Suppose if you have used any contour electrode, then you are supposed to leave the stillet in place.
Yes.
But we have plenty of straight arrays
You can't
available.
afford to do anything in the intra-aortic meatus prophylactically.
Yes.
If you try to push any stilate or anything inside, you may injure the nerves.
Yeah, the straight arrays are much cheaper than contour. They are available with every company.
Sir, post-operatively, do you put them on lumbar? Hello?
Pardon?
Sir, post-operatively, do you put them on lumbar drain or mannitol diamox?
Lumbar drain not required, madam.
And diamox?
Practically, once you seal these two openings thoroughly and obliterate the cavity, you don't need anything else. Lumbar drain unnecessarily, why? That is, that's a good idea to divert the pressure so that the seal matures. But that is another avenue to introduce infection unnecessarily. It should be avoided as much as possible.
So we don't even think of diamox or mannitol, sir?
Nothing. I tell you, once you seal it perfectly, forget about it.
No. During the recovery, there is some cough or something, there is raised pressure. Are there chances that the leak starts and becomes a fistula?
Let me show you my closer and we'll take up your question again.
Okay, sir.
हाँ बंद मत करना अब वो उसमें जो मैंने पहले दिया था ना उसमें छेद कर वो इलेक्ट्रोड जाएगा उसके थ्रू या कैन यू गिव मी द इम्प्लांट प्लीज सो नाउ वी आर ओपनिंग द इम्प्लांट
Please focus a bit.
Hello?
It's out of focus, Dr. Satish. Yeah.
Yes. Oh, धागा नहीं निकाला क्या इसमें? जल्दी आ जाए इधर। उसको छोड़ दे। इसमें इम्प्लांट डालेंगे। इसको उधर रख। नहीं यहाँ सलाइन में रखो। लाओ वो लाओ प्रोलीन। 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 You should have kept the thread inside ना। चलो जल्दी see now the fixation of the implant जल्दी जल्दी don't waste time guru Vertigo is unusual. Common cavity, yes. The question is the possibility of post-operative vertigo. Since this is a compensated vestibular system, we don't expect any more stimulation, and more than that, that can happen in a common cavity more, because that can stimulate the vestibular end organs. Here we are purely into the cochlea.
Yeah.
Common cavity
answers your question. Yeah.
Ashish,
yeah,
we have devised a new technique for the common cavity. What we do, common cavity is like nothing else like a pot, the entire thing. So we make one opening, parallel to that we make two more openings. So through one, and we want, because we want the electrode to lie on the periphery. So what we do, we push the electrode from one opening,
yes,
and pull it out through the other opening.
Okay, I understood.
And then it becomes a loop. That you push the loop, it will go to the periphery. And third loop is to put your silo endoscope so that you can see under vision.
Wow.
So that is the technique for common cavity. Common cavity is almost always a CSF gusher, because that's a very early anatomical abnormality in the 4th week. The CSF, the intra-auditory meatus, is directly in continuation with the inner ear. And yes, can you see the implant being fixed?
Yes, sir. Sir, Dr. Vijay Chauriya from Indore wants to know what instruction do you give to anesthesia people while having this kind of CSF gusher?
Nothing. That's why I told you don't to fall into any monkey business.
Yeah.
Don't do anything. Let it drain, wait for 10-15 minutes and close it efficiently. Nothing works.
Yes, sir.
Some people give mannitol, Diamox, head up, down, this and that, steroid. Yes, steroid you can give. And lumbar drain, nothing. You have to face the situation of a gusher. You can't, manipulate it.
For anchoring the implants, are you still using proline or shifted to ethibond?
Proline, madam. What I will make sure, I will invert this proline down, because I am scared this proline should not come laterally and pierce into the skin. See this?
Yes, that's very, very important.
This is a very important step to invert this proline in. What was the question from Monish? Not really. I tell you, all these, the measurements people do, the Diamox, lumbar drain, mannitol, they have a fear of CSF leak, facing the CSF leak.
Yeah.
CSF leak, being ENT skull base, you have to face it every day and night. Don't you have to get away from it? And the best way is to control in the normal condition rather than in the false stimulated, low pressure conditions.
Yeah. Correct. Yeah.
If you try to deal with in a false condition where you reduce the pressure and seal it, it may give way. So don't invite problems. Nothing is required.
Actually, sir, by looking at the flow, people get tense that something wrong is there, and so we start doing this and that thing.
See what I've done? I've inverted inside and pushed some Surgy cell to induce fibrosis over there. That's it.
Yes.
See the CSF which is filled up.
Yeah.
Now, lastly, the implant. इसमें से डाल दो उसको. वो देना. वो पिरो के रखा था. And the implant, the crux is, somebody asked earlier, I tell you again, direct it inferiorly. See how much inferiorly I extended my opening.
Yeah.
I will be miles away, you can say, from the intraocular meatus by this way.
Yeah.
Because your direction is altogether different. Your array is a smaller one. I am not going to have more than 1 ton. Because the second ton may go inside the intraocular meatus. Okay?
Yes, sir. Sir, Dr. Ram Babu wants to know if while preparing implant bed, if a dura get injured or tear, how do we manage?
Injured what?
Sir, dura, while making the bed, implant bed.
You manage like any other injury to the dura.
Yeah.
You have to reinforce it. If it is a small leak, you can bipolarize, you can place some fat or fascia, glue anything, like any other injury. Yeah. See what we are struggling now, we are,
holding,
passing this implant through the hole in the muscle.
Muscle.
The implant is a very soft thing. You can't put pressure over there on the electrodes. Now see, I have loaded this muscle on the implant. Can you see?
Yes,
this
sir.
one?
Yes.
Yeah.
See this? And now lastly is this insertion, and it is the direction of the insertion which is most important, Can you see the stopper at the end of the implant?
Yeah.
This
Nicely
stopper.
seen. Yeah.
I will snugly push my periosteum at the level of the stopper.
Muzzle periosteum.
See the straight array.
Yeah.
What I want this to go inferiorly. See this. I want to direct it inferiorly along the lateral wall. See this, pakadna. See this along the lateral wall. Okay, picture. Yes. See my direction?
Yes.
Yes, sir. Yes.
Yes. Hold kar. Now I will bring my muscle all the way. छोड़ना एक बार छोड़ थोड़ा सा वापस पकड़ना छोड़ दे यस सी माय मसल अच्छा हटा ये एक हटा दिखने दे what I want to show is my stopper. This is my level of the stopper, you can see now. See this?
Yeah, we can see it. Yes.
And then now, pick there.
While advancing, the feel will tell you that you are inferiorly, isn't it?
Pardon?
While advancing, number one, the direction, and second, the feel will tell you that you are in the right area.
Yes, my direction was inferior.
Yeah. And the feeling of while you are pushing, the ease with which it is going, that is also important.
Pardon?
The ease with which it is going in,
Sir,
that is also important.
Here you have full ease. There is nothing inside the cochlea.
Yeah. Yeah, we have seen that through the yellow.
No, it can easily go into the intrauditory matters also. The ease is not the criteria.
Yeah, how to prevent that? Only the direction?
Only the direction.
Only the direction.
Exposure. The exposure that he did by drilling, I think that is the key.
Right.
Will you do Siam? Will you do a Siam intra?
Yeah, second way is under fluoroscopy. See now, this part is the other one. Now what I am doing is plugging the
foot plate. Oval window actually, not the
big there. Yes.
Yeah.
Going into the vestibule.
See now, boss.
Yeah, fantastic.
No leak at all.
Yeah, excellent.
Yes.
See my stopper.
Yes, yes.
My implant array is 2 millimeters from the stopper.
Yes.
Yes.
See my Eustachian tube?
Yes, yes.
Yes.
This is to induce thick fibrosis. See this big area.
Yeah.
No, they bone wax. Bone wax. Bone wax.
Centralized karo. Eustachian tube is not seen.
See, I am not putting anything over the seal what I have placed. Not a single drop coming. See that?
Yeah.
Yeah, yeah.
Excellent closure, sir.
They are.
So fibrin glue you don't want to consider?
I will. Let me wait in the real condition if the CSF is coming. We should not be, terrified with the CSF and go in hesitation fast and create the false situation.
Yeah.
Now,
Dr. Satish, just one thing at this stage, how can you be sure that I am not in the internal auditory canal?
Yes. First is your entry along the lateral wall, number one.
Yeah.
Second is, if you really want to see under vision, if you are not sure, you can take the help of fluoroscopy.
Okay, C-arm you can use.
Third is, we'll take the X-ray, intraoperative.
Okay. Yeah.
Still we can change everything. So I will not put the glue until my X-ray comes.
Okay. So you mean to say you take the X-rays routinely?
Pardon?
Or you rely on your experience of putting it?
Yes. See now.
Yeah. This is the bone wax you have applied.
Chapter closed.
Yeah.
One source of infection is this. The other source of infection is external canal, which we have, here we have closed in 2 layers. See this chapter closed.
Yeah.
Now this is all mucosa cells excentrated. This is the most, I would say, sterile area. And this would be covered by the fat which we always, put in the,
lateral skull base,
rifampicin solution and then place it.
Yeah.
So let's check the response from the electrode first, if it comes.
Yeah.
Wait. Give me the gauze. वो देना connect करने को magnet. Madam, NRT. See, I am leaving a wet gauze over it. See, besides that plug, I didn't use anything.
Yes.
Close the leak. That is good enough, I believe. And more than that, once everything is perfect, वो भी लगा ले जैसे X-ray. X-ray ले लेते इधर पहले. Yeah. So in next 5 to 10 minutes, we'll do NRT. We'll take an X-ray, and then I will put the glue, and then I will put the final fat for the obliteration.
Yeah.
ले X-ray फटाफट.
Do you take X-ray routinely, Dr. Satish?
Pardon?
Do you take X-rays routinely or rely on your experience or the response?
Mostly, we take the X-ray as a routine, not intraoperatively always. In a other situation, we take post for the documentation. But in difficult situation, when you are not very sure, better take it operatively for final decision making.
Yeah. Yeah.
Because anything goes wrong, I can still change right now.
Yes. True.
लगा दिया? Connect? Excellent. Okay, the impedance is good. Hello?
Yeah.
Impedance is good. These are 24 electrodes, 12 pairs of electrode opposite to each other, pairs at a definite spacing, and this area in the short array. This is how these are called full band electrodes. अरे वो हट गया यार. करो.
You say this is Dr. Ravindra has made these two cartoons.
Yes, yes.
Yeah, did you? Thank you, Ravindra. Great job.
We asked him half an hour back, just make something. He made it within half an hour.
Brilliant. You're fabulous with your work and imagination. Congratulations.
It's all Rajeev directing now.
No, Ravindra.
Ravindra Bansal has created this.
Okay.
And I actually like what his WhatsApp motto says. काम करो क्या है लिखा हुआ है?
काम करो मस्त रहो.
मस्त रहो. I like that.
Thank you, sir. Thank you for giving me opportunity.
Thank you, Dr. Bansal. Thank you for being here.
More than that, he's an amazing surgeon as well.
Yeah, he's a very...
I know him. He does all extensive procedures.
He's a leading surgeon of Gwalior as well as MP.
Yes, he's a...
In our conference, in our you can say, book, his cartoons were very famous.
Ah, okay.
Ashish? Yeah. I hope this technique is very well understood by everyone.
Yes, of course, absolutely.
And the concept, it is not difficult. We have to execute it properly.
No, very sound scientific basis. It begins there, I think. Because I think what you showed that the footplate can be the weak point no matter what you do to the round window.
View सही है ना?
Dr. Ashish and Satish, can I say that in future this subtotal petrosectomy be a feature because people will not like to take any chance of infection at a later age?
I think so, absolutely. In
because
that, there will be lesser indications for the routine posterior tympanotomy and probably...
Yeah, because if you are doing a CI surgery at the age of 1 or 2 or 5, you cannot be sure that rest of his life he will not develop a CSO or a Eustachian dysfunction, isn't it?
Yes, true.
So this could be a future, you know.
No, kuch nahi, impedance badhiya.
Of course, one has to learn the technique properly and do it. It's very, in Dr. Satish's hand, it seems very easy, like anybody can do it, but actually it takes guts to do all this.
Actually, anybody doing a good open cavity, just another, really
right.
Yeah, it is
drilling of the hypotympanum, nothing really.
It is the most simplified version, I tell you, because once you expose, it's a child's play. Everything is in front of you.
And these are normal, healthy mastoids, actually, so it's that much easier.
So don't expect a lot of bleeding or other things. And if you
No, not at all. I don't think the surgical challenge of a subtotal period. It is the application of that technique.
Right.
And why do you do it? I think that is more important.
Just follow the anatomy and it is very easy in a way,
And that too in an infant or child is not that.
Yeah, correct.
Yeah, right.
Undeceased, very healthy. So
that's right.
One more thing came to my mind about the coccia is like Satish, you are using a particular brand, others are using a particular brand.
Not
Is
really.
there something that one should get used to a particular type of CI or you do it according to situation?
Sir,
And if so, what are they?
I use all brands with
Yeah.
equal efficacy, no
Mhm.
predilection to any particular brand, but yes,
Okay.
sometime to certain particular electrodes.
Okay.
Like in such situation, I would always prefer metal foam electrodes.
Yeah.
So depending upon the situation, most of the
Okay.
time in regular
So
situation,
you are
any brand,
open-minded and depending on the situation, you choose your electrodes and the types of instrument, isn't
our
it?
audiologist Ranju gives patient all options. She only does all this, and
Okay.
then patient finally chooses.
Okay. Thank you.
he's not married to any company.
No, it's not married. I think once you are get used to using a particular type of thing, because all these have got little bit variations in. So that's what I asked. You want to be very happy with one particular type, then you don't change or something like that.
Medal is a huge range of electrodes.
Yeah.
Biggest range,
Mhm.
right from the largest electrode to the smallest one.
Yeah.
And these electrodes are sometimes very important. Different electrodes. Like if I'm doing a ossified cochlea, I would prefer to use a split electrode. Split in 2 electrode arrays, split in 3 electrode arrays. That is important so that I can pass in different drill outs to stimulate different nerve endings. So
Okay.
maximum electrode I can insert to stimulate.
Yeah.
Depending upon the situation, you have to choose. The same implant is or same electrode is not
Yes, I got your
going to work for every situation.
Yes.
So our next case is ready. Revision step each, and you will be free here from 5 minutes. I am waiting for this thing to finish. Are you open? Left side. एक्सरे लेता हूँ. जल्दी मंगा एक्सरे.
Dr. Bishwajit Gogoi wants to know any role of C-arm in this case after.
C-arm can be useful, though it is additional exposure of the radiation. But yes, you can do this insertion real time in C-arm.
Yes, sir.
Real time.
Yeah. Probably Kranti regularly, no?
Hello? Yeah?
Dr. Kranti, you probably use C-arm regularly?
No, not for my releases, sir. Only when sometimes you are not getting NRT proper, then it's better to confirm it using a C-arm. So that is already available in our OT and we can easily use it
Right.
in the OT complex. Yeah. In routine cases, when you're sure about your
There is no need for,
your NRT normal, why to expose them to radiation?
Yeah, true.
Meantime, we have a couple of minutes for the questions, if anybody.
We have discussed, I think, most of the things in detail.
I think we have covered almost all the questions, sir.
Yes, sir. Yes,
So,
sir.
to cover the variety in the future webinars, we'll keep drill out, we'll keep IP3, we will keep common cavity, and more difficult situations.
Which one you find the most difficult, sir? Drill out or? As per
IP3.
you, which is the most
IP3. IP3, you know what happens? In this, the cochlear end of the extraordinary canal, anterolateral, because posterolaterally is the vestibule. In IP3, the cochlea is directly on the lateral end of the canal, and the interscalar septa are intact, quite thick. There is no modulus. So passing the electrode on the periphery is a big challenge, because it tends to fall into the intra-aortic canal by default.
Yeah.
So technically that is more challenging.
Nerve status, sir, left side. Hello.
Hello?
Hello.
Yes?
Sir, on the left side you had hypoplastic cochlea. How
Right
was
side.
the nerve?
Right side. On the left side, yes.
Was if the nerve was better, our implantation on the left would have given a better outcome?
I don't think. In the left side, in the hypoplastic small cochlea, you will not be able to insert much electrodes and stimulate that much as compared to this. This is a normal size cochlea.
But the nerve is thin here, sir. It's
No, it is
hypoplastic nerve
almost
here.
similar. Almost similar.
Both are okay.
Fine.
And one more question, sir.
Dr. Satish, that takes me to a general question. Which side to be selected?
Pardon?
Which side to be implanted first?
Which
Left
side?
or right? Yeah. What are the criteria and what are the guidelines?
Yeah, that's what I discussed in the beginning.
Okay. Yeah.
That's why
I heard that. Anything else? Since this question has come, so I thought it.
So now we got the X-ray and we have a good implant curvature inside the cochlea. Yeah, can we show through the...
Okay.
How come? How will you show? Okay, show that. Show on the camera. So we got the X-ray and finally we are closing it now. Hello?
Yes, sir.
I will show you X-ray.
So Dr. Bharti madam was asking, she asked this before also, that if on follow-up if there is cholesteatoma observed, then what will we do, sir?
Sorry, picture. In follow-up, first of all,
उसको लैपटॉप में
all
लोड कर
these
डालो.
are hypothetical questions. Yeah. See, focus.
Yeah. We can see it. Yes.
No, focus inside. That is not the curvature. Inside. That is the outer one. What you are seeing. Little focus. Or boss.
There is a glare basically.
Ask him to get a printout, not on mobile.
No, उसको इस पे ट्रांसफर करो ना लैपटॉप पे.
हाँ, लैपटॉप पे या.
Printout. हटाओ. It's not clear ना. ये इधर focus करो interiorly. See, that is the outer curvature, the curling of the cable, and as it comes inside, you can see the round curve. Yes.
Yes.
I would like to focus it. Get a printout. Yeah. Tilt the mobile. I think tilt. Now, yeah. Can you see inside a little bit better now?
Yeah.
Yes, we can see. Yeah.
Yes, boss. Very clear.
There it is, curling, rounded. What I wanted to see, that it should not go straight in the intra-aortic meatus. It should go to the wall and curve. That is what required. That is a simple trick required for this implant to function. If this implant is on the outer wall, in the intra-aortic meatus, finished. Now final closure. Glue. छोटे टुकड़े करे fat. Can you give this picture, please? Microscopic picture. Microscopic. Suction. First thing I want suction यार. बोलना पड़ता है क्या? Are you getting the picture?
Yes, yes.
Yes, yes, clearly.
Now see there inside the middle ear, absolutely dry.
Yeah.
Could you see?
Yes.
Not a single micro drop.
Yes, yes, absolutely.
See this, absolutely dry.
Yeah.
So now give me the glue first. See, this sealing is most important. क्या दिख रहा?
ఇది పోయింది బ్యాక్ అయిపోయింది వేరే ఉన్నాయి తీసిస్తావా ఇయర్ వేరే ఉన్నాయి లోపలే ఉంది దాని లోపల బయట ఉంది ఇక్కడ నేను వస్తాను
Okay, give me. Hello? Hello?
Yes, sir. Yes.
Hello?
Yes, sir. We are with you.
Hello?
Hello?
Yes, Dr. Satish, we are with you.
His audio is not with him.
Yeah.
अरे ये क्या कर रहा है भाई?
Hello? पकड़ना.
Yes, sir.
Hello? Hi.
Hello?
Yes, yes, we can listen you.
I removed it again. See this. Hello?
Why?
Pachauri was not happy that it should get a complete curvature.
Just asking.
Oh.
Yeah. Okay. So next Sunday you'll come. Of course, there are only 3 cases. One stapes, one cochlear implant, and then microshare.
See now again.
No? So we'll see. We'll try to. I'll definitely call you on this. Yeah, but let me ask this question now. Yeah.
We can see.
I want to show him a full curvature. You are not happy. So,
Sir, sir, please center the.
See this. No. See, I am going along the periphery.
Centralize a bit, boss.
Sir, can you center, sir?
Yeah.
Okay. Yes, now?
Not
Rajeev
yet.
is trying to
No, sir.
Not getting?
Sir, please center.
Yeah, it is okay now.
Very good.
See now my electrode going along the wall. Can you see?
Yes.
Yes. See now it is sticking very well. Give me the. I have not taken the soft tissue along it. Hey, पकड़ दिखला मत. It should be lateral. रुकना, छोड़ना.
Yes.
रुक जाओ, पकड़ो इसको. यहाँ पकड़ लो. Yes. What I can see now for you, I can show you now through the endoscope where it is. Okay?
Okay.
Give me again. Just for everyone's full satisfaction.
To be doubly sure, huh?
Give me quick. यार क्या जल्दी लेके बा?
Satish, meantime,
क्या जल्दी? हाँ, yes.
Ask the question.
Yeah.
The reason why you soak your abdominal fat in rifampicin.
Yeah, this is to prevent, airborne Staph aureus infection. Because the fat is something, on the slightest infection, it may autolyze.
So as soon as you harvest it, you put it in the rifampicin solution.
Yes. Yes. So I don't want, and it is the Staph aureus which is almost always responsible. वहीं पकड़ा हुआ ना? Section.
So he has complimented you, by the way, on the subtotal petrosectomy and the entire case.
What I want to show, my implant is lying at the periphery. This is what I want to show you.
Yes.
Yeah.
Just a minute. I will give you a better picture.
Suction.
See, in the middle is the intraocular meatus.
Yeah, we could see it.
Just a minute. किधर गया? Now see the implant at the periphery.
Not sure.
I could see the glimpse. Let me clear it. I could see it again.
There is too much glare, so actually not visible.
Now see.
Now we can see the intraocular.
Yeah, now it is visible. Yeah, yeah.
See, pulsations are coming from the center and implant is to the periphery. Can you see very clear?
Yeah. We can.
Very clear. See along
Yeah,
the
yeah.
wall.
Now it is clear.
We
Very
can
clear.
see that the implant is not in the intraocular.
Yeah, yeah.
Yeah, that's what. See, there cannot be a better evidence than this. ऐसे पकड़े रखो.
Yes, that's
Yeah.
right.
No. See, my assistant is holding the implant. Give me the. नहीं वो दे muscle. तू हिलना नहीं मत. I want him to keep it like this. Okay? बड़ा दे. Bigger one.
Is it seen?
Pardon? See, he is holding the array in position.
Not visible.
We can't see you, sir.
Yeah, not visible.
और क्या हुआ यार?
नहीं हाँ अभी आएगा.
हाँ अभी आएगा.
Sir, it's coming full black, sir.
अरे कैमरा तो लगा यार. किसी का दिमाग नहीं चलता क्या?
I thought only I could not see.
Just a minute. Sorry. They didn't change the camera from silentoscope. Frustrated यार.
Easy. It's all going very well.
Yeah.
I thought you were seeing.
Yeah, now it is visible. Very clear, Dr. Satish.
Let me. Yes.
Yes.
See, he is holding the implant in the same position. See this. See that?
Yes.
And
Yes.
I pushed my seal. So, the position where the electrode cannot change.
Correct. Yeah.
Yes.
Record देना. ये नहीं. Knife दे.
So Dr. Biswajit from Guwahati is asking that is there any specific sterilization protocol to use scope inside the cochlea? Also,
Yeah, it was
also
already,
what is better?
Yeah, it was already sterilized. Yes, you have to keep the scope sterilized. That is most important.
Okay.
No doubt about that. Pick there. Give me pick. I've taken a fresh piece of muscle.
Yeah.
See, what I want to ensure is I don't want to mobilize the electrode, because now I am seeing it is correctly lying along the periphery. Now it is. See that? Hello?
Yes.
Absolutely sealed?
Yeah.
Now give me the glue. X-ray एक बार और ले लेना बात के देखने के लिए. छोड़ना मत अभी. See now glue, no, not a micro drop of CSF.
No, not at all.
This is glue.
Yeah.
Now give me some fat pieces, small. अभी मत छोड़ना.
Again, Dr. Satish, glue you use in all the cases?
Tooth. Pardon? Pardon?
Glue you use at this stage?
Glue, yes. In such situation, it is better to use, sir.
Okay.
Not in regular
Because
implants.
even if you put the fat and the muscle, that is good enough because there is hardly any leak.
Yes, sir. See now, this is soaked in rifampicin.
Yes.
Small pieces all around. Or the no. This is towards the tip. No, they or there.
Yes.
Or there.
Your assistant's hand is as stable as yours, man.
Tetwa.
Tetwa hai, acha.
एकदम स्टैचू हो गया स्टैचू
statue, yeah. Yeah,
not even pulsation
इसने हाथ हिलाया इधर से टांग पड़ी
fantastic, yeah.
See now, I will show you the X-ray. बहुत print out चाहिए मेरे को X-ray का इस बार. वो नहीं, not on mobile. It should come absolutely 360 degree. No question of moving here and there, brother. Enough fat. See now, finally, remove. That's it. Okay? Hello?
Yes, sir.
Yes, sir. Yes, now sir. This fat will compress. Yes, this will compress like this, and nothing can mobilize. Yeah. See, this will prevent infection. This will prevent mobilization of the array. This will prevent CSF leak. All possible advantage you can think of.
Yeah.
Okay?
Yeah.
So I will
whatever
show you
is completely filled with the fat, you know.
X-ray.
So
this was another trick how to ensure the implant is lying on the periphery. Put your silent endoscope.
Yeah.
Make sure under vision and then fix it.
Yeah.
Ready? So now they will close it. We'll have our next case that is already started. I have asked Ayub to raise the flap. Transmeatal, that is for revision stapes. Revision stapes is one of the most...
So the message for today, Dr. Satish, if I can conclude, the message for today is subtotal petrostectomy going to be the future of CI surgery.
For indications.
Yeah, but probably in many of cases, those indications will be expanded. As I said, you cannot just preempt that there will not be a CSOM in the...
Yes, for indications it is amazing.
Do you agree with me? Yeah.
Now our next case is revision stapes. Revision stapes is one of the most challenging situations, I tell you. It is always a fear in the surgeon when he starts a revision stapes. You never know what you are going to find. Patient coming with a conductive hearing loss. Revision stapes has not got that kind of result what you think in a primary situation. It is full of surprises. You never know what you are going to find at the oval window level, at the incus, piston, whatsoever. So we have certain our technical how we go about it. I will share with you. So first of all, by and large, few facts about the revision stapes. There are certain indications, and a number one indication is a patient having a conductive hearing loss. Still, after the first surgery, that too, the best patient is the patient who has improved his hearing with the previous procedure and has now come back with a conductive hearing loss. Is the ideal candidate. That is the ideal candidate. There are other indications like dizziness, persistent dizziness, to rule out a granuloma or a perilimb fistula. Sensorineural hearing loss to rule out any long piston, granuloma, fistula, All these things are there. And fistulas particularly sometimes present with distortion or vibration of the sound. That gives you an idea to re-explore. Otherwise, majority of the indications are due to conductive hearing loss which has come back after the previous improvement after the first surgery. Those are the ideal candidates. Now, once you plan a revision surgery, first of all, a CT scan is must to know what has gone inside, which you can pick up. Though it may not be very informative if the CT is not good. Number two, the selection of cases. I tell you, this is one of the major cause of the litigations. Don't choose a patient who is criticizing the previous surgeon like anything. Never ever choose, because that may not be grateful to you as well. So those are the worst patients, number one. Number two, try best possible to talk to the previous surgeon, because that will give you a lot of input about the previous experience of the surgery, the findings, how difficult it was. That will give you a good idea about the experience of the surgeon as well. Like, let me give you an example. If some patient is operated by, say by Ashim Desai coming to me, who has done surgery, patient says, I didn't have any improvement after that. The surgeon, like who has done thousands of stapes, like we have Dr. Vishnu Reddy here, who has an experience of about 1,000 stapes. He has operated some patient and is still not finding improvement. That is not going to be a good candidate for you. So patient who has been done by a less experienced surgeon is a good candidate. And out of them, the best is who had some improvement. Because if the patient did not have any improvement during previous surgery, it may have been a misdiagnosis which may have been continuing now as well. There could be so many conditions giving conductive hearing loss rather than otosclerosis, which may have gone unnoticed during previous surgery, and still you are not knowing about that. So again, get ready for the surprise in that situation. This patient was operated 2 years back. Somewhere, I tried my level best to find out who was the operating surgeon, not to criticize or anything, for the betterment of the patient so that I get to know what the results. He said I got operated in a college hospital and I don't know who the operating surgeon was. Honestly. So I don't have any information about the previous history. He even doesn't have a discharge ticket or operating notes, anything with him. So we have a fresh situation, but has a pure conductive loss. Bilaterally, only left ear was operated. I told him we can go for the right ear. He said, I want to get operated this one only. With, explanation that results are never going to be as good as we operate on the other ear. But still he wants the left ear only. So we have the CT, of this patient. Let me share with you. Yes, on the left side. Now, first of all, what I can see here is the malleus stapes complex. This is the oval window. Can you see?
Yes, sir.
This is the oval window. This is the facial now. Can you see?
Yes.
This is the region of the genu and some opacity at the level of the oval window. Can you see this?
Yes, sir.
Yes.
Can you see some opacity in the oval window?
Yes, yes, very much.
Most dangerous thing. The reason in stapes surgery, why we are so, proponent of laser using in this situation is to deal with, to deal with the oval window. Any soft tissue at the oval window where the piston is lying, you never know where the piston is going in the depth. Though in this patient, I can see the foot plate very well, nothing going inside the foot plate, but lot of opacity of the oval window. And that is something pre-operatively warranting me to use the laser probably. The role of the laser here is amazing. I would say would be criminal not to use laser once you have a piston entangled at the lower end. Ashish.
Yes.
Because
no laser, no revision. That is the.
At the oval window. If you have a problem with the revision at the upper end, incus necrosis, piston falling down, that is different. But if you have a a fibrosis at the lower end where the piston is entangled, you never know what adhesions the piston might be having at the lower end into the vestibule, and if you try to pull out the piston, can ruin everything. That can lead to damage to the vestibular end organs. You can't pull the piston. So role of the laser is to use at the low power to vaporize the soft tissue completely around the piston. Completely vaporize to see where the piston exactly entering into the foot plate. That is what you want. Then once you see the piston, once you free the piston from all around with the soft tissue entangled, you can pull out the piston. You can see the oval window completely, all the margins. If the previous opening is closed, you can make another fenestra. If it is a bony closer, you can flush it and make the fenestra again. If it is a soft closer, use a low power laser and make a fenestra again, and then do STP surgery. So it is the lower end which is most important. But in revision surgery, let me show other things on CT scan in this patient. Not significant. Here the atic is good, the facial nerve is good. To see if the facial nerve is overhanging, I can see the coronal situation. See my facial nerve here and the oval window here, and lot of opacity at the level of the oval window. See, this could be the piston, previous piston, I don't know what it was. The patient doesn't have any notes. This could be the only thing, abnormal thing, looking like a piston here, going towards the oval window into this soft tissue. Can you see something? Can you see something? Do I enlarge? Can you see this? Hello, can you hear me?
Yes, sir. Yes, sir.
Yes, sir.
Yeah, this is something. Yeah, this is something going there inside. So I want to see my inner ear structures are all normal. I don't see any regions for third window syndrome. See the superior canal. No dissense at all. Can you see? Very clear. You see the cochlea, absolutely clear. No question of third window sign anywhere. Arey yaar. Arey. See this. See the cochlea carotid partition now. Can you see here?
Frozen.
Very clear. I am ruling out all possibilities of the third window. The vestibule is of normal size. The introitory meatus is of normal
Your
size.
screen is frozen, Dr. Satish. We cannot see your cursor. Yeah.
What is happening today? Why the screen is frozen?
Yeah.
No, sir. We can see your cursor, sir. We can see your cursor.
Okay. See the cochlea is normal, vestibule normal. I don't see any other abnormality except this finding, funny finding over there at the oval window. Now, so what it can be? If you see, these are the, let me put you a slide. These are the possible findings one can get during revision. There could be anything. You can broadly categorize into 3 categories. Gone? Picture? क्या हो रहा है यार?
Can see you, sir.
Go ahead. Yeah.
Yes. Yeah. अरे यार. Virendra. Yes, now. Don't move. There is some short connection here, loose connection.
Visible, boss.
Virendra. Some loose connection. Okay. Can you see the screen now?
Yes.
So these are the possible findings one may come across during a revision surgery. You can broadly categorize into, अरे यार, I'll kill you, man. क्या कर रहे हो यार? Loose connection बंद हो रहा है ना?
We can hear you, sir.
Virendra, what is happening?
Okay. कहाँ है? हाँ ये रहा ये घूम गया, ये घूम गया। हाँ 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 ये तो नहीं, ये वाला सही नहीं लिया, सही नहीं लिया, सही नहीं लिया एंगल। वीरेंद्र क्या प्रॉब्लम है? लिव इट 2 मिनट्स। अब कोई नहीं जाएगा उधर, इधर आ जाओ। कैन यू सी द स्क्रीन नाउ?
Yes, sir. Yes, sir.
Yes, sir. Yeah.
So you can categorize these findings into either the problems at the upper end at the level of the incus, most likely either partial incus necrosis, loose piston over there. Sometimes the piston is coming out of the oval window fixed to the angle of the oval window somewhere, and a fixed piston there hitting on the incus again and again can lead to incus necrosis. There could be adhesions between the incus and the promontory, pulling the piston out. There could be anywhere fibrous adhesions leading to conductive hearing loss. Small fenestration leading to fixation of the opening, regrowth of the otosclerotic foci, could be fistula, loose crimping, so many things, incus displaced. There could be any possible situation one may come across, and one should be prepared to deal with that. Incus necrosis, incus displacement, or any other thing. So these are the possible regions one can come across during a revision surgery finding. So let's see in this patient. I've asked my colleague Dr. Ayub to raise the flap. You know, my first sight, the first thing I can make out about the previous surgeon through the exposure. If I see a proper exposure, I can believe that the previous surgeon was an experienced one. And if you still need to improve the exposure, that means the previous surgeon was a beginner. It can be as simple as that. So,
was there any initial improvement, Dr. Satish? Was there any initial improvement? How long the patient was better?
Yeah,
or no improvement at all?
He says that I could hear for a month or so. That now he says, I don't know exactly how sure it was that I improved, but it looked like I felt so.
Okay. Okay.
And he was so scared. Now he has come after more than 2 years.
Oh.
Sir, your experience, you have done so many. What is the most common which you have seen because of?
Most likely either the incus necrosis or the piston out at the lower end.
Oh.
Piston out at the lower end. The length of the piston is so important. A short piston may come out, or the angulation. Like you saw that day, Ashish, what he showed, the piston coming right angle from the incus to the fenestra. If if you put a piston at the angle, it can stick at the margin of the foot plate, and then it cannot work. So there are many reasons to it. Stapes requires highest level of diligence. A micro-millimeter mistake can ruin the overall outcome.
Does extrusion has very relation with the type of piston? Because I have seen few cases with the Teflon only. And well, the titanium is a better one, or doesn't really make a difference?
I tell you my experience. I have not used the Teflon for last almost 10 years or so. Very rarely. Majority of the series you see, the revision series, using Teflon, the problem with the Teflon is it requires a crimping. That is a big issue. And you have seen in the last webinar how Ashim Desai was crimping with both hands. How you crimp, your experience, it definitely matters. The reason is, if you put a loose piston, a loose piston will keep on hitting the incus and it will ultimately erode. It may erode the vascularity. At the same time, if you try to crimp it tightly, it may dislocate the malleologidal joint. Secondly, it is a misbelief
that the piston has a memory. All pistons do not have memory, and that it is going to come on its own. Don't be in those illusions. It never happens, because the goal of the piston is to transfer whatever sound energy coming to the incus to transfer to the vestibule. Any play of the piston at the level of the incus is not going to efficiently transmit the sound energy. So one should be very, very good at crimping. That is the big difference which the Teflon and titanium makes. In titanium, in my experience, I have not revised my own for long, because titanium tightly holds the incus like a clip, and there is a middle slot there which tightly holds, and it holds less than 1/3 of the circumference of the incus. So it doesn't erode anything, doesn't erode the vascularity. And believe me, I don't know, but in my hands the titanium is...
But not just, it's not titanium material. He uses the titanium clip piston. You get titanium pistons which need to be crimped.
Yes.
So this is what he's talking is about the clip. Yeah. Because the clip is a lot of surgical, physiological, all, because it does not go circumferential. It is only a 2-point contact, but a firm contact. So there is a lot of merit in that titanium clip.
It has a definite advantage which makes me use a titanium piston, which is relatively more costlier.
Yeah.
The intention is not to...
Cost is really just a matter of perception. I don't think...
It has a definite advantage.
Huge.
Regarding biocompatibility, Teflon is good biocompatible. Titanium is more biocompatible. Marginally, I would say.
And no
there
amount
is not
of...
a single disadvantage of titanium over a piston. There is not a single disadvantage.
Yeah, other thing, Satish.
Yes, sir.
If there was no initial improvement, sometimes you see there was no fenestra made.
Yes.
So you see on the table, fenestra might not have been made because of the thick foot plate, or if they don't have adequate instruments to drill.
Yes.
So they may not have drilled, and that also has seen few times. Piston simply lying there without a fenestra.
Yes.
If there was no initial improvement.
And Vishnu's point is, those are the easier cases. You mentioned which improved and then got bad. But those who didn't improve at all without any
cases, most ideal cases.
Yeah, the other things are, suppose if they have made the fenestra.
Sorry Vishnu, let's welcome Dr. Vijayendra. Satish.
Yes.
Hi Satish.
Hello sir.
Hi.
Hello, Dr. Vijayendra, how are you?
Hi Vishnu, how are you?
Fine, thank you.
Thank you.
Vishnu, complete your point, Vishnu. Yeah, sorry.
Yeah, the other thing is, if they have made the fenestra and the length of the piston may be inadequate. Okay, one thing is piston, the fenestra might not have been made. Okay, that is one explanation. If there was no improvement, fenestra was not made, or even if they have made the fenestra, the length of the piston was not adequate, perhaps. When you see there is so much of thickening around the oval window, the possibility of thick foot plate, probably they have not drilled. That is also a possibility.
Probably the next case is that one, which I am going to demonstrate, probably. And that happens very commonly. A surgeon finding a thick foot plate, he goes on drilling through the thickness of the, focus to enter into the vestibule and put a piston. That cannot work. You have to flush out the entire foot plate, remove the entire foci, then make a perforation in the thin foot plate and then put a piston, then measure the piston finally after removal of the, overhang, all these otosclerosis material. One should not measure from the top of the obliterative focus to put the piston. So all these things.
I think, Satish, I think mainly the people who do not drill, those who use laser and laser also on a thick foot plate, I think that's a disaster.
That is disaster.
And if you just use on an obliterative, if you only use a perforator, then also it's probably inadequate.
I have seen people using on an obliterative foci 10 shots of laser.
Oh,
that is criminal, I would say criminal.
Yeah.
That can damage even the facial nerve. Laser is to be used as a single shot only for fenestration. As simple as that. For particularly this luminous, just a single shot. If you really want to use laser, first drill away all the otosclerotic foci until you flush the foot plate. Once you find the blue foot, Ashish had shown last time very nicely. Once you come to the flush foot plate, then you make a fenestra with a laser or drill or whatever. But laser is something not to vaporize all the way the entire obliterative focus.
Not the bone, yeah.
That is
not the
something
thickness.
I would say to be condemned.
It will never work, sir. It will never work. So you need to have the drill, make it blue lined, and
Laser
then
means just one shot, not a second one.
You know, after seeing Dr. Vijayendra, I am remembering our Guru, Dr. Mahadeva garu. Hello.
Yeah.
Dr. Vijayendra. We miss him so badly.
Really?
You know.
Yeah.
We were together, Ashish.
Yeah.
After I returned from England from 2003, every 6 months, myself, Dr. Vijayendra, and our Guruji, you know, Dr. Mahadevaya, and he used to talk a lot about you. You know, I think you were coming to Bangalore and doing the microscopic surgery.
Yeah.
And
I did his gardener's daughter, bilateral microshare.
Right.
Yes.
Yeah, he told me about it. He told me, you know, every 6
He
months
was a
we used to meet.
great man, very generous and a great man. Great teacher, great man. No question.
You know, again, I'm seeing this, the canal speculum. I think I've been using his self-retaining ear canal retractor. You know, I've done it with one retractor. You know, it's so handy. Your both hands can be free.
Yeah.
You know, I don't know whether any of you have seen. I think
You're
Dr.
talking about
Vijayendra must be using the same thing.
Dr. Madhavaya self-returning retractor.
Absolutely, yes.
Yes, sir. That's a fantastic, and that's a must for. It's a very good.
That's right.
Yes, sir. For stapes surgery. Yes, sir.
That keeps your both hands free.
Yes, sir.
Satish. Yes. The king of crimping, Ashim is there now.
Hi guys.
Hi master.
Hi Ashim.
How are you? Hi Vishnu, how are you doing?
Fine, thank you. Ashim, how are you?
First class. Ashish. Good to see you, man.
Hi, buddy. Hi.
What's the master up to?
He's finished subtotal petrosectomy and cochlear implant. Wow. Now a revision stapes. The flap has been raised.
Okay, great.
So there's some soft tissue reaction at the lower end of the piston. I mean, at the foot plate. Let's see what it turns out to be.
So was it a mixed loss or what?
I haven't shown the PTA.
Sorry, I missed the history. The first surgery was 3 years back.
They have not showed the PTA yet.
Okay.
I think it's 2 years ago.
2 years.
2 years ago, he was operated, and there was no improvement apparently from the beginning.
No. There was improvement, and no, I think so. I missed.
He said for a month or so. For 1 month or so, there was.
That we were not very sure whether there was improvement or not.
I think it's a fantasy for the patient.
Yeah. He was not sure of the improvement.
Patient may feel that they are improved.
Yeah.
No, the surgeon psychs them into believing.
Right.
Ashim sir, good evening.
Yes, sir. Very good evening. How are you?
Sir, fine, sir. Yes, yesterday there was a question regarding this. Somebody dislocated the anchors while opening the thing. So there was a big discussion happened. I would like to have your words on that.
So, during stapes?
Yes, sir. Yes, sir.
Okay, so when you are dislocated, there are two possibilities. One is that you are subluxating it, and the second is absolute dislocation.
Yes, sir.
Then the second possibility is whether you disturb the stapes superstructure or not.
Yes, sir.
Now, if this has happened before the stapes superstructure is disturbed or before the stapes is nothing has been done, then your option is to put it back and keep a little piece of gel film or silastic superficial to it so it does not attach to the tympanic membrane, and then go back in on a second stage.
Absolutely, sir.
If, however, you have already done something to the superstructure, taken it away or whatever, then you are better off to go. If it is mildly subluxed, you can go ahead and do a stapedectomy. But if it is grossly dislocated, then you are better off using a Malleus stapes assembly.
Yes, sir. So, any take on this ionomers, glass ionomers? It was mentioned in one of the discussions, so I'd like to ask now.
Not the glass ionomeric cement, but there's another cement that actually Satish can talk about that seems to work very well.
Yes, sir. That one used for the preparation of the lenticular process. But not the glass ionomers.
When you attach it to the incudomilial joint, because that's where it subluxes from, you're creating bony ankylosing, and if it gets ankylosed to the attic, you had it.
Yes, sir. Actually, that's what, sir.
So that is a big issue. So if you want to ever use that effectively, what you need to do is do a complete cortical mastoidectomy, thin out the posterior canal wall completely, put a piece of salastic superficial to the MI joint, and then put some ionomeric cement. But that's a lot of jugglery involved when you can get away with something else. Ashish, your views on this, please.
Yeah, absolutely. I don't think that other option is. You just try to put it back in its anatomical position.
Yes, sir. And close it. And
only issue what Satish was during crimping. If you do it, the piston has gone there, and the worst incus dislocation is the one when you put the piston there, suprastructure out, and during crimping you have for some reason dislocated. That's the worst.
Absolutely, sir.
Hello.
Totally, sir. Totally.
Yes,
agree.
boss.
Can you hear me? चला ना यार इसको.
Very faintly, Satish.
We want to know whether the overhang removal was adequate or the yeah, Satish.
Yes, Ashish.
Yeah.
Oh, what a big surprise. He said I had a piston operation.
The strip is there.
He said I had a piston operation 2 years back. See
and
that?
the strip is present there. Suprastructure.
No, it is a cartilage, man.
Cartilage.
Oh,
It's a
it
cartilage.
is a cartilage.
Okay.
And the incus is there or no?
Doesn't appear to be. It seems to be necrotic.
Yeah. Oh my God, so many cartilages. Can you see?
Yeah. Then probably the foot plate is mobile. So it's an ossiculoplasty and not a...
Yeah. I can see the facial canal above.
But do you see the incus, Satish?
Everything is, fixed there laterally. I can't mobilize anything.
Okay, that's the incus.
Looks like rock solid.
Rock hard. Oh.
And you see, this is another cartilage there.
Cartilage canal wall, yeah.
What kind of stapes was done?
This is a...
See, there's two cartilages. Why cartilage, man? Ashim?
Yes, boss.
Somebody is using Y cartilage.
Yes.
Absolutely. But it's a very large cartilage, yeah.
I am seeing the first one after Ashim Desai using Y cartilage.
Oh no, hello, I also use... I mean, very seldom I use it, it's a very difficult one.
See this Y cartilage? Oh my God, the facial is decent.
See, these are the difficult cases which require Satish's expertise.
Oh my God, what can I do in this? Here's probably tympanosclerosis laterally.
Yeah, I think you'll have to put a bow cartilage, remove the head of the malleus.
Are you sure this is a pure conductive loss, boss?
I counseled him for the stapes surgery. Had a lot of discussion about the results and all.
The other side is normal tympanic membrane?
Yeah, normal tympanic membrane. Both sides normal tympanic membrane. And now see this incus is completely rock solid. See this?
Amit ki Satish ki nahi?
Can you see?
Yeah. See, we can see the shaft of your instrument bending.
Yes. Instrument is bending.
Yeah, not the...
And there is another cartilage behind that as well.
Behind, yes.
Oh my God. And more than that, he completely forced this cartilage in the oval window and see pressed on the facial now.
Yeah.
My goodness. And see this cartilage.
Was there any facial palsy also, Dr. Satish?
No.
He didn't give any history of that.
Okay.
And see another cartilage lying here behind. I told you this revision surgery is full of surprise.
Yeah,
we had that talk this morning only, Satish.
Yeah.
See, so what Satish is doing
Now
is
it is coming out, yeah.
he has very gently removed that cartilage, and he is going to first assess the lower end of the cartilage and the foot plate before he decides what to do with the incus.
Now see the lower end.
Yeah.
Now whether it is mobile or not mobile,
That is correct.
It looks like tympanous sclerosis there.
Hello.
Yes.
See that?
जाऊ शकतो तू.
See, this is like tympanous sclerosis there.
Yeah, absolutely.
And it is
Can you zoom
completely
out?
fixed.
Can you zoom, Satish?
Pardon?
Can you zoom it little more?
See, it is fixed.
Yeah, absolutely rock hard.
So come on, boss. अभी lateral chain को mobilize करो and come on.
So you have a situation where there is a pan-ossicular fixation.
Yeah. So staging is important.
So ideally, this is a staged procedure.
Yes. Ideally, first I have to talk to his relative outside.
No. Can I suggest one thing, Satish, please? What I saw that the incus was grossly fixed. What about the malleus?
Completely fixed.
What about the malleus?
Yeah, I'm
What
going
about
to
the
go
malleus?
there anteriorly and see.
Yeah, because if the malleus is mobile, you can, because the tympanic membrane is intact, you can do a malleus tapedotomy.
Yeah, but I don't
if you
think
wish.
that will. Then is the good situation. I can do a malleus tapedotomy.
Yeah. The other
See now
option,
the
of
round
course,
window,
is
whole window?
to immobilize everything. But the conundrum here is that there is no superstructure. So once you mobilize something, nothing is stopping the incus from floating away during the healing process, unless you make another similar assembly right
know
down to
what
the
was
oval
done.
window and then approach it at a second stage.
So I think this was a pure case of tympanous sclerosis earlier.
Yeah.
With the surgeon operated.
We kept saying we have not shown enough tympanoclerosis.
My God. And see one more cartilage there anteriorly. I don't know where it is going to.
But you know what? You can ignore it.
Yeah, that I can ignore only if the malleus is mobile.
Yeah, that's the important thing.
If malleus is mobile, then I'll go ahead.
See, you can mobilize the malleus. Anyhow, incus is fixed. Just slightly remove the incus and mobilize the malleus. It will become mobile, even if it is fixed. Forcefully, you can mobilize the malleus. Anyhow, remove the incus. Then the malleus, you can forcefully pull it. It will become mobile, most probably.
Yeah, if it doesn't fracture, but most of the times it does not. Yeah.
So usually what, that's why you should not keep the instrument in the handle.
It looks
keep
like
the
there is
instrument in the neck.
Neck.
Then there the stability will be more.
Yes, and it is stronger.
Stronger. If you use handle, it will get fractured.
Sir, it looks like it is fixation with the tympanous sclerosis in the atic.
Yeah.
And see this, it is rock hard.
Then even if you mobilize, it may not work.
It will refix,
No, the only option here, if you want to mobilize it, is you need to do a complete cortical and mastoid go far anteriorly.
So Satish, दूसरा case तू लगा, let Ayub take care of this.
So suppose
this is the part of the incus.
Yeah.
If you do mastectomy and then mobilize it, I don't advise to do staphylectomy in this stage. You have to go for another stage.
Second stage.
Third stage. This is second stage. Third
That's
stage.
the head of the malleus, I think.
Third stage.
The part of the ossicle.
Yeah. And plus, in tympanoclerosis, when you do staphylectomy, the results will not be as good as real staphylectomy.
Yes.
Third, you are doing a malleus assembly. Again, the results compared to the incus assembly, malleus assembly, the results will not be good.
Huge,
so it is not worth doing
Ashish.
all these things rather than giving a hearing aid.
Ashish.
That will be the best thing.
I have one more option now.
Or else go to the opposite here.
No. What I can do...
Has the malleus become mobile?
Yeah, malleus was part of it. It came out. It was malleus only, not the...
Malleus, head of the malleus.
No incus. No incus.
No incus, okay.
Now I have a fixed foot plate without tympanous sclerosis.
And no ossicles.
No ossicles. Now the next option is to either use a TORP.
I think for now...
After the fenestration,
No, I am personally against the torque.
Yeah, I am also against torque. See, then the chance of intrusion
even I
will be
don't
there.
like. I don't like even that is the option I told you.
Yeah.
No, torque if you keep, when you keep the lower end, what will happen? It may go inside. There will be no stability. Torque, how you are going to keep?
So these are not, by definition, not the normal aerated ears. So they can be compromised. Yeah.
So you can try these things. Best thing is
Positive pressure दे लेना.
hearing aid is the best choice.
देना क्या?
Honestly, even if he closes now, is going to have the same hearing loss.
Same hearing, yes, yes.
Yeah.
Same hearing. What I would have done while counseling, so he has opposite ear also conductive deafness.
Yes.
Okay.
But
So I would have told him I'll open and see. If I am not able to do anything, if you give permission, I'll open the opposite side and see. If it's a classical step otosclerosis, you can do it.
Sir, now Ashim.
Yeah.
What are your options now?
Boss, this kind of a case we don't have malleus incus or stapes, I'd take a step back.
Let me tell you the situation.
Yeah.
The foot plate is a deep oval window niche, deep.
Absolutely.
With a tympanous
There is a
sclerosis.
facial. The facial
With a
is there.
dense facial here, see this?
Absolutely.
With no ossicle.
Yep.
And big defect at the attic.
You know, I would reconstruct that attic defect a little with the cartilage and take a step back. Forget the hearing reconstruction. I think one of the messages that we need to also share is the wisdom to take a step back when need to.
Perfect. I agree with you, Ashim. I also do the same. I agree with you.
Sir, Pranam Vijendra sir, how are you?
No, that's what you should do it. Don't take. Already second stage. Best thing is play safe role.
Yeah.
As you said, attic has to be recast. Otherwise, you'll have attic retraction after again you have started go on surgery after some years.
Yeah.
So that's a very good point,
Yes.
valid point. You have to reconstruct the attic. There is no incus. So reconstruct that and ask him to go for a hearing aid.
Okay, now that is one most likely option because I have to talk to the his brother
Satish.
also.
Satish.
We had a long discussion in counseling.
Satish.
That is one.
Neomalleus.
Yes.
Sculpt the remnant of the ossicle, create an incus sort of a thing in a graft. No, two stage, but create an incus there, attached to the, and later on you could think of putting a piston on that.
Yes. Now the second option.
Other thing is that Vincent uses that malleus prosthesis that you fix it now and again go on.
Now the second option for everyone, if you have to do anything now, what you can do?
Now,
Vestibulopexy. What you can do is remove the whole tympanoclerosis, expose the vestibule, put a vein graft, and then put a cartilage. But it is all risky.
no, mobilize the stapes and then put a bow cartilage. You'll refix, but at least on table and few days you will hear.
It's very dense. And one more thing, what has happened, that the whole vestibule is filled up with tympanous. It has gone down.
You know,
So it is risky to remove that.
With the presence of dehiscent facial, this ossicular gymnastics may not be the best option.
I agree with you.
You think the bow cartilage pressure on the facial will be an issue?
It's too narrow for a bow cartilage to efficiently act.
See, this is a deep, narrow niche.
It's very narrow and deep niche.
Deep and narrow niche.
Should he try to at least remove the tympanus and see if the foot plate gets mobilized? Oh, that is also risky.
That's what
Again, now the problem here is that if you, while mobilizing in this kind of a scenario, you make even a slight subluxation, you lose high frequencies.
Yes.
Yeah.
I
And
may end up
tinnitus.
giving sensorineural loss.
And tinnitus, more
5
dangerous, I am
minutes,
worried.
5 minutes, let me talk to the relative. If they agree, my plan is to mobilize it and reconstruct with a cartilage. That's it.
They will agree when
If
you
he
tell
agrees,
definitely.
because now the issue is he has to take a call for not very good improvement,
From piston to no
possibility of a
piston.
sensorineural loss, or more.
All the Superman stuff you spoke about, the titanium piston goes for a toss.
Now the things are all together. You know, revision stapage is always full of nonsense.
Yeah, correct.
And this was not a stapage case actually.
Yes, yes.
I'll be
Many
back
people
in
are not getting.
few minutes. Let's see what
The screen is frozen here.
Because Satish has got up. He's talking to the relatives now.
And I tell you, whatever Satish tells the party, they will agree to it. Because people go with so much faith. Yeah.
No, that
For that matter, anyone, patient,
but
really means he comes with a great faith. And you have to honor that faith by explaining everything.
But I think what Ashwin sir has said is very, very correct in the present scenario.
Hello?
We were not expecting this, and we got to have something.
Hello? Hello?
Yeah, yes. Screen is frozen.
Yeah, so in the implant case, the Shefali has completed the NRT and she is getting good response in majority of the electrodes.
Lovely.
Great. Great.
Can we bring her on mic?
So, Dr. Satish, what you are planning for this case?
Let him finish with that.
I think he finished with the relatives, I suppose.
Something, we have 5 minutes about what you Hello? Hello?
Yes.
I'm giving mic to Shefali until I finish that stapage part with the attendant. She will apprise with the situation of the NRT this patient.
Yeah.
Hello? All the electrodes, kind of electrodes here.
Okay.
Hello, Shefali, hi, we are with you.
Am I audible?
Yeah, you are
loud.
Thank you, sir. So basically, we have done ECAP responses twice today.
Is she audible?
Yeah.
So first time when we did, we were not able to get any responses. So second time when the reinsertion took place, so I have done measurement wherein I have measured until 100 charge unit. Okay, so now here on channel 1 and 2, I was able to get threshold of around 800 current unit, and I was able to get very clear ART responses when I used a pulse width of around 80 microsecond. So on channel 3 and 4, I was able to obtain the threshold of around 533 current unit, and there was a good amplitude growth. And lastly, on channel 5 and 6, I was able to get threshold of around 533 current unit. So possibly the reason why I am getting such kind of high threshold in your ECAP measurement is because first of all, it's IP1 deformity, and second of all, it's thin nerve, so we need a little bit of larger duration of in order to stimulate the nerve. So what we can expect post-operatively is that maybe we will not be able to use the coding strategy that we use in regular cases, which is your FS4, and maybe we'll have to use the ST6 coding strategy, and also it is quite a bit possible that we might have to use a longer pulse duration of around 30 or 20 or 30 microseconds post-operatively during the switch-on time. But let's see, our main focus is going to be to use the FS4 coding strategy, which will give temporal and as well as place coding to this particular patient, because the more information that we can provide the better the outcome is going to be. But just in case we can't, then we will opt for STSS coding strategy. So about electrode arrays, so we have got different types of electrode arrays. So the first series that we have is classic series. So classic series has 3 electrode arrays: standard, medium and compressed. So in most of the cases we use standard electrode array. The length of the array is 31.5 millimeter, and this is 31.5 millimeter because one of our primary philosophy is complete cochlear coverage. That, we believe that we have to cover up to 720 degree of insertion in order to provide appropriate temporal coding in appropriate place. And second is medium electrode array. Now medium is used in shorter length cochlea, or it can be used sometimes in abnormal cochlear cases where you're not expecting a CSF gusher. And third is compressed electrode array. So compressed electrode array is primarily recommended, or we use primarily for ossification case. It depends on the type of ossification that is present. Now the second type of electrode array that we have is form series. So as Sir had already explained before, the form series electrode have core kind of stopper at the end, which helps to stop the CSF gusher. So hence, any time in any cochlear abnormalities, if you expect CSF gusher to be present, it is always recommended to use form 19 or form 24. Depending upon the length and the size of the cochlea. And third is the flex series. So flex series is based on our second philosophy, which is structure preservation. So we believe that the structures in the cochlea are very important and they have to be preserved, not only so that you could utilize the technologies later, but also there are a lot of studies which are shown that when there is when there is proper structure preservation, then the outcome of the cochlear implantations are better. So there again, there are various lengths that can be chosen. So Flex Soft is 31.5 millimeter, Flex 28 is 28 millimeter, and then Flex 24 again, as the name suggests, 24 millimeter, and Flex 20. So depending upon the cochlear length, it can be measured using a value, or we have a tool called Otoplan in order to measure this particular the duct of the cochlear duct length. Depending upon that, the right size of the cochlea and the right type of electrode can be chosen, because the thing is, in cochlear implant stimulation, not only maintaining or utilizing tonotopicity in apical area, but also in basal area is important. So if you see always, the distance between your marker ring and then the basalmost electrode is approximately 2.5-3 millimeters in almost all the electrode array. The reason why this gap is there, because at the level of cochleostomy or around, the nerve fibers are responsible for hearing around 18,000 hertz. So if we go a little bit ahead and stimulate, then we can stimulate nerve fibers of around 10,000 or 9,000 hertz. So what exactly is the your maximum ability of the your audio processor? Hence, tonotopicity, maintaining tonotopicity is very important. So thank you so much. I'll hand over the mic to Sir now.
You can see the.
Thank you, Shefali.
Beautiful insertion.
Satish, beautiful insertion, ultimate.
देखो तो सही. Clear. See now, see the curvature. Now, reduce the glare little bit more.
We can see it.
See, that is the outer coil, and see the how the electrodes inside the cochlea. Yes.
Very, yes.
थोड़ा glare कम करो यार.
दिख रहा है.
Now, अब दिखाओ. Better.
Yes,
can you see?
Yeah.
So this was to the periphery of the cochlea where the neural elements are. That's how she is getting responses as well.
Very nice.
Okay. So regarding the stapes, patient is still confused His brother says, I'll talk to the patient himself and will tell you tomorrow.
Don't worry, tell
Either
them
we'll
we are
get,
also confused.
tomorrow again done, or we'll get the hearing aid.
Yeah. Okay. The other one, the
See,
second revision.
stapes is one problem that you have to keep the patient in loop always. Any surprise finding you have to, tell the patient. Because the patient having conductive hearing loss, if develops sensorineural loss, you are to blame.
Since Prakash is obsessed with the future, I think the future is a diagnostic endoscopy before doing the...
No, still we could try, still I could try now, a
No,
I
don't know, yeah.
a sort of partial stepidotomy, put a vein graft and a cartilage. It would, I believe, it would improve the hearing. Not to that level, like stapes surgery, but yes, that is the best available option, the simplest option in this condition. So now we have next 3 cases. The 2 I am going to, the case is getting ready. I will take you quickly through the radiology of both the cases together. The first one is the stapes, again the revision one, and then is a paraganglioma of the jugular foramen.
Satish, if you don't mind, can we see the CT scan of this previous revision? Yes. Just to sort of correlate what we saw in top.
Cartilage is not picked up by CT scan, that is the problem.
Okay.
See, this is the previous one. You cannot pick up the cartilage on CT scan. CT picks up bone, it picks up metal, it can pick up piston, but not the cartilage. See, nothing is visible.
Hello, ready? Oh,
that's why in revision I told you the CT may not be so informative.
They're trying now the mic.
Now in this patient, कौन सा गिरा left है ना? Yes. Hello. Hello.
Yes,
This patient has a history of, we had a notes also, using a piston, Teflon piston. 1.5 years back, he had some improvement according to him, but slowly deteriorated. But still has a good conductive component. There's a slight mixed loss, but has a good conductive component to be valid for exploration. And what we found on CT scan, see again, looks like thick foot plate. Can you see?
Yes, very nice.
Yeah. Like Ashish did on that day, it looks like that kind of a situation. And see this kind of a piston coming to the foot plate. Can you see?
Yes.
Looks like the piston coming to the foot plate. This is the incus, this is the malleus. This is the incus, the malleus, incus body. Then incus long process, and from here is the piston. Can you see the entire chain?
Yeah. It doesn't look like it is going beyond the foot plate.
I don't think it is anything going beyond. Is this, you mean to say?
No, it is not going. What I'm saying is it is not into
small
the
fragment has been subluxed inside, and that has reossified.
Yeah, this is the reossification, what I believe. Either the previous ossification was not cleared by the surgeon.
Not cleared, or it has got.
Yes, so this will require definitely drilling. See the facial now looks good.
Yeah.
And this one on the coronal.
The previous surgery is how long back, Satish? I'm sorry, I missed it.
What done?
1.5 years.
Uttarakhand.
1.5.
See this?
Yeah, beautiful.
The thickness here.
Somebody's phone is on there. Yeah, nicely seen.
So again it looks a difficult situation because this kind of oval window requiring drilling is a challenge.
In a revision, yeah.
So let's see what we can do in couple of minutes. And the next case after this, what we are going to take is a paraganglioma, and after that a schwannoma, the huge one. Both lateral skull base cases. So paraganglioma, we have first of all, let me take you through the CT angiogram. This is our favorite investigation because it establishes the diagnosis. It gives you a picture of the entire vascularity going to the tumor as well as extension. And this tumor is characteristically coming into the IJV, lower down in the neck, inside the IJV. The huge extension to the length of the IJV, that is very important finding in this patient, tumor. See this. See this tumor here? And this is coming all the way down into the IJV here, until here, in the neck. See, this is the normal vein below. Can you see? Hello?
Yeah. See, Satish, we are with you here.
Yeah, see, this is the opposite side vein, normal, going up.
Yeah.
This is the this side vein, and until here is the tumor coming.
Yes.
See this? And this tumor is coming from the jugular foramen. See this jugular foramen. This is the carotid artery. That is the carotid, vertical carotid, horizontal petrous carotid, foramen lacerum going up and dividing into terminal branches. And this is the tumor, very, very vascular. Why I am saying very vascular? Look at the vascularity going to the tumor. Amazing. See this. Let me start from below. This is the level of the IJV, normal IJV, dilated one. This is carotid, okay?
Yeah.
As I go up, now see this IJV. This is the tumor now coming into the IJV. And this carotid, this is external carotid. And see, so many branches are coming out of it. So many branches. Where they are going? See this large branch.
Yeah, huge.
This is occipital. This behind. That is the terminal external carotid. This is occipital and going into the tumor. Imagine such a big branch going into the tumor. So I will go first in the neck and catch this to make my life easy. This is totally embedded into the tumor. There is a principal vascularity to this tumor.
It's huge.
Yes, this is the external carotid which is given off here, the occipital. And see now it is inside the tumor. Beside the other branches, there are so many other small branches, but this is the big one. So this will make my life easy once I go and catch this vessel. Now if I go up, now see I am going up. This is the carotid here. This is the jugular foramen. See, this is horizontal carotid.
Yes.
If you want to track the carotid, come from above. This is foramen lacerum, horizontal. Here is the vertical petrous carotid, and posterior to that is the huge tumor in the jugular foramen. Huge vascular enhancing tumor with the carotid in the relationship anteriorly all the way embedded in the tumor. See, this entire wall is in tumor. And now going extracranially, and now the vessel is away. See that?
Yes.
So this is the tumor. Monitoring, facial now. Now, if you see the same picture on a MRI, contrast MRI. See this contrast MRI. See this tumor with huge enhancement all the way and completely occupying the jugular foramen. See the jugular foramen of opposite side. This is the jugular sigmoid sinus. This is jugular bulb. And see at this level of the jugular bulb, huge vascular tumor. Can you make out the location? That is the carotid artery. That is tumor. It is so vascular, you can see on T2 weighted imaging the amazing flow voids. See the flow voids in the tumor.
Yeah.
These are all big vessel, dark. Paper, salt and paper.
Almost 1/3 of the tumor is vascular.
Yeah, it's all
Vessels,
vessels. See, this salt white is a salt, low flow vessels, and the pepper is the larger flow vessel, big flow vessels. That's how it is, salt and pepper appearance, and it is going in the neck into the, the jugular vein. This is into the neck. See the level of epiglottis here in the jugular vein. See this tumor. Now this is in the temporal lobe, temporal bone, and this is the level of the jugular foramen. So this is my going to be the paraganglioma with a different extension than before we have demonstrated, where the tumor is going lower down in the jugular vein, completely occupying it with no flow in the jugular vein. And after that, the last case which we are going to take is the schwannoma from the lower cranial nerve. Again, it's a very, very interesting one. Let me show you. We have a CT angiogram. She got somewhere done. Yes. Coming. This is a very, very interesting location of this schwannoma. This patient is a pre-operative vagal palsy, so I believe it is a vagal schwannoma from the vagal ganglion in the jugular foramen. Why is not opening? Yes. Now, so look at this schwannoma. The classical location, I am coming from above downwards. See at this level. This is the level of the CP angle. You can see the 7th, 8th nerve complex. Can you?
Yes, sir.
And see this schwannoma going into the CP angle. Schwannoma on T2 weighted hyper intense. Then if I come down, this is the level of the jugular foramen, completely occupying the jugular foramen. And if I see anteriorly here, it is entering into the hypoglossal canal. See the hypoglossal canal on the opposite side and the hypoglossal canal. And see, this is the carotid artery, the petrous carotid. Lateral to medial, if you go, it is completely medial to the petrous carotid artery. So deep it is. Medial, and it is in close relationship to the carotid. The wall of the tumor, the sheath of the tumor is in close proximity to the carotid, adherent to the carotid. And as you go down, this is the kind of schwannoma going so medially to the level of the vertebra. If I see in, the coronal one, you will appreciate better where the tumor is. See this tumor. This is the hypoglossal canal where the tumor is going. This is the CP angle. This is jugular foramen, and from there this tumor is coming down here. This is the carotid artery, and this tumor is immediately underneath the carotid artery. So this is jugular foramen. This is the cochlea, deep to cochlea, medial to the cochlea. See, this tumor is going in the deep in the petrous bone. Above is the CP angle, and this tumor is extending right up to the CP angle, little bit above the CP angle here. So that's a very interesting tumor going right to the CP angle here. Going here. Now contrast, it has a moderate contrast enhancement as well. Though it looks a soft tumor, I will do a intracapsular removal of the tumor to save the rest of the surrounding nerves, because it's a slow growing tumor. Patient already has a vagal palsy and we don't want to give a compound cranial nerve palsies. See on contrast enhancement, this is the CP angle component. So the tumor has a intracranial component, see this, has a jugular foramen component, this, as a extracranial component, this, that's the carotid artery. And this tumor is a component in the hypoglossal canal. And now I am going down and down. This is the component in the upper part of the parapharyngeal space, deep to the carotid artery, right in the prevertebral area. Deep to the carotid in the prevertebral space. So again, this is till here. So now I am going below upwards. This is the neck, prevertebral region, deep to carotid. Coming up, this is the jugular foramen lesion coming up, and see medially it is going towards the clivus. Here it is going into the hypoglossal canal. Coming up, this is jugular foramen proper with tumor infiltration of the clivus. Deep infiltration into the clivus. This is the nasopharynx. See, this is nasopharynx here. Deep infiltration of the clivus, and then coming to the CP angle. This is the CP angle component. That's the 7th nerve complex, and looks like good vascularity also. This is the contrast one. See the vessels going to the tumor. That's why it is showing a moderate contrast enhancement. So interesting situation. One of the most complex pathologies in this region is a dumbbell tumor, intracranial, jugular foramen, extracranial.
Yes, sir.
And I will expose by the retrolabyrinthine approach. I'll have to transpose the facial nerve below, where a sort of, I would say, limited transposition up to the second genu. I will try if I can access this, and if I need more exposure, then do a complete infratemporal fossa type A with this suboccipital exposure. The CP angle will require a suboccipital exposure. Infratemporal fossa will give us exposure right in the jugular foramen, hypoglossal canal, extracranial, all other areas. And this area medially here in the clivus. See this, you are coming from the mastoid, go middle mastoid, then go to the jugular foramen, the deep, and this area deep to jugular foramen. This is into the clivus, right into the clivus where the tumor is going, and it should be a suckable tumor. Looking at the characteristics, it has a good vascularity as well, but I still believe it's a suckable tumor. So these are the 3 cases coming up. Any questions?
Dr. Nadia is asking that will you do an injection laryngoplasty on the same sitting as we are going to cut the vagal paraganglion?
Not really. In this patient is already pre-operative vagal palsy. There is a lot of compression by the tumor. I told we'll do an intracapsular resection, and I will wait for some time, before doing any intervention to the vagus nerve. She's a young patient, 22-year-old. So I'm not concerned about any other complication with this kind of vagal palsy, an ipsilateral vagal palsy. So there is no need to rush for anything. Let's decompress it, remove it maximum possible without damaging the surrounding cranial nerves. This is not the case where you need to go for a radical resection. You can end up paralyzing all the cranial nerves if you try to go radical all around. There's a classical, even if you leave a thin shell, you saw in the previous parapharyngeal schwannomas I have shown intracapsular resection. A thin shell of capsule protects various nerve branches in the surrounding, and that is the need to prevent morbidity. बुलाए क्या अयूब को? अयूब, अजय, क्या बोला? Yeah, any questions?
Dr. Bharti madam is asking, how do we differentiate IJV thrombosis and IJV involvement?
Yes, IJV thrombosis and IJV involvement you can make out from the contrast picture. See this. See, if the contrast is going in the IJV, that means flow is there, as simple as that. If the contrast is not going, that means it is no flow, it is thrombose. So, if your contrast is going, there is a flow, as simple as that. Okay.
Yes, sir.
Niche. Okay, so the next case is ready. Ayub has already lifted the flap and I am going to start this in a couple of minutes. What he has told me, something a finding of relief, there is a Teflon piston in place.
I was about to ask, is the piston visible or not?
Yes, I asked him up front now. The Teflon is there in the place.
So Dr. M.B. Apparao is asking, will you address the intracranial part of the lesion in the same sitting?
Yes, same sitting. Always, sir. Unless it is a huge intracranial, then you have to, stage it to remove the intracranial part later. That we do in the globus most often, but in such schwannomas, we can remove it same sitting. No issues. And in such situation, when you have a huge posterior fossa component, if it is this doesn't look like a huge posterior fossa component, I would go with a petro-occipital transsigmoid approach, POTS. You expose like a suboccipital approach, retrosigmoid, and then divide the sigmoid sinus by ligating on both sides and divide it. And open up the posterior fossa right to the jugular foramen. It will open up like a book. Right from posterior fossa to jugular foramen to extracranial like a book. But in that situation, you have to sacrifice the sigmoid sinus. You have to go intradural. Here, we'll try to remove it as much as possible, what I believe. Let's see, extradurally. Second situation in this patient, we don't see the jugular vein in the any visible jugular vein in the jugular bulb because of the tumor is completely compressed the jugular vein. But still our philosophy is not to ligate the jugular vein. Once you decompress, remove this tumor, the jugular vein in majority of the patient again expands. So why to unnecessarily sacrifice the jugular vein? So POTS, not now. In case it warrants, yes. And that too in a second stage. With this extracranial tumor going down, we should not open the CSF space widely, as once you remove the skull base lower down, the tympanic bone and all, there is nothing to hold the the skull base, and then repairing the CSF is very, very difficult. So in case that requires a second stage. But I don't foresee any second stage in this patient. We will be able to remove in one stage. We have done such many and they have been able to remove it in one stage.
Yes, sir.
So couple of minutes with the STPs.
Ashish boss.
What you finding for the revision of the statement?
Ashish boss, when you avoid the revision cases, what are the contraindication of doing revision surgery in your contraindication? Well, you will not touch the case.
Even if the other side is normal?
Yes.
I think only for a dead ear. I mean, only if it is a non-serviceable ear. Otherwise, I am okay. I'm sorry. Sorry, I am doing some other things. Ask me the question again.
No, miss.
Which cases I will, even if it is a revision, which case I will not explore?
Yes.
Okay. So, only if there is no possibility of improving any hearing. That is the only case that I can think of.
And suppose there's a like this case, the piston is totally in the foot plate and surrounded by the granules of tissue, etc. You will take it out
this second case. Now, right now, what Satish is going to do?
Yes. What will your call in this case?
No, I think straightforward. I don't expect any challenge. It's to get if there's a scar. The whole issue of a revision stapes is assuming that the incus is present, or incus is, I'm going to use usable or salvageable.
Yes.
Then it's really just the scar tissue at the lower end. And when you have a laser, it's like having a debrider and the polyp. So it just bloodlessly goes away. And the endosteal membrane or whatever is formed down there presents itself to you. So the working on the foot plate when you have a laser to clear scar tissue is very, very easy in a revision. It's when you start playing with it. So if the incus, yeah.
By someone, and I saw him. In that piston, the Teflon piston is just coming out from the you can say attic part. You can see that part of the piston over there. Lots of granules tissue. So could be because of excessive attic removal could have been the cause. And what you will do in that case?
We have to rebuild. We have to put a thin slice of cartilage. Okay. The procedure remains the same. But you have to just make sure that you take care of whatever caused the retraction in the first place. So you have to rebuild it, but not with a very thick, like in a cholesteatoma, use a full thickness.
Okay.
Here you have to rebuild because you don't want it to touch the loop of the piston, the cartilage. So try to keep it as thin. A thin cartilage gives an equally good support. Because remember, these otosclerotic middle ears are not diseased middle ears, unlike in a chronic ear. So they behave much differently. They aerate very well. So they are not really prone to recurrence of a pocket.
Okay.
That I think is the big difference between the reconstruction in a chronic ear versus reconstruction in a revision stapes surgery.
That's true. Dr. Satish is ready now. Satish?
Yeah, just a minute. Laser.
So regarding this mixed loss and other things, I am quite aggressive even in revision stapes surgery. We do something called as a instant hearing aid score. You fit the hearing aid and in the first 2-3 minutes or 5 minutes ask the patient, is there any improvement?
Yes, sir.
But we don't see the microscope picture.
Yes.
Not getting microscopic picture?
No.
Microscopic picture, please. और ये तो लगा टेटवा. Camera.
Wait.
Okay, वो ला रहा है, दूसरा ला रहा है. और this is Ashish.
Yeah.
This is classical case. With lot of issues. What exactly we discuss? What can happen at the lower end of the piston?
Yeah, okay. Let's see. Due to keeping too much suspense, show us the picture.
जल्दी करो. अब तक क्यों नहीं? 2 minutes. 2 minutes will be on.
Yeah.
I can see the Teflon piston with lot of adhesions on the whole window. I can't see the lower end of the piston.
Yeah.
Everything like a mess at the lower end.
The lower end tells you the story always.
Yes. The incus is looking in place.
And very, very often, I think in most of the revisions we do, the compromise of the lower end is actually because of inadequate overhang removal. Because the exposure is not good, the patient's visual and the working axis starts to get narrower. And that is when the precision of the action goes away. So I'll be very surprised if the overhang removal has been adequate or more than adequate. Unless now Ayub has already removed the overhang. Commonest cause of failure, I think, is inadequate overhang removal. That increases the degree of difficulty of the subsequent steps. दिख नहीं रहा है सतीश माइक्रोस्कोप
लेजर लगा दे
So Dr. Deepa is asking, how do you address floating or the submerged foot plate? We have discussed this in the previous many webinars, but maybe Dr. Ashish Bhumkar can tell us about it more.
About Vijayendra sir can take it up because
Vijendra sir, yes sir. So Dr. Deepa is asking, how do we address a floating or a submerged foot plate?
They're two different. Vishnu and Vijayendra sir can tell.
Sir, Vijendra sir, you need to unmute. Yes sir. Yes sir. Hmm. Hmm. Yes. Hmm. Hmm.
Fraction.
Yes sir. Yes sir.
ग्रीन कर
Oh God.
रुक मेरे को फोकस करने दे अब कर
Yes sir.
Hello.
Okay sir.
This is a fulminant granulation, man. Unbelievable.
Hello.
Yeah.
Yes sir.
Okay, not bad. Okay. Sorry, it's car. Yeah.
Yes.
Sorry, I don't know whether that was Deepa's question or it's in a primary case if you get a floater. What was her question?
Yeah, revision cases she's asking.
If you get a floater or if it was a floater in the primary case.
Yeah.
Oh.
Okay, can you hear me now?
Yes sir, yes.
So now see the primary picture. This is the exposure, this is the facial canal here.
So the exposure is good. I take back my words. Did
I
Ayub increase the
see the ring
exposure?
of the Teflon here.
Outcoming,
with lot of adhesions at the upper end.
Yeah.
Which I have divided now at the upper end. See that?
Little bit.
Yeah, incus is necros.
थोड़ा बड़ा दे इससे.
Eroded at least a little bit, yeah.
And this is the incus. See this. And the lower end, you never know what is happening. What is this excess bone? I don't remember.
That must be the part of the crura. No. The stapes may have been just left there.
Yes.
Cancer. That looks like the arch. See, the crura is seen.
Yeah, that is stapes because I can see the tendon here. See the tendon.
Yeah.
Can you see the tendon?
Yeah. So now. Yeah.
My laser is the most useful thing here in this case.
Yes.
We don't know where the piston is going in. What is the condition of the lower end?
But this is where also I like my KTP fiber because I can turn the fiber and go around the piston.
Yes. You showed the KTP last time. The beauty was the bloodless field.
Yeah.
KTP has the ability to give
because then you pass the fiber through curved cannulas and then you can go.
Free them.
Yeah. See the big.
The surgeon put the piston with the suprastructure in place.
Yeah. So you have to. The challenge in revision is you cannot use adrenaline if there's oozing.
Yes.
That is the biggest. That's where the role of laser comes, and then it also. Yeah. Sorry. Yeah. Hello.
So Vijendra sir, what is your opinion about it? Why adrenaline not to be used in this way?
See, I'm trying to look more at the foot plate level.
Okay, sir.
I'm not pulling anything. Lot of adhesions with the incus to the foot plate, the suprastructure as well. These are the suprastructures of the foot plate, my God. See this? Can you see the suprastructure coming out?
Yes. Satish sir, Vijendra sir is asking about the facial now. What about the facial now?
Yeah, facial now I can see above very well. Very nice.
Yes.
There could be micro descensions in the facial now.
First of all, the best news is there is no foot plate.
Foot plate could be there below, Ashish. I
The
can't
moment
say
you see that
what is
when it
happening
just the
below.
suprastructure, it's good news.
I can't say because still I can't see the lower end of the piston.
Yeah.
That is my biggest concern.
Still some white thing is there.
Yeah.
No, that probably the shaft of the piston.
Could be. I'm lucky if it is the shaft.
Or why don't you laserize it, Satish?
That doesn't appear to be the shaft. See, this part of the facial nerve is decent here at the inferior aspect.
Yes.
See this?
Yes, sir.
How the picture is good there?
Yes, clear.
Now give me. See, I am using laser at a very low wattage.
Now the question is, what is that whitish structure?
Yeah, still not very sure what exactly it is. What I'm going to. Can I laser beam?
Yeah, tympanosclerosis.
I think because I called you, tympanosclerosis come along with you.
Yeah. Where's the laser beam? Yes, now. Yes, see now? I am not using adrenaline like Ashish has already mentioned.
This you need just a lot of patience.
Yes. See, low watt vaporization.
Beautiful, fantastic. Yeah.
I can't pull anything here.
Yeah. Yeah, absolutely, no question. And I think it's a good idea to actually refer your revision case to somebody or go with the patient to somebody who has a laser. I think that sort of a cooperation should start because it's really too much at risk.
See this mucosal tube around this thing.
Around the shaft of the piston.
Yeah, see this?
Yes, sir.
And I will vaporize it completely. This requires patience, time.
Yes. So, sir, you were saying advice to the surgeons who don't have laser?
See this kind of lower end issues now.
Yeah. I agree, because you will end up with so much oozing and you would not know, and then you'll start taking chances.
Not
That
only
is what
oozing,
happens.
not only oozing, you'll have to pull. If I try pulling the soft tissue, I don't know where my piston is stuck to.
Yeah, we don't know what's.
And I can damage. See this?
One trick that I did, and I can say this openly here, is even revision surgeries in dead years, I have done them free of cost, just exploration, promising no improvement in surgery, but you open and take a look inside. You say that there's a 1% chance, but I'll not take a single rupee. Go ahead and explore, because that revision surgery teaches you so much about the primary surgery. I think this is just some way that you speed up your learning curve.
See, my most important part here, this is my investment here, to define the oval window by clearing all this tissue.
Yes.
See, my oval window is much better visible now.
Yeah.
Though I don't see I can see the thickness of the foot plate here.
Yeah.
Not anything much. That is the remnant of probably the superstructure.
And because he has the advantage of the image in his head, he's not very anxious. Without the CT scan, you keep thinking whether the membrane is there, whether it is going to be bulging, whether we are going to prematurely open it. There's a lot of security that has come into his strokes because of the data from the CT scan.
See this again, vaporizing.
Yeah.
Satish sir?
Yeah. See all the soft tissue, I'm vaporizing so that it doesn't remain anymore. See now the shaft of the piston, can you see?
I think you are able to see, yeah. Is it centralized, Satish, please?
Yeah. Can you see the shaft of the piston better?
Yes. Now we are starting to see the lower end now. Yeah. Yeah. Yes. Thank you for your kindness.
There was such a bunch of tissue,
yeah,
which was not allowing to see anything below.
So centralized, sir?
Yeah, only after this vaporization I am able to see the oval window region. See that very clear?
Yes.
Satish, if there was this was a titanium, and if your laser had hit the titanium shaft,
that is problematic.
And
Yeah,
then
that's a very important issue. See this, with the piston inside the vestibule, if your laser happens to hit the piston, there are a lot of studies done. If this Teflon is hit by the laser, it is not going to transfer that much of heat energy inside the vestibule as compared to the metallic piston, titanium. So be careful while using the laser energy close to the piston so that you don't. Now I am getting this piston out.
Fry the vestibule, yeah.
See this much of adhesions.
Dented and yeah.
See the tube.
Yes.
But it means when you get this type of a pattern of erosion, it means that down there the fenestra is either was snug or it has become little smaller.
See, still there is Ashish.
Yeah,
see
I can
tube.
see the.
I can see the parallel coming out of the tube.
Yeah, I can see it. Yeah, and maybe this was a fat. Oh, I don't know. Still, what is that white thing?
See, at this time, people using a lot of material on the oval window adds on to the difficulty in revision surgery.
Yeah. Yeah, can't tell. No.
Forceps.
You should check whether there is an incision on the tracheal cartilage.
Now this foot plate is looking to me very, very thick. I will definitely explore it.
Yeah.
There's a quite thick foot plate.
Yeah.
See that? So
Yeah,
what
beta, the failure needs to be defined, no?
Yes.
What
So what
do you
surgeon
mean
has
by
done?
failure?
Let's get it. What the previous surgeon has done
It's a very inferior based fenestra.
is just a fenestra through the thickness.
Through the thickness, and it is at the inferior edge of the, actually it's in the annular ligament and adjoining the upper.
Yeah.
Let's assess this, Udbhav.
Ashish, I have reduced the brightness
Yeah.
to see my laser beam there inside.
Okay.
See now what I'm दूर मत जा यार यूं जरा हाँ center में रखो. Is the picture in center?
Yes.
Yeah, we can see it. Yeah.
Now what I am going to do, this is my drill, साफ कर. I will slowly,
Yeah, gently drill. Actually, it's the.
Oh. Keep it away. The flap has become very thick,
This was the point I was making. When you have narrow canals, you make the bulk of the. You take the incision more medially. This is the foot plate, Satish. What you're drilling?
Yes. It's all thick
Are you
focus.
drilling on the foot plate or on the?
Absolutely on the foot plate. There's a thick focus.
Okay.
Oh. No.
See this?
Massive. Oh, yeah, total obliterative. So this is a refixation of the.
Yes.
Not refixation. It is closure of the fenestra.
See this?
This was what we were discussing. When you have an obliterative foot plate, you have to drill the foot plate as much as possible, not just what is necessary for the fenestra. Look at the amount of bone dust that is getting generated.
See this bone dust?
Yes, and now the color change. What is directing him is the change of color. Yeah, very wide, yeah. No tunneling.
No tunneling.
I think Bhumi, Satish uses a skeeter, I think.
Yes.
0.6 millimeter diamond burr, I guess.
Yes.
Bhumi was asking.
We have to be also careful with the shaft not touching the dehiscent part of the
facial.
Yeah,
That's right.
that is important. The more important is not to use any pressure.
Not to use, yeah.
See the whole window niche. Piston मंगवा ले सारे.
Now it is turned to a primary obliterative autosclerosis. The revision part is all gone now.
Yeah.
This is like any other obliterative, except the mucosa is little more thicker and vascular. Yeah, there. See how much area is he drilling? Almost more than 2/3. Fantastic, Satish. Yeah. Yeah, possibly.
See so much of, and we could see on the CT scan as well the thick, focus. Ashish?
Yeah.
Remember?
And that is why, because the lower end of the piston was not moving, the reverse transmissions were going to the incus, and therefore the incus started getting eroded.
Yes.
Yeah.
Too thick a focus.
Wow. But his overhang removal was very good. The previous surgeon had done a fantastic job with the overhang removal.
One and a half years.
बंद है. ये बंद है. Give me section. Fine, very fine section.
I think the fact that he left the suprastructure also there means he landed in some sort of an accident.
See now, right at the level. See how deep it was. Ashish?
Yeah, massive. Still, no blue, nothing blue, still white.
Your technique with a fenestra in place. Drilling.
Satish, what is the thickest obliterative footplate reported? Is it 2 millimeters more?
Probably. Now see, right angle. See, in this obliterative focus, one should not use the vein graft, number one.
Yes.
Secondly, in the deep niche, such deep niche, one should not use the vein graft.
Narrow and deep niche, yeah.
Yeah. What I can see, the foot plate opening, see that?
Yeah.
See, it's not about the autosclerotic focus, the entire foot plate is,
Yeah.
Turned into
totally.
it.
So that was that white thing. See, the footplate is there is also white. Great. Now when he removes that piece, the fenestra will be, of course, oval.
Can't help. This is going to be my fenestra now.
Yeah.
Can't help with this. See now?
Yeah. Beautiful. Very nicely done. That was a master stroke, what he did.
Oh my God.
Without getting the whole footplate out, to just get that.
Yes.
And oh, not yet. One more time. This is where I'm sure even Vijayendra uses the fish hook.
Yeah, the Yugo fish.
Too big, yeah.
After removal of this, I will measure the required size of the piston. See, kind of. See this? Ashish?
So what is this whitish thing? Is it
focus?
Okay.
My goodness.
Send it for histopath. It may be tympanosclerosis.
Yeah, I think looks like tympanosclerosis.
Yeah. Could be.
Yes.
Is Ashim there?
Ashim is not there, unfortunately. I was looking for him.
I want to know if anybody would do anything differently.
Vein graft.
Now it is completely out. See that?
Yes.
Hello.
Yes, sir.
Yeah.
Completely out. Yes.
Ashish.
So it's It's getting to be a sort of a...
And I can use my piston over it now. See, the vestibule is full of perilymph.
Yes.
I didn't put my suction at all at the vestibule. That is a disaster. Oh, measuring gauge. Can you see the situation, the promontory below?
Yes.
And now I will measure the required.
Can we also see the health of the long process of the incus, Satish, if you don't mind?
Health looks reasonable. I don't say very
healthy, but
see this, how the Teflon is partially eroded. See this?
Usually the undersurface gets over, but this is quite a...
See this, how the Teflon ruins the incus at the long run.
So now here, my preference would be to place the loop of the piston as superiorly as possible.
Yes, number one. And number two,
to the healthier part of the long process.
Ashish, my titanium is 4.75. My titanium is not going to ruin it because it holds.
Yes, and it does not hold circumferentially, but...
Chota.
Sir, if the fenestra is larger, then what we will do anything to seal it?
No. I will make sure my piston is not large, not longer.
Long. No, and she's saying, is there a seal required?
Seal required.
I would put a ear lobule fat or that post-oral which Madhavya sir taught us.
I
Yeah,
use a
even the
drop of
generous
blood
ones.
and stop using anything else.
Yeah. So, but that is just my lucky charm. I mean, now I stopped using for many years, but otherwise it was my lucky charm for 2-3 years. Putting the earlobe.
Yeah, 4.5. Ashish,
Vein graft, what are the causes?
the vein graft should not be used because it can ossify.
Yes.
अरे यार बंद है यार, जल्दी तैयार रखो दूसरा. Always keep ready. Ashish?
Yeah, Satish.
Would you do anything different?
No, no. I will just put, I will just do exact.
Whatever what I want to say, if you don't suck into the vestibule,
yeah,
even if some blood is pouring, the pressure inside is more, it will not allow it to go.
Yeah.
So never suck onto it. See this?
Yeah. Yeah. Yes. Another trick for people is to keep a dye gel form inferior to the pyramidal process. So that sort of, keeps on sucking. So because the oval window is the deepest portion, the fluid tends to go there. If you want, you divert the fluid down there.
Ashish.
Yeah.
Now the simplest part is piston placement.
Yes.
Okay. And this beauty of the titanium is the way it holds. And you witness how the Teflon is ruined.
Oh, hello. If the footplate had got fixed like this, even your titanium would have ruined. Yeah.
Yes.
It's not the Teflon. Yeah.
That is one of the reasons. Because
see now, sorry, let me make a point. See where he is engaging the piston.
Superior.
Not near the lenticular process, way up.
Superior, yeah.
Where the incus is the healthiest.
What Ashish is trying to say, if the piston fixed at the lower end, piston fixed at the lower end,
Satish.
keep on hitting the incus above. That is how it is eroded. It was not the Teflon at the fault, according to him. It was the fixation of piston. Hey, yaar, क्यों हिला देते हो यार? Why are you coming in? कौन है?
Yeah.
Yeah, just a minute.
Yeah, put the facial.
The final blood. I will pour a micro drop of blood.
Agree.
So now in this case, when the piston is more superior, the shaft is also touching the descent part of the facial nerve.
No, not touching
it
at
is
all.
not. In this case, it is not. But if it does, it does not matter.
Yeah.
It does not do anything to the facial nerve, nor does it compromise the hearing.
See, under magnification, it is not far off.
Yes, far off. That's because the titanium shaft is very slender.
There is no play between the piston and the incus. See this?
Yes, it is one.
It holds so tightly.
दो जिस्म मगर एक जान है हम.
See this? See this? Free, nice, perpendicular, and the more than that, no crimping required. That's why I like this. See, it's so easy to use this piston. Don't you believe?
Agreed, Satish.
And see this a micro drop of blood. Now, that's it. Okay?
Yes, sir.
In this situation, nobody would use a vein graft. You will have to do a direct piston. If your fenestra is little bigger, like Ashish said, you can use some soft tissue. But anyway, that gives you a sense of security. But anyway, if your piston is not long, nothing is required.
Yes, sir. Yes, excellent.
So this was a classical example of the revision wherein laser is the key.
Yes.
Ashish?
Yes, absolutely.
Laser is the key. Number 2, you have to drill away the entire focus.
Yes.
Rather than keep on, उठा के ढंग से लगा देना flap. Rather than keep on, firing the laser on the focus.
Yes.
You have to completely remove it, flush the foot plate, make the fenestra.
I used to say that the incus tells you a story. If the incus is necrosed, you jolly well know that the lower end is not moving or not moving as well. So I say the story told by the incus.
So this is a classical example of a revision, what we find at the lower end. We will keep in the future more revisions, how if the long process of the incus is eroded, how it can be dealt with. Either you lengthen it with a bone cement or you do a malleostepidiopexy. Here,
no, but generally, you get that part where he actually placed his piston. You do get some element of some part of the long process to fix your.
Yes, to lengthen it. And in malleostepidiopexy, again our piston of choice is a ball and socket titanium piston. Ball and socket titanium system is a beauty in the sense you can adjust the length of the piston through the ball and socket joint in the piston itself. And secondly, it gives you perpendicularity with the joint, because once you fix on the neck of the malleus, it becomes tilted. So through ball and socket you can make it perpendicular. That is something, I don't know how somebody created that piston, how the thought process came. But it's something amazing. What exactly you want from a piston in a malleostepidiopexy is there. There is a ball and socket joint in the piston itself.
Yes.
So you can adjust the length, you can adjust the angle, and so many things with that piston. Simply amazing.
I mean, the piston adjusts itself. You don't have to do it.
Yes. So now, a couple of minutes, I'm going to the glomus. The case has already been started with the flap raising and all. I'll straight away
Satish,
go to
just one question. When do you pee, man? you're there from lecture to OT.
Capacity.
Hey, हम लोग साला screen off करके जाते हैं. Where do you go? Sorry.
Our next webinars we'll keep in the morning. We had a lot of requests from people on the question box that the IPL has started. 7:30, so keep the webinar in the morning. So our next webinar will be in morning.
10 onward.
10 o'clock. And like I mentioned in the beginning,
27th we are doing morning only, 10 onwards.
Yes, 27th is the webinar from Ashish Bhumkar's place, again from external to inner ear, with cochlear implants, tape piece and pinna, all dedicated cases, no overlapping.
Sequential.
Beginning to end, sequential.
So every,
yes. So that will be 10 o'clock from Ashish's place.
We were thinking yesterday we got a revision case. We were thinking of putting the revision case Satish Sunday, but I think I'm changing my plan. Let me stick to the primary.
Revision is a surprise.
Because that case is the one which I think Udbhav asked, or somebody asked, where there is a retraction, the attic has been overexposed, the piston has migrated.
See, revision, the basic thing is a laser which is required. Had I not been, you imagine, had I not vaporized and gone to the lower end of the piston, what would I do? Had I pulled the piston, everything would have been ruined. Everything. So, flush to the oval window margins. When I removed, I found a thick foot plate. Then you have to drill it with no pressure on the foot plate. It is like drilling on the cover slip. And you have to completely remove the foci. Now everything is clear, and put the piston, it should work well. It is now like a regular situation.
Yeah.
But it was interesting. So let's move on.
I still think it is a tympanosclerosis.
Yeah, even that can
The way the focus behaved, the way it cracked, I think it is tympanosclerosis, not otosclerosis.
Yeah.
The moment I saw you, I knew it is tympanosclerosis. Oh, you mean it is even chalky, you can feel it between your fingers? It looks yellowish, the tympanosclerosis.
Whitish. So as Bhumkar sir said that with Vijendra sir came the tympanosclerosis.
Yeah.
Yeah.
Yes. No, thank you. It is
Thank
our
you,
pleasure
sir.
that you
Thank
could
you.
come
Yes,
and
sir. Yes, sir. Thank you for joining.
अभी ट्रांसपोजिशन करूंगा ना.
So Vijay, next Sunday the whole microtia from skin to skin.
Okay.
And that microtia will be from 2 o'clock. 10 to 2 will be the cochlear implant and staples.
Okay.
हेलो.
Thanks Vishnu. Thank you man. Thank you for
ये वो लेके आओ ना.
Yeah.
अरे वो लेके आना. ये चेंज करना है.
Yeah.
तू करना है क्या?
Unfortunately, Manoj has to go. We'll call him some other time. Yeah.
So Ashish. Hello. Hello.
Yes, sir. Yes, sir.
Yeah, I'm ready in 2-3 minutes.
Okay.
All set. My colleague has already started the case. He has done a cul-de-sac closure and partly subtotal petrosectomy. Quick drilling.
Okay. Satish, Vishnu is going. Vishnu has to leave.
Oh, thank you, boss.
Thanks, man. Thanks. Yeah.
So in the next case, I will go straight away to the
Tell us when you do the other year of the vice president's wife.
Ashish.
Sorry. With me, nothing is confidential. Thank you, Vishnu. Thank you so much.
So
yeah, Satish, bolo.
Next case, I'll go straight away in the neck.
Yeah, you have to first catch that.
Cul-de-sac closure is already done and part of subtotal petrosectomy is done.
Okay.
So I'll go to the neck, take the vessels in control, define the cranial nerves, the vessel, jugular, external, internal carotid, the branches, occipital and all. Then come for the facial nerve transposition.
Okay.
I will try first with a limited one,
You
but I
said
don't think it's
partial,
a glomus.
second
I think we
genu
have to do
onwards,
a
yeah.
proper one.
Okay.
Glomus with a huge, jugular foramen involvement. We should do a proper transposition in a neofacial nerve canal, and then close the sigmoid sinus from above, extraluminal. Take the jugular and remove the tumor. I hope I should be able to do in 1 to 1.5 hours. 1 hour 15 minutes or so.
Okay. You are the boss.
I think schwannoma will be too difficult, but then it will be too late for schwannoma.
Schwannoma, too late?
Because IPL is there. Na?
Pachauri was is asking whether to keep schwannoma or not.
वॉच कर मेरे को दे। हेलो
कैन यू यस?
जैन साहब की आवाज नहीं आ रही। हेलो
हेलो आशीष बॉस।
हेलो
हेलो परमिता। हेलो
बोल दिया इनको कर रहे हैं कुछ। उन लोगों की आवाज डॉक्टर के पास नहीं आ रही वहाँ पे कैमरा में टीवी में।
सही है सर।
हेलो हेलो बॉस। डॉक्टर आशीष।
पता करना और रिजल्ट भी एक
रिजल्ट करवाए शायद पता करना पता हो।
हेलो करण बाबू।
We can hear you.
We can hear you also.
Hello, Satish? Yeah.
Ashish boss.
Yeah.
Our sound is there. Can you hear us?
Yeah, I can hear you very well now.
Okay, now see what I was doing.
Yeah. And now Satish's voice is gone. No sound again. Rajeev?
There seems to be some connection problem over there, no?
Here, my mic.
We can hear now, yeah.
Yeah.
We can hear the monitor beep.
Yes.
Now, can you hear my voice?
Yes.
Yeah, absolutely clear.
Okay, are you getting the picture, Ashish?
Yes, very nice.
See what has been done now. See, this is the subtotal petrojectomy.
Yeah.
This is the cul-de-sac closure done, 2 layers.
Yeah.
This is all subtotal petrojectomy done.
Yeah.
This is the facial canal here. That's the middle parts and tumor which was coagulated. And this is the entire this thing.
Yeah.
So this is the sigmoid sinus. And this is all about. Then I went into the neck.
Yeah.
What I want to show everyone who are doing neck dissections again and again, I've shown several times. See, this is the sternomastoid. I've divided over here. Look at the point where the sternomastoid starts showing the tendon. Can you see this beginning of the tendon?
Yeah.
Just medial to that, can you see some vessels?
Yes.
See this vessel?
Yeah.
I call this as a Chalker's vessel. See what is there underneath that vessel.
Yeah.
Can you see the 11th nerve, spinal axis?
Yeah.
So I call this Chalker's vessel because the Devendra Chalker initially described in 2002.
Achha.
Our friend Devendra, who was on one of the webinar. See, this is the 11th cranial nerve. How one can easily identify with this landmark? The moment the tendon starts of the sternomastoid, just anteromedial to that, you will find the vessel, which is a branch from the occipital artery along with the vein. And just deep to that is the 11th cranial nerve. So simple. See what a landmark. Can you see the accessory here?
Yes, very nicely.
So now, behind the accessory is level 2B. In this, in paraganglioma surgery, we always make sure to take a sample from clearing the level 2-3. The reason is, these paragangliomas, glomus, they are termed malignant only if there are lymph node metastasis, not by the histology.
Okay.
There are no histological criteria of defining malignancy. If the lymph nodes are positive, they are considered malignant. See this level 2B dissection.
Yes.
So just for the sake of sampling, I have taken this. First. To be out. Goal is not to be, goal here in the neck, why we have come, is to define the neurovascular structure, to control the neurovascular structure. And now you can see the jugular vein very clear. Where is the IJV? This is IJV.
Huge.
And what I can show, because we have to clear the level 2A as well. This is digastric muscle, can you see above? And lateral to that is the parotid tissue. See, this is digastric. Anything lateral to the digastric, you can dissect without any issues. All critical structures are medial to the digastric. See this? Yes. So this is the digastric, very clear now. Retractor. And see the vein. Now the important structures are here, and this vein is dilated here because of the tumor inside. I have shown this vein has tumor inside extending right into the neck. Okay. This is the vein containing the tumor. See the 11th? My aim is not the neck dissection only, my aim is here. To define the neurovascular structures. See the tumor until here. Can you see?
Yes, very nicely.
Below is the normal vein. Here, and I can feel the tumor. I can feel it. And this is soft vein below. Very clear? That's like, see how dilated the vein is at this level. So this part I am just going quickly, you know. Okay, no. उठा Now I will look for the carotid and then rest of the nerves. This is the branch, looks like common facial. Can you see the common facial vein? Artery. I have to take this. See below carotid here?
Yes, nice.
Chal. Quick. Hey. Scissors लो ना यार. Scissors. quick इसको पकड़ना. पकड़ना.
Yes, this is to separate the IJV. Cut. Quick, like it. So now I will be right on the target my carotid. I will define the external and internal carotid and 10th and 12th cranial nerves here in the lower part of the neck. That's the common carotid. Can you see the common carotid? Not to the. See the common carotid here. Scissor there. Scissor. Give me fine artery. That is my common carotid. This is what I wanted to see. Bipolar किधर है? The pedal. Bipolar. नीचे Bipolar, please. Bipolar. Okay. Open. This was the way now. For now, like it. Quick. Hello. I'm just going fast here without Niger. The pedal of the bipolar. And now you can see the bifurcation of the carotid. This is bifurcation. This looks like external carotid here with a branch coming out of it. See this branch? Yes. That is a branch. So this should be external carotid. Quick. Got this. This is external carotid with branches. This is internal carotid here. So that is important. And one of the important nerve here, I have to open up. This is hypoglossal nerve. That is hypoglossal nerve crossing the carotids. And this is the hypoglossal which is coming out of the hypoglossal canal. That is. And now the important structure here is the vagus. That is the vagus now. Vagus is here between the carotid and the jugular posteriorly. So we have seen all the three cranial nerves. Now taking the vessel, required vessel in control. See this digastric. We know the culprit is a occipital artery. Where does the occipital artery lie? Deep to digastric. Your first. Yeah. So this is digastric, which now I am dividing. Section look. See, I am layer by layer dividing the digastric. And see the huge occipital artery below. See the huge occipital artery, this one. This is a major vessel to the tumor. This we could assess on the CT angiogram. Bipolar. छोटे that's the branch of the occipital, and this is the main occipital artery here, this one, the huge one. See, amazing, such a big vessel going to the tumor. And you can see how exactly it is coming out. पतली है ना डिसेक्टिंग आर्ट Suction. Leave it. All bunch of vessels going to the tumor, and the leader is this digastric, this occipital artery. This is occipital. Huge one. The distal end I am coagulating. Pardon. Just क्यों नहीं रहता है? So that is the big vessel to devascularize the tumor. Bipolar. इधर बुला के रखना, कुछ आए तो लेके आए.
Dr. Satish, there is request to reorient the anatomy by
Yes, sir.
many a guy.
Yes, sir.
So whenever you feel free.
Okay, okay.
Yeah.
See this. This is the mastoid. This is the mastoid tip. I have come in the neck. I have separated the sternemastoid.
Yes.
Good. Now this is accessory. This is the tumor
Yeah.
in the jugular. Okay. Oriented.
Yeah. Yeah.
Yeah. This
Very
is the carotid.
Yes.
See the fork. The external and internal carotid.
Right.
Then it is the hypoglossal.
Yeah.
See this. This is hypoglossal. And what I have, see this huge vessel, which we saw on CT angiogram,
Yes.
was the occipital, which I have.
Just like
yeah,
it.
yes. So that was an important step to
Vegas
devascularize.
also you had shown. That you please show. Vegas.
Pardon?
Vegas nerve you
Yeah,
have
Vegas,
shown na, just now.
I will show. I will show. I saw it.
Yeah.
It is deeper. पकड़ना. All this is venous bleeding. नहीं रुकेगी. Huge. Now, having seen that, okay, Vegas, retractor there.
That is just between the carotid and
Yeah, carotid and the jugular, this is in the
jugular.
depth.
Yeah.
This one.
Yeah, yeah.
The
Very
big one, this one.
Yes.
Bipolar. The whole jugular vein is, involved by the tumor.
Yeah, that I can see.
Tumor is completely filling the jugular vein from inside.
Yeah. Very much in line with what you have shown in the radiology.
Yes. Now, my next step is to mobilize the facial now, because see, this is the jugular vein. This is going here to the jugular foramen. Jugular foramen is right here.
Yes.
That is deep to the tympanic bone, and the facial nerve is crossing like this here.
Yes.
And there is a huge tumor we have seen in the jugular foramen. Unless and until I don't transport the facial now, this area is not going to be opened up easily. Got my point?
Yes, yes.
So now my role is to quickly transport the facial now.
Yes.
So first let us see the facial now. Give me the diamond, badi wali. I hope you are oriented now.
Yeah, yeah, it's very much oriented. Actually, somebody from Nepal wanted to get oriented again.
Oh,
so I
yes,
requested you.
yes.
I am following you. One who is following continuously cannot get disoriented.
Yeah.
One left in between will have to.
So my neck part is over, sir.
Yeah.
Only this upper neck, once I drill this tympanic bone, my upper neck will be exposed. See this tympanic bone, entire tympanic bone has to go.
Yeah.
So here, funny. Drill. Now see, this is your I will follow the facial canal from the mastoid.
Yes.
See, this is the facial.
Yeah.
The transposition of the facial is a most important step in this surgery.
Yes.
See the vertical facial?
Yeah. This you demonstrated in your earlier case also, if I remember correctly.
Yes.
Transposition, yeah, in the another jugular one.
Yeah, several times.
Yeah.
Udhav, any questions? Dr. Udhav?
So I will catch here, cutting there. Catch here this nerve as it leaves the stylomastoid foramen.
Dr. Udhav, any questions?
See, this is a horizontal segment, this is vertical.
Yeah.
Thin bone is there over this.
बंद है क्या? Mirror बंद है क्या? Mic बंद है? कहाँ से चला हुआ?
हाँ.
Hello.
बस.
Yes, yes, go ahead.
Pardon? I am thinning out the tympanic bone.
Already done just now. That is I requested from the chat box only. Yeah. Yeah. Yeah, already done it. Just now he has done it. Yeah.
पतली देना. One size smaller.
Satish, Dr. Rajsekhar Reddy wants to know how often you get, Satish.
Yeah.
Dr. Rajsekhar Reddy wants to know how often you do encounter right common carotid crossing trachea.
How often means, yes, we have encountered, but how often I can't say. But you have to be,
and
cautious about it. You have to suspicious of such findings.
Yes, yes. And Professor Mazumdar from Pondicherry.
One can otherwise damage the carotid artery during tracheostomy.
Yes, yes. And Professor Mazumdar from Pondicherry wants to know the extension of neck dissection in squamous cell carcinoma of the middle ear.
In the squamous cell carcinoma
of middle ear.
Extension of neck dissection in the squamous cell carcinoma of the middle ear is this question from Dr. Majumdar.
Yes.
We do a supraomoid dissection. If there are any positive nodes, then we follow with the formal neck dissection, comprehensive bipolar. See what I am doing? I am following this vertical course, and here is going to be our, this is the level of the stylomastoid foramen.
Yeah, yeah.
Diamond is there. Where the carotid, the facial nerve is coming out. So, then I will trace the facial. The facial will ascend here absolute laterally. The moment it comes out of the foramen, it will ascend laterally. This is the stylomastoid foramen.
Yes, yes.
Can you see this now coming out?
Yes.
Yes, रुक जाओ. You must touch it. इसमें पटक दो. Before removing that, I will remove the mastoid tip as well.
Already mobilized.
Yeah, before I transpose the facial now, see, this is a part of the tumor which is. Give me chisel hammer. Suction रखना. Cautery, suction रख इसका. See, the facial is going out from there.
Yes.
This is the mastoid tip behind, and we have to remove it. What I can do, I can free it from the outer side. Knowing facial nerve is away, see this?
Yes, yes.
One can easily remove the mastoid tip. Now this is outside in the neck.
Yeah, yeah.
Yes. देखा. Just now the facial nerve is so simple to trace into the parotid. Pachande. See, here is the tumor. Deep to facial, here is the tumor.
Yeah, going deep.
So now, can you see the facial nerve ascending in the parotid?
Yes, very nicely.
See now, lot of vessels. Artery दुखी दे यार. Not a good artery. Give me diamond. हटाओ. See, this is pure jugular bulb region. It is not going to control. डाल दे, सर्जिकल डाल दे. पतली फाइन आर्टरी चाहिए मुझे. छोटा गॉड प्लीज. यस. चलो. See, such oozing in this case, you don't bother. Yeah, you रख. Yo. Okay. ला दो. Fine artery. See the facial now?
Yeah.
Yes. Beautiful.
Yeah. Give me scissors. See, this is how one can easily follow. There are many ways. This is one of the fastest way. See my facial nerve coming out of the temporal bone. Scissors. See some vessels on the surface. Scissors. Now, I will follow it in the parotid to the level beyond the bifurcation. Now going in the parotid. See how it is ascending into the parotid.
Yes, yes.
See, rising laterally, absolute laterally. Is that clear?
Yes, yes.
Very nicely, sir.
Scissors. वो दे दो ये. Monopolar दे दो. उठा. हाँ. See the. Now reaching towards the bifurcation.
Yes, you can see it. Yeah.
What I will do, I will raise a little bit of flap, and now our goal is to bring this facial now right from here to here.
Yes, yes.
Transposition. So for
Yes,
that, I need to raise a little bit of the flap. So next 5 minutes, we should be through by transposition. Guru. Punctured. ये खोलेगा बार बार. Now, see this, I want this parotid tissue lateral to the facial now. See this? To go. This one. The entire tissue. See the level of the bifurcation? And I am going beyond the bifurcation now. ये है एक वैसा यार. सक्षम रखो ना यार. Wait, रुक जा.
Cancel.
Close. Now quickly I have to mobilize it.
Cancel कर देना.
करना है अभी मस्त से. चलो करो यार, क्या है ये. और डालना. वाइजेटेड. Leave it, leave it. Now, going to the other end of the bifurcation to mobilize it. चलो कट पकड़ने. Hello.
Yeah, Satish, we are here with you.
Ashish, see the bifurcation and beyond.
Yes, nicely seen.
So I am uncovering it
So
to
you are
mobilize more
correct,
and more.
correct. So no tension when you reposition it here.
Yeah. Mobilizing it more and more. Artery. क्या करते हो? छोड़ दे. See that I am freeing this nerve from the bed. Here it is.
Yeah.
See the entire now. Look, you must have karo. Bleeding mat karo. Hold it. Okay. Somewhere here. This I will use as a parotid tissue to cover the facial nerve after transposition. It's a very, very important tissue. Yes.
ये एक काम करना है.
This parotid tissue, leave it. This will be used to cover the facial nerve here at the nucleus.
बड़े वाले की. बोले मैं 5-6 पहुंच जाऊं तो ऐसे 11 बजे.
Now, coming on to elevate the facial nerve in the mastoid, patli diamond dena pehla. I did not mobilize the facial nerve in the.
Uddhav, you are audible to us but not to Satish. Satish, Uddhav is trying to talk to you.
Who? Yeah.
Uddhav is wanting to ask a question.
Yeah. So what I was saying, Ashish,
Yeah.
I did not mobilize the facial nerve in the temporal bone first.
Yeah.
Because it may break if I mobilize it first.
Yes.
So I mobilize the extracranial part and then finally the mastoid part. That will be safer. And this now, see this now. This I will elevate till here and then it will come like this.
Yes.
इसको काटना.
Not really, not really.
Udhav, you want?
Yeah, was some question?
Udhav?
Role of facial nerve monitoring in this surgery.
Yeah, we have a monitor on. So practically Not much.
Directly on the nerve here. So.
Monitoring has a role if you have a doubt about the integrity or whatever. In the end of the surgery, if your monitor says good, that is important. Let me show you where the facial nerve monitor is. I will show you. See, that is the tympanic segment. That's the tympanic segment of the nerve. And I'll make a separate canal here anteriorly. This will be a separate canal for the nerve to come out into the parotid. And I will fix this nerve in this canal with the glue.
Glue, and then the parotid tissue will hold it in the extra.
Yeah.
See, he rounded off the edge, so inadvertently the edge should not touch.
Yes,
you see at the lateral most end of the canal.
Now, with high magnification, I will little bit, open up the open up the horizontal segment.
We counsel, it's a consent. In India, we're not like that much. We say that there may be a facial weakness which over weeks will...
There will be temporary, up to grade 2, 3. Most of our patients come to grade 2 after a few months. See, there's the distal, close to the first genu. Can you see the horizontal segment?
Yes, very nicely.
Once I turn it around, there should not be any sharp bony spicule which can damage the nerve. Everything should be smooth here. Okay? Bipolar. Now give me fine section and side knife. Quick. 18 number दे दो. So now I am ready for the transposition. See this. First is elevate the thin bone which is left above the facial nerve. Very thin bone is left.
Yeah.
I use the diamond drill without any pressure to leave a thin bone over it. See the thin bone. Everywhere is a thin bone. And now we will elevate the Okay. Iris. And non-tooth, fine non-tooth. The reason for this weakness is the vascularity which we take away. This is supplied by the plexus around the nerve formed by two vessels, one coming from below, that is the stylomastoid artery, and one coming from above, from the first genu is the descending petrosal artery.
What is this fiber?
Fiber? What?
These are the fibers?
Periosteum, periosteum. This is periosteum. The best instrument here is a beaver knife. आज autoclave तो नहीं कराया उससे यार. The knife though, on the number. See the nerve, integrity of the nerve with the periosteum. Sugar. सर्कुलर नाइफ. सर्कुलर यार क्या देता है? This is the horizontal canal. Knife, knife. This thick periosteal attachment.
Yes, please.
Can you see the thick periosteum attachments?
There is, that's what he said, and the weakness comes from that.
Yeah, see, because it is devascularized, but it acquires vascularity in the new bed over the period of time.
Here, Vijayendra was asking, do we need to cut the greater superficial petrosal now?
No, no.
I think.
Why do? Why? That is required in posterior transposition. See, that is the first JNU we have reached. And we have a nerve which is going to go like this now.
Yeah.
See in the parotid without any tension?
Yes.
And that will be away from our area of interest. What's the forceps there? Yes. See how tension free it is.
Yes, yes, yes.
Shuna?
Perfect. Perfect.
Now put a suture not on the nerve, this to this. Look. This tissue to this tissue, outer. मैं दबा रहा हूँ. हाँ. See the nerve is
yes
embedded inside.
Beautiful.
एक मिनट रुकना. No, what I will do, more. This is full vein. Human of the vein, man. Yes. Yes, yes, easy, easy. Yes. See this?
Yeah.
Now it is completely embedded in the parotid.
Yes. Very safe.
Yeah, लगा दो उधर. अरे इसको नहीं, इसको उधर लगा.
Yes, very much intact.
So
You have to
now-
lift it along with the sheath.
So it
From the
will
body.
nowhere come in between our way. Glue देना मेरे को. ये पकड़ना, इसको पकड़ना. Now I will further mobilize this. अरे रुकना यार. पकड़ो. Yes. See this parotid tissue. I am mobilizing, and now my area of interest will be completely uncovered. That is jugular foramen. काटने दे इसको, फेंकने दे. काट के फेंकने दे. पकड़ लो, पकड़ लो, पकड़ लो, पकड़ लो, गुरु पकड़ लो. So many vessels in the parotid. Remove all this. See, all this I am removing to open up my area. It's of no use now.
Camera lens needs to be cleaned, something else.
Yeah, camera lens clean करना. See, to orient you, this is our jugular coming from the neck. Clean कर.
हो गया.
See, this is the jugular coming from the neck. This one. And this is
Yes.
the jugular foramen. So now, look, section and give me the glue first.
Yeah.
I will fix this facial now so it doesn't bother us again and again. The best part is it should be tension free, lying there. Now that area we don't have to go again and again. नहीं निकल रहा.
Glue.
Now this bone we have to remove, tympanic, and we'll be right on the tumor. To get onto this bone, to reach there, we have to remove this facial now. See the fallopian canal.
I think the tympanic bone is the only bone which does not get pneumatized, no? The temporal bone.
Yeah. See the facial now. Should not bother us.
You must be buying this glue in kilos, liters, eh?
Liters. Every day using. All these muscles I can, until lateral to the jugular, I can remove all this.
Yeah. It destroys. Correct. Yes. Yeah.
See the neck and
Very
the
good
temporal
point, yeah.
bone become one.
Oh. Yeah. Visible.
Now, for the sake of, orientation, see, to reorient you, this is the mastoid.
That is the
glue. This is the middle ear. Eustachian tube, this is the fallopian canal, this tympanic bone. And now, after this tympanic bone, this is neck. This is the upper part of the jugular. This is the 11th now, this is jugular. So the neck and the temporal bone have become one entity. So this one. Where is the tumor? There. There. Now I will remove this tympanic bone completely. We'll remove this tympanic bone completely, section motor rakhna. And get onto the jugular bulb. Section. See, this is tympanic bone.
Yeah.
What is this bone at the lower end of the tympanic bone? What is this? This styloid process, see, going in the neck. This styloid process.
Yeah.
And this is going, see how long it is broken. Styloid process is an important anatomy because the jugular and carotid are supposed to be deep to it, medial to it. See part of the styloid. Nibbler. Section. Nibbler. This is tympanic bone, and from here the styloid arises. And deep to tympanic bone, this is our jugular. Remnant of this. Yes, cut this. Beauty. Yeah, broken. I've taken away part of it. See, this is jugular. This is jugular. Now the bone remaining over the jugular.
Hello?
Bipolar.
It doesn't matter, but I can come.
एक section और ले ले. एक section और ले ले. This is pure jugular. Now give me the drill. एक section और रखूँगा. यहाँ रखूँगा. See now what I am trying to do to drill away, cutting this. Drill away this remaining tympanic bone to make the jugular foramen in continuity with the neck. दो section रखो. एक इधर रख, एक उधर रख, एक उधर रख. I hope you are oriented.
Vijay is asking, are your assistants also seeing through the lens, or are they looking off the monitor when they are assisting you?
No, naked eye.
Naked eyes. They are not even seeing the monitor.
No, nobody is seeing.
See this, all tympanic bone has to go. And very soon, the jugular bulb below is going to be uncovered. The fallopian canal I have drilled, see this?
Yes.
Now give me diamond. See the tumor here below.
Yes, yes.
All these are tumor bleeders. मोटा देता ना. Look, look. I have taken diamond to improve the field. Dry diamond. This tumor, comes laterally into the tympanic bone very often. Bipolar.
It can erode the tympanic bone?
Yes, very common. See, all these are tumor vessels. यहीं रखो तो dry. Only dry. I'm using diamond because it is so vascular. So I have to uncover the entire jugular bulb. Here is jugular bulb. This is jugular bulb now.
No mobile, yeah.
Drill. See, this part of the thick bone has to go. Anterior to the jugular bulb is the carotid artery, petrous carotid. See, here is the eustachian tube.
Yes.
The petrous carotid is in the medial wall of the eustachian tube.
Trying to create a plane or trying to see?
Yeah, this is jugular bulb. I have to remove this bone. I am trying to control this. It's all tumor. All this bleeding is a tumor. See this tumor deep to this bone? And now, give me, drill. What is the cutting? Is a medium size. So now, यहाँ भी लगा दे. What will वो दे दे. सर्जिकल लगा दे. So in next 5 minutes, once it is exposed, I am going to obliterate the sigmoid sinus, ligate the vein, and then we'll go to the tumor. So there. cutting my 40. See, you have to go quick with little bit of the bleeding, otherwise you can't work. It will take longer and longer. You can save a lot of time by this. Since it is a thick bone, now diamond. Now this is pure jugular bulb below this. I'll expose it wide. Sometimes you have to work with little bit of the bleeding on. Now I am going anterior to the jugular bulb towards the petrous carotid. That is the carotid canal. See, cochlea is here. Here is the cochlea, that is eustachian tube, and this is the petrous carotid canal. This is my pure jugular bulb. Jal from there. Oh, Sanji, sir. Got this? See, I can control the bleeding any moment. See this? See this? Oh, you retractor laga.
You are now going to almost skeletonize the petrous carotid.
Not completely yet.
Partially, at least define it.
Yeah, defined it. Yeah. You रखना इसको. अरे जो ना गुरु फेशियल है ठीक है. हाँ. See, now I am anterior to the carotid here. This is infratemporal fossa. That is the carotid artery. See this. Bone nibbler.
That's the bone right over the carotid.
Yes. Now, give me the drill. This bone you have to deal with what? Here I can't afford to use the cutting now.
No.
Oh, मैं कह रहा था ना.
Most frustrating.
Oh. चलो चलो चलो. No, give me the bipolar. See, so far, the entire what I have done so far is exposure, exposure, exposure. Nothing else. लो दे, थोड़ा बता देना वो सर्जिकल दे. बड़ा महंगा था ना मैंने. अरे यार. गॉड दे बड़ा. यार छोटे दो. This will not control now. बजे बगा तो रोक ले. ठीक है. Yes. Now coming to this side. Cutting the cutting. Hello.
Yeah, Daddy.
See, this is the jugular foramen. This is in continuity with this neck. Now I have to remove this posterior wall. Badi there. This entire posterior wall of the jugular foramen.
Yes.
To see inside the jugular foramen. Diamond though, yaar. So many oozes from the bone. Diamond. See all this foramen. For the jugular. Yeah, this is jugular. चलो दो, सर्जिकल दो. इससे से कुछ नहीं होगा. Give me a. Yes, give me. Cotton ball. See, every time you have to control like this. This is the posterior wall of the jugular foramen. Bipolar. This is a part of the occipital artery. Hello?
Yes.
That's for the same occipital artery coming to the tumor. छोड़ हटा दे. See, such a huge one. For sure? Yes. तो इसे पकड़ो. All branch of occipital artery. Now coming to the carotid from the neck, and then we'll mobilize artery. करो करो ये ट्रैक्टर लगाओ, ध्यान रखो इसको यूँ कर लो, नॉन टू था ना. Now see, this is the jugular with the tumor. This is the accessory, this is the jugular with the tumor. And where I am going now to separate the carotid from the tumor. See this is internal carotid. Can you see? This was the branch which was the main culprit. I will ligate it again here. That was the main supply. Like that. Fast. Next 10 minutes will be on tumor removal. Show me this vessel. और ये था ना. That is hypoglossal, and this carotid is going deep to the hypoglossal here. क्या कर रहा है? Again vessels, bipolar. Still so much of retrograde flow in this. कहाँ से आ रहा है इसमें? चल कट. मॉप यार दूध अच्छे घास रखो. See this tumor in the jugular, and the hypoglossal is adherent to it.
Just fix with it, almost fix.
See, this is all tumor in the jugular. Carotid is deeper, and the hypoglossal is adherent. Posterior auricular artery. Could be,
Which one? What is it?
This could be posterior auricular artery.
Okay.
पकड़ लेना. The third, this is the posterior most branch, na? Superior branch.
Tight.
Now see the distinction. You रखना एक second रखना. That is the internal carotid. You पकड़ रहे हो. इसको पकड़ना. Now see, This is hypoglossal. This is the loop of the internal carotid below. That is the loop of the carotid. Scissors. ये लगा यहाँ यहाँ यस यार एक और रिट्रैक्टर दे इनको I am following carotid into the Peter's bone from here. यहाँ नहीं छोड़ना इसको यस इसको एक और ला नरेश इसको पकड़ जो पकड़ पकड़ना यार यस yes section रखो now see this is hypoglossal, this is carotid going there and this is the thick periosteum at this level. I am opening up this periosteum to follow in the temporal bone. कोई मतलब नहीं है इसका भी कहीं पकड़ लेता है ना ये रख now see the carotid becomes absolute medial before it touches into the temporal bone. It becomes so medial. This is a thick periosteum. I can suction kar. I can see my carotid below. And see the jugular being separated.
Yes.
That's the carotid. There you go. Yes. So separating the carotid away from the jugular. Not more. See, the tumor is here and the carotid is here. This looks like glossopharyngeal now. Here. Nope. Section देना. छोटे. लगा ना यार कुछ See the internal carotid loop.
Yes.
And that is the, about that is the glossopharyngeal nerve. This is glossopharyngeal.
Yes.
That's a jugular with tumor. Very good. See the tumor being separated.
Yes. Beautiful.
My important structure are here. This is the 12th and this is the carotid. Vagus is deeper. This is all tumor. This tumor being separated off here. Yes, that's the entire tumor. Carotid is far anteriorly. Jugular is here. Little bit of the see the thick periosteum. Hello? Yes. Now remove everything. Yes, put the see the tumor in the jugular, full of tumor.
Yes.
Now I will first see my area. Neck is very clear. The carotid is far anteriorly left. Hypoglossal is left. The tumor is separated. 11th is here. And the jugular foramen is fully exposed. Now I will do extraluminal obliteration of the sigmoid sinus. Diamond. This is our sigmoid sinus. And we'll do a good This will be the extraluminal obliteration by means of making a window and pressing it. Cutting.
मेडिकल से बड़ा वाला सर्टिफिकेट मंगाया
The sigmoid sinus wall very thick, and what I am using here is the cutting bar.
डॉक्टर उद्धव की वॉइस नहीं आ रही इसमें. डॉक्टर उद्धव है ना, उनकी आवाज नहीं आ रही. नहीं,
डायमंड
1 घंटे से नहीं आ रही.
Now I will change to diamond.
Huh?
Periosteum. So this is.
Hello? Yes?
Hello? Hello? So, what I am doing is the extraluminal compression of the sigmoid sinus.
Okay.
Hello.
Udhav, can you hear us?
Yes.
This is fibrillar.
Udhav?
Yeah. Yes.
This is fibrillar.
Fibri? What's this?
Fibrillar. This is cousin of Surgicel.
Okay. Which company?
Same Johnson.
Same Johnson company? Okay.
Yeah, this gives more volume.
Okay, yeah. Yes. Quantity wise, it's...
Yes. Same material like Surgicel, but in a different form.
Okay.
Lolo. See, I will tightly compress it against the bony wall.
Satish, repeat this material name and all.
Fibrillar. Fibrillar.
Okay. LAR.
See, I am tucking it under the bony margins. So it keeps the sigmoid compressed.
Yeah. Extraluminal compression of the sigmoid sinus.
Yes. You can ligate also.
Yeah.
They much safer. So look. Got this. What? See the tight compression?
Yes.
ना मेरे को दो, इसको काट दे। And now I will fix it with the bone wax. So it will not mobilize now.
Yeah.
Next part will go in the neck and catch the jugular at the level of normal vein.
Yeah.
See this lumen, nothing?
Yes, yes. Go on, go on.
Good. इसको बांध दे. See this? Hello.
Yeah.
This is the accessory. उठा उठा ऊपर रख.
Yeah.
ये रखना. See, all these nerves are outside the wall of the medial wall of the jugular bulb.
Yes.
So as long as you stay into that, you will not damage anything. See, this accessory has a close relationship with it. See, this way we have elevated till here. दो रख ले सकता हूँ. Now the source of bleeding is the inferior petrosal sinuses. Tumor full of this. Almost is spoiling the field. इधर भी देखा. Tumor में सारी. इधर इधर See the tumor?
Yes, yes.
इधर पोजीशन रखो, इधर ले बाद में आऊंगा मैं. Yeah, hold this on this side. Section. Okay, ये पकड़ना है ना. Okay. Got please. यहाँ रख दो. Now. So this. Give me a periosteum. Tell for the. It's some vessel. Very part of the hospital, man. Now I am at the tumor removal stage into the jugular foramen. Give me cutting bar, fast. निकलने दे थोड़ा खून. What is? See, more and more jugular foramen I am opening. This is all tumor. The periosteum. हटा दे. Give me periosteum. देखो, बहुत लगा. ये लो. ये छोड़ो. Very vascular. बड़ा देखो. नहीं वो अबे सर्जिकल बढ़ा दे यार. ह्यूमन वेरी स्लो. छोड़ना. Yes. I have to take care of the flow. Yes. Wait. कुछ नहीं होगा. You remove this bone. Bone nibbler. छोड़ना. देखना देख कहाँ प्रेशर बोल. अब ब्लड ट्रांसफर करेगा. बोन हटा दे. Yes. Now. Some more. Sir, इसको उधर कर. Yes. This bone.
Okay, because of blood loss की वजह से या
periosteum.
55 कैसा है?
Let me see where this is coming from. जाने जाने yes 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 put go अब breathe up. I can see the medial wall now. No, ज़्यादा जोर lose इधर भी लगा इसके नीचे very vascular. I didn't expect. So vascular. चलो wait for a minute. पकड़ it is coming out. See the entire tumor. So the tumor is coming out. See just cut this out. Yes, that's it. Yeah, out. जब मैं एक बार पेट्रोजल साइनस चेक करूँगा. See, this is jugular foramen. This is interior of the jugular foramen here. This is the cochlea here. Inferior wall of the cochlea. Jugular foramen. There are some inferior petrosal sinus openings which will now, tumor has been removed. After 2 minutes, let's pack for 2 minutes and then we'll see the openings and finally pack that. बढ़ गया क्या?
क्या जल्दी करे? हो गया क्या? बढ़ गया. आ गया.
So now it's perfectly under control. Yeah. चलो 2 सेक्शन तक ये लगा. ये इसको तो रहता है. ये तो सिग्मोइड की तरफ. हटा इसको, हटा दे सबको. हटा दे सबको. हटा दे. No need. That's the medial wall. That is towards the filter support. See, these are the petrosal sinus openings. Yes. See anteriorly, these are the petrosal sinus openings. See this opening? The big one. There are 2 kinds of openings which we anticipate. One is the petrosal sinus, and another is the condylar canal opening. कुछ भी नहीं दे दे. Finished. Light, gentle. Yeah. Another is here, so the posterior condylar canal. See, छोड़ा. See, this is my medial wall of the jugular bulb. This is something, this is the medial wall, smooth medial wall. This we should not cross. The entire tumor is out. You can see the smooth medial wall. Very clear. What we can see is the inferior petrosal sinus opening, and here is the condylar canal opening. There you go. Go. Bas, go. Yeah. Yes, that's it. God please. That's it. We'll just keep this gauze for 2 minutes and we'll stop. Now see in the neck, all these are the cranial nerves intact, the carotid artery, and here in continuity the tumor is out. It was quite vascular. See the field after this. Larger view. That is the tegmen, temporal bone, or facial nerve is here. See in the place. Here. Then this is jugular foramen. This is cochlea.
How much deeper is the petrous apex, Satish?
Pardon?
From there, how much deeper is the petrous apex? Just a few millimeters?
Immediately deep to the cochlea.
Yeah.
Immediately here.
Just a few millimeters, no?
Yeah. See now, it was a huge tumor, big one. Hata. एक छोटा दे दे बस छोटा सा God दे दे God. So finally the tumor out, big one. See the field, the structure is the carotid fork.
Yeah.
Hypoglossal above we saw that is the glossopharyngeal above. Then the 10th and the 11th cranial nerve. So all cranial nerves preserved. Hemostasis achieved. The petrosal packing is there with the Surgicel. We can't pack tightly. See, as long as the medial wall is intact, you don't have to bother about the nerves which go deeper to that. See this? See how deep the jugular foramen is. I hope you are oriented.
Fabulous, yeah.
See the neck and this. That's why in larger, openings for the intracranial lesion if you make, it is difficult to control the CSF leak because there is nothing to hold at the level of the skull base. Nothing to hold and separate from the neck. Because the tympanic bone has been removed, all that fibro-osseous attachment has been removed and the neck and the temporal bone has become one compartment. So you should not communicate with the intracranial space with a larger opening. Smaller opening you can plug with a fat or muscle or anything. You can suture the fat, muscle. But larger opening cannot sustain the pressure and it may give way. Okay, we'll just obliterate with the fat. So गीले से कवर कर दे, बेटाडीन से क्लीन कर दे बेटाडीन.
क्या बोलना है? He is able to hear me.
Fantabulous. Fantastically fantabulous.
ये रहने. Hello, Ashish?
Yeah.
Yes, so any questions, any suggestions?
Great job, Satish. Fabulous.
It was quite vascular, man. Not expected.
Yes, okay.
So, Pachauri boss, according to him, we are not taking the next case, that schwannoma.
I think it is a sensible decision.
Yeah, we'll do it tomorrow.
I think Udhav, is there some problem with Udhav's voice today? Some issue with the mic. Udhav, can you hear us? Some issue from his side. Sun Pharma, I think anybody from Sun Pharma. So today I think all the cases were good, especially the
excellent, yeah.
Especially the subtotal petroscopy and implant. Wonderful case. The X-ray was ultimately very good. We can call for the
We
day
can
now.
save a lot of problem in implanted patients after subtotal petrosectomy and obliteration.
What are protocols? Means after surgery, how you call the patient for the radiological?
Nothing. Once it is packed, you call after 7 to 10 days. Then you don't need to. That area is completely segregated.
So, Asim Desai, Dr. Asim Desai is there. Amit is there.
Ashim is there?
Zoom is on. Dr. Vijayan sir is there. I think.
No, Ashim is not there.
Ashim is not there?
His name. We can see his name.
Acha. Oh, I'm seeing the party. Anyway, yeah. So we are calling it off now?
Yeah, we're calling it
Yes,
off.
yes. If no more questions, we can call it a day.
Wonderful.
And see you all next week from Thane.
Thane, yes.
Ashish, 10 o'clock. Ashish will send the information.
Thank you, Satish.
Yes.
Thank you all.
Sun Pharma. Thank you
case
all.
we are going to show the arteries here.
For being with us.
Thank you. Thank you all.
Absolutely. Thank you very much. Thank you, sir. Bye bye. Bye, everybody. Bye, Vijendra SK. Satish boss. Bye bye. Bye, Udbhav.